check. A very good morning, ladies and gentlemen. We welcome you to the day 2 of the 4th World Dental Sciences and Oral Health Conference. Our first speaker of the day is Dr. Pritender Singh. He's an eminent periodontologist and implantologist. Sir is a senior professor and international faculty at Universal School of Health, USA. Please welcome Dr. Pritender Singh.
Good morning, all of you. A great pleasure to speak at this platform, and thank you for a nice introduction. Presently, I am working as a senior faculty at Universal School of Health, Florida, US. Also, international ambassador for Academy of Oral Surgery, USA, working with Cambridge, UK. It's not that I am working all abroad. I'm also working as a key opinion leader for many companies in India, and right now I'm working on some research products coming up in Perio. So the topic for today, add-on techniques to regenerative periodontal and oral implant surgery. Blood, as you all know, has a lot of power. It's also called miracle blood or regenerating blood. So our own blood has a lot of healing properties which we can use and do regeneration in any part of our body. Now, not as such you take the blood and use. You have to make some blood and its products to use. Platelets, very important part of our human body and blood. What's so special about platelets? They have large number of growth factors, alpha granules. They release when platelets aggregate, adhere to the site of major inflammation. There are many growth factors released from the blood. Platelets, platelet-derived growth factor, TGF, insulin-like growth factor. It is the activation of platelets and release of various growth factors that makes them special and is the key to enhance tissue repair and healing. Blood clot. A natural blood clot contains 94% RBCs and only 5% platelets and 1% WBCs. So, my dear students, you must be knowing that whenever there is an extraction in oral surgery, they tell you the importance of the clot. Right? So that clot is just 5% of platelets. And when we make platelet concentrates from blood, it contains 85 to 95% of platelets. So in comparison to blood clot versus platelet concentrates from the same blood, there is a 90% variation of the concentration of platelets. What are platelet concentrates? They are not stem cells. They are not mesenchymal stem cells, neither lymphocytes nor bone marrow. So what we do is we take autologous blood from the patient, centrifuge at certain speeds, which I will be telling you, and we have various forms of PRPs, that is platelet-rich plasma. Then we can make PRF, that is platelet-rich fibrin, and in PRF we have various other forms. They can be used alone or in combination with bone grafts. So whenever these are mixed with the various bone grafts, what we get is various growth factors, PDGF, PDAF, FGF, TGF, PDEG, IGF. They all combine together and stimulate collagen production, improved neovascularization, that is angiogenesis, and enhanced bone formation and maturation, all leading to enhanced qualitative and quantitative healing and regeneration. Now, these various growth factors have various functions, as is PDF, chemotaxis, TGF for cell proliferation, BMPs for repair of epidermis, fibroblast growth factor for mitogenic function, EGF for keratinocytes, vascular endothelial growth factor for angiogenesis, insulin-like growth factor for granulation formation, and interleukins for pro-inflammatory function. So all these are present in blood, and when we make any platelet concentrate, we get them to a concentration of 80 to 90%. Now we have various forms of PRP and LRP, LPRP, and then we have the second generation, we have the PRF, that is PPRF, LPRF, IPRF, APRF, and TPRF. So in PPRF, it is a solid material, LPRF is in a gel form, IPRF, as the name says, IPRF as injectable PRF, used in facial rejuvenation also. APRF is the advanced form, and T, which is the latest, is the titanium prepared PRF, that is the third generation platelet concentrate. Now, I already told you that these all contain various growth factors. This is a again a slide showing various growth factors present in PRP and PRF. Current clinical uses of these platelet concentrates, everything and anything. Internet is a marketing for host of ailments. It is the snake oil for today, cures rheumatism, grows hair, gets rid of wrinkles, etc., etc. But right now we are here talking about perio-regeneration and in dentistry. So what are the various roles in dentistry of these platelet concentrates? In sinus lift procedures in advanced implantology, ridge augmentations, socket preservation, alveolar cleft palate repairs, oro-nasal fistulas, intraboreal defects, jaw reconstructions, soft tissue surgeries, gingival grafts, endoperial lesions, filling of cystic cavities. So you can see in this table or the slide, there's hardly any area left where we can't do any regeneration with these platelet concentrates. There are some limitations of PRP. Lack of uniformity in PRP is a bit of a limitation. Release of growth factors is for a short time, and concern is in PRP, we have to use one external agent, which is known as bovine thrombin, to release PRP. So what happens is, in some patients, bovine thrombin causes immunogenic reaction. So when I just told you that we are going to use patient's own blood in patient's own body, so why to add a third agent, that is a bovine thrombin? So to avoid adding any agent, the next generation was developed, which is PRF. Nothing at all, just patient's blood and a centrifuge is what you require. It represents a new revolutionary step, does not require any bovine thrombin or jellifying agent. Chokran et al. Developed the PRF in 2001 in France, and production protocol of PRF attempts to accumulate platelets and release cytokines in a fibrin clot. What is PRF? You can see, I'll tell you the various centrifugation speeds right now. In this test tube, you can see 3 zones, and this is the red corpuscle base, this is the fibrin clot, and this is the acellular plasma. So this is the fibrin clot. Just by taking patient's intravenous 5 ml of blood and centrifuging at a certain speed, this is what you get. This clot is being held together in a single piece with the help of a tweezer. So you can see how the blood has changed into a fibrous clot, or known as PRF. It has lot of tensile strength, loaded with growth factors, used in everywhere and anywhere in dental problems. So what happens is, standard PRF, now I was telling the speeds. How to make a standard PRF? 2700 RPM for 12 minutes in a centrifuge, and APRF, that is the advanced PRF, 1500 RPM for 14 minutes. Now, when we decrease the RPM while increase the centrifugation time, PRF gave us some presence of more neutrophilic granulocytes in the distal part of the clot. So we got more osteogenic stimulation. That is, more osteocytes are activated to form new bone. So APRF advanced version is a better one. Now, LPRF, APRF, I just told you. Then we have IPRF, that is injectable. It is centrifuge at 700 RPM for 3 minutes. And again, it is of 2 types, IPRF-M and IPRF+. So they were pursued so that we can inject also. So IPRF is the one which we can inject in the skin, in the gingiva, in the interdental papilla areas. It is an injectable form. Taking advantage of slower and shorter centrifugation velocity, it is possible to observe an increased count of regenerative cells. What we require in our body, we just require increased amount of regenerative cells. That's what we get with IPRF. The latest titanium prepared PRF. Okay, I told you LPRF, I told you IPRF, APRF, all these are formed in glass test tubes using a centrifuge. TPRF is the latest version in which we don't use the glass tubes, test tubes, we use a titanium test tube, hence the name titanium. So it is prepared in grade 4 titanium tubes. Blood samples are taken from the antecubital vein, collected in tubes, centrifuged at 2800 RPM for 12 minutes. TPRF is based on the hypothesis that titanium will be more effective than activating platelets. than in the glass test tubes, because in the glass test tubes, it was thought that maybe silica present in the glass test tube might interfere with the original LPRF method. So hence, but expensive. Titanium test tubes are expensive, but yes, the technique is available. Properties of TPRF, better hemocompatibility of titanium than glass. You all know implants are made of titanium. It's an inert metal. Yes. So, great results. More polymerized fibrin. What is more polymerized fibrin? You know what? You can actually suture a PRF membrane. If I press PRF clot like this for 10 minutes with a weight, it becomes a membrane. I can actually suture a PRF membrane. So this is the property of your own blood. Long life of TPRF in tissues. Various, what you can say, centrifugation speeds and minutes formulated in this slide. Not be repeating. Advantages of PRF over PRP. Platelet-rich fibrin, PRP. What was PRP? Blood with thrombin. PRF, no additions. No biochemical handling of blood. No thrombin. Simplified, cost-effective. No anticoagulant used. Favorable healing due to slow polymerization. More efficient cell migration. PRF has supportive effect on immune system. Why it has supportive effect on immune system? We did not use any outside agent. Your blood, centrifuge, get back in your own body in the form of a gel, that is platelet-rich fibrin. Clinical applications I already told you. Perio, we use in root coverage, bone grafts, socket preservation, oral surgery in extraction sockets. A great idea to avoid dry socket. Have you heard dry socket? Very painful for the patient, very painful, and painful for the dentist as well. What to do? Patient comes, you irrigate, put a dressing, patient goes back, comes back again. Dry socket has to take 7 to 10 days to heal. So my dear friends, in your clinic, takes 5 minutes to take a 5 ml of blood, prepare PRF, take out any tooth. I am not saying a wisdom tooth. Take out any tooth, extract, put PRF inside and give one suture. Fine. One clot is formed after extraction. One concentrated clot you are giving in the form of PRF and suturing. And if you're charging, say, X amount from a patient in your private practice using PRF, you can charge 10x. 10 into X. You can tell the patient, I'm going to use your own blood. It is going to heal very fast with least complications. Yes? Oral surgery, pre-prosthetic surgery, periapical surgery, implants to enhance osseointegration. Amazing results in implants. Implants, what do implants require? Implants require basic growth factors. So if you give them loaded growth factors, amazing osseointegration. Endodontics for the regeneration of pulp tissue. You can inject PRF, liquid form, IPRF inside a root canal. Anywhere in the body needs growth factors, right? So inject it anywhere. Damage root, apical dentin in pediatric dentistry for pulp capping procedures. Showing you a case of platelet-rich fibrin, case 1, case of an immediate extraction socket. The tooth was extracted. You can see the implant is placed. He just told you, extract a wisdom tooth, put this inside and sleep aram se. Patient is not going to have any dry socket. Fine. So this is another application. Third, case 3, sinus lift. A direct sinus lift procedure. In this case, we have made a lateral window, and after the sinus lift was done, close it with PRF. Again, it will form bone. The bone you have removed to create the window, PRF is going to form that bone, another in 3 to 6 months. PRF case 4. Now, in this case, you can see it's a very narrow ridge for placement of implant. So in narrow ridges, what we can do is a technique known as a ridge split. We split the ridge, we give a incision in the bone with some vertical incisions, and you can see this vertical groove. This is the horizontal groove on the ridge, and this is the vertical groove. We expand the ridge, right? We expand the ridge along with splitting the ridge split. So what is this exactly? We have fractured the bone. Yes? We have fractured the bone. In any part of the body, if the bone breaks, it's known as a fracture. This is an intentional fracture of the bone, but we have not separated it from the base. The bone is still joined to the base. So in this case, you can see this test tube, centrifugation ke baad, what we have gained is a very nice PRF formulation, and then we take it out in a dappen dish, mix it with a bone graft, and put in, after the placement of the implant, cover it with PRF, then the remaining PRF, put it on the soft tissue, and then suture. So one part of PRF and bone graft goes inside the, with the implant, remaining PRF goes top of the implant, and then you suture. So I'm gaining two things here. With PRF, I'm going to get a good bone. With PRF, I'm going to get a very good soft tissue. And when I have to give the prosthesis, what do I need? Implant is successful, fine. It is also integrated. But I need a nice attached gingiva to place a prosthesis. That also I gain with this PRF. Evaluation of peri-implant soft tissue and crystal bone levels in dental implants placed with or without PRF membrane and PRF liquid. Now, one is PRF membrane, the remaining liquid is also not to be wasted. When I take out the PRF membrane like this, there are some 10 drops which come out of that. I preserve that also. That is known as PRF liquid. Your 5 ml of blood is like diamond to me. I'm not going to waste even a drop of that PRF drops coming out. How will we use? I'll tell you. Now, see, my dear friends, dental implants placed with PRF. So this is the case. You can see the edentulous site. Now, we plan to place an implant here. Absolutely nice bone. Now, before placement of the implant, you can see some liquid in the dappen dish. This is PRF liquid. I have taken out the PRF in the solid gel form, and the remaining liquid is the PRF liquid loaded with growth factors. Don't throw it in the dustbin or the dental chair spittoon. Dip the implant. Dip the implant. Now, if I don't dip the implant first of all will go in the socket and touch your normal blood. Yes? So before touching the normal blood, why don't I load it before with growth factors and then place the implant? So we dipped it and we have placed the implant successfully. Now the PRF, you can see with the tweezer in a solid form, we cover the implant with the PRF gel. Do you see this covering? This is the PRF gel. Suture it. This is the placement of the implant. And this is a 12 months X-ray after the prosthesis. You can see excellent crestal bone levels. There is no bone loss at all. And an excellent width of attached gingiva was achieved. So just an additional procedure while doing an implant, which doesn't cost much to you. But yes, you can charge to the patient, obviously. So in this cases, I compared with PRF and without PRF. So with PRF, a great papilla fill was observed, very less crestal bone losses, great reduction in probing depths. Now everything comes with the limitations. What are the limitations of PRF? Only a limited volume of PRF can be used because you have to take it from a patient's antecubital vein, and for dentistry, take 30 ml of blood. 10 ml, 10 ml, 10 ml. I say even 50 ml of blood. 5 times, 10 ml, 10 ml, 10 ml, 10 ml. 50 ml is not much. But if I talk of PRF used in other surgeries of the body, you need a lot of blood, right? So in dentistry, there is no problem to the patient, and 50 ml of blood is also not a problem. Usually, my normal procedures of what I showed you is just 5 to 10 ml of blood. That's it. PRF tissue banks are unfeasible. So everyone was thinking, why not preserve the blood and make a PRF tissue bank? They are unfeasible because PRF membranes are totally specific to the donor. Your blood cannot be used by the other person. You know it. Blood transfusion? Nahin. So why to make a tissue bank? Call the patient, take the fresh blood. 12 minutes it takes for the PRF to form. Jitni der mein anesthesia di hai, your PRF is ready. Next, after PRF, CGF, concentrated growth factor, again coming from your own blood. CGF, like PRF, does not require the addition of any thrombin. It is altered protocol, and this is just playing with the centrifugation speeds. Unlike PRF, however, CGF is prepared with 20 to 60 cc. In this, we have to take 20 to 60 cc of patient's venous blood. Centrifugation speed 2400 to 2700 RPM using a specific centrifuge, resulting in rich blocks which are much larger, denser, and richer in growth factors than the common PRF. What are the various modes of CGF preparation? How is it made? First, acceleration for 30 seconds, then 2700 RPM 2 minutes, then 2400 RPM 4 minutes, then 2700 RPM 4 minutes, followed by 3000 RPM 3 minutes, and then deceleration of 30 seconds to a stop with a centrifuge. Amazing steps you have to stand there and make, and you get an amazing product known as CGF. A special centrifuge, this is made by a company known as CynoDent, Medifuge, but you can use other centrifuges as well. Essentially, what is CGF? It is an upgraded version of PRF. Why? It is a bit more dense, more boosted growth factors and cytokines, right? So it is a better form of PRF. Periodontal ligament cells cultured with CGF membrane showed increased osteogenic markers such as collagen 1, bone soluble proteins, and osteocalcin. CGF membranes are used to cover wounds. You can see this is the preparation. This is the liquid, and this is the CGF prepared, and you can see how we have isolated it with the spatula. A clear, dense structure. It looks more dense than the PRF as well. Fine. So, and end of the surgery, the wound can be brushed with the serum. I told you, don't waste any liquid which is left. That is our own blood loaded with growth factors. So once you use this in any type area of surgery, after the surgery and the suture, brush with the cotton pallet or a surgical brush, just use this liquid to promote a nice healing. CGF case 1. In this case, you can see there is a lot of bone loss, and if we have to place an implant, the sinus is very close. This is the sinus position, almost 2 millimeters. So we need at least 8 to 10 mm of bone height to place an implant. Yes? So there is a procedure known as sinus lift. So in this case, we make a lateral window or a direct sinus lift. You can see we have made a window and exposed the sinus. So, and place the implants simultaneously and the window, obviously after raising the sinus, and we have placed CGF inside the window what we have created for the placement of implant. The same case I showed you. Can you see the bone? We have gained 8 to 10 mm of bone with a lateral sinus lift with simultaneous placement of implants and using CGF. This is after 6 months. Can you see the bone? It's the amazing results of your body's own healing and using CGF along with this, and we were able to give the processes. CGF case 2 in a case of gingival recession. You can see in this canine, you can see the recession. We planned a coronally advanced flap using CGF. The flap was lifted and the root planing was done, and then we are doing a procedure known as root biomodification. So in this case, what we are using is 24% EDTA, ethylene diamine tetraacetic acid. Just clean the root for 30 seconds with 24% EDTA. It will remove the smear layer. It is known as root biomodification. Fine. After that, we have sutured the CGF membrane. See the power of that. We can actually suture your CGF with what we have obtained from your blood, and then we coronally advance the flap, and you can see 90 to 95% of root coverage was obtained after 6 months. So this is the power of CGF in root coverage. Next, after CGF, something known as MPM. Very unlikely if you have heard about this term. Many clinicians ask me, what is MPM, what is sticky bone? I am just back from Vietnam, 3 days back. I was invited there to speak on my new invention, which I will be sharing with you. So there, Dr. Son, who is the inventor of sticky bone, was present, and I had a lot of interactions with him. And amazing product, sticky bone. The word says sticky. I'll show you how. A way to prepare the particles of bone grafting or bone substitute that makes it malleable, stable, and enhances the penetration of growth factor inside the graft. Speed 12 to 15 minutes at 2500 RPM. Everywhere you are seeing PRP, PRF, IPRF, APRF, LPRF, TPRF, CGF, MPM, sticky bone. What am I playing with? Your own blood, 5 to 10 ml, and a centrifuge machine. Just the difference of speeds and RPMs. Blood taken from the patient's and antecubital vein. The centrifugation was done, and we obtained this. And now you can see we are extracting this liquid. This yellow liquid is being extracted and mixed with the bone graft. Can you see this white thing? This is the bone graft, and we are mixing this yellow liquid, which is the MPM liquid or the sticky bone. Now you can, and this bone is particulate bone, powdered bone, the artificial bone. Fine? It is in powdered form. Now you can actually lift this bone with a tweezer. Hence the name sticky bone. MPM case 1, implant placement, loss of buccal bone, so implant threads are exposed. Fine? Cover it with MPM and we sutured it back. After the 4 months, we removed the cover screw, and you can see beautiful bone which was absent during the initial phase. The buccal bone was absent. We see a perfect bone formation, and you can see an amazing gingival collar with rich, nice 2 to 3 mm of attached gingiva, ready for prosthesis delivery. Sticky bone. You can see in this picture, this powdered bone mixed with the liquid is held like this. Yes? You can see what tensile strength this sticky bone has, and it can do wonders in our dentistry. So in this case, we are going to use sticky bone in placement of implants in the mandible, both on the left and the right side. Now in this case, implants were placed, still they are exposed. There is narrow ridge, yes? But we still place the implants. Can you see these tiny holes in the bone? We have created these holes. Why have we created these holes? To get blood. To get blood so that the graft or the sticky bone we are going to place on top gets the nutrition and the blood supply to the graft. Yes? So in this, we are going to have some nice osteogenic stimulation. So in this case, we have covered it with sticky bone. Can you see this? So implants placed, narrow ridge, do some holes in the bone, put sticky bone, suture, forget for 4 months. This is again, after the sticky bone, you have to place a membrane to stabilize it. Something you would have heard in perio, GTR. But when we use it with bone, we call it GBR, guided bone regeneration. Implant placement. Can you see this bone formation? Yes? So, awesome bone formation, no crestal bone loss, parallel implants, amazing results. So MPM is a natural evolution of the PRP and the PRF. The interesting part in MPM is the mineral fraction, which is either autologous bone or any other bone graft. So MPM is, you have to add a bone graft. In sticky bone, you need to add a bone graft. So it has more osteogenic potential. So it is a jungle of platelet products in the market available. I mentioned quite a few. It is your choice. What are you comfortable with? Are you comfortable with PRP, PRF, various forms of PRF? You are comfortable with CGF. You are comfortable with the sticky bone, MPM, your choice. But same techniques, same blood, same centrifuge. You just have to play with the speeds and the centrifugations. It's your choice. Okay, coming to the last 5-7 minutes. This is my invention, Magic Os. Just launched in Vietnam 3 days back. Got Best Presentation Award from all over the world for this invention of mine. This is my second launch in India, and I'm very proud to launch Magic Os at KGMC, Lucknow. I hope I'll get more launches soon, and this product should be there in research papers soon. It's known as Magic Os. What is Magic Os? It is a mixture of vitamin D, melatonin, calcium, hyaluronic acid, vitamin C, vitamin E. So all these products are again vitamin D, human body, melatonin. Melatonin, you know, is a hormone present in our body. Calcium, yes. Hyaluronic acid, yes. Vitamin C, yes. Vitamin E, yes. So all these are basically some nutraceuticals or hormones. These are not any chemicals which are specially synthetically prepared, right? So vitamin D, as you all know, topical applications of vitamin D on implant surface for bone to implant, they enhance the osteogenic potential. Various studies of vitamin D were done and praised. So in my technique, we are going to use 10% solution as topical application. I'm not going to use single solution. I'm just telling you, in my combination of 6 products which I'm going to add in Magic Os, these are the various concentrations to be used. So vitamin D 10%, then comes melatonin. It is an indolamine synthesized and secreted by the pineal gland. You know what? Melatonin helps you to sleep. Abroad, people take melatonin tablets to sleep, right? But it is also a very great substance because it has antioxidant and inflammatory properties and a great role in bone formation and reduction of bone resorption. So it has shown that melatonin increases the orthoprotectin expression while decreasing wrinkle expression. So it decreases bone resorption. It decreases osteoclastic activity. Various studies which support melatonin to bone formation. So melatonin 1.2 milligram per ml as topical application. Calcium, everyone knows the role of calcium. Following implant placement, titanium surfaces establish an ionic equilibrium with the surrounding tissue in which calcium plays a major role as it mediates plasma protein absorption, intervenes in a number of other agents for bone regeneration. Studies suggest that there is a great importance of provisional matrix formation to the implant when we use calcium, along with various studies which support the role of calcium in implant success. So I'm going to use a solution containing calcium gluconate and calcium chloride, adjusting the pH to 7.35 to 7.45 as topical application. Coming to my fourth, hyaluronic acid, used in skin surgeries, dental surgeries, everywhere. It is osteoconductive and is a very positive interaction with the progenitor cells responsible for bone formation, consequently making it responsible for secondary stability. One is when you place an implant and you torque it, you get primary stability. You also require secondary stability after 3 months, and hyaluronic acid plays a great role in secondary stability. Hyaluronic acid acts on migration, adhesion, proliferation, differentiation of various cell precursors on titanium implants by improving the connection between the implant and the bone. The use of hyaluronic acid in perio for the closure of black interdental triangles with small gel infiltrations have a great impact on treatment. Various studies which promote hyaluronic acid, they are well versed in literature. 1% solution or gel as topical application. Vitamin C. Everyone knows the role of vitamin C in COVID times. You know, everyone was on vitamin C. Something must be there with vitamin C. So a lot of, yes, it is required. Postoperative healing following dental implant surgery in patients with chronic periodontitis and treated with GBR. It is critical to bone health, helps to stimulate the production and action of osteoblasts, the cells that build bone. So basically, when we're talking of implants, perio, bone regeneration, we are actually playing with the bone. What we need is decreased osteoclastic activity, increased osteoblastic activity. So add on the products which increase osteoblastosis, decrease the products which can lead to osteoclastosis. So vitamin C is important nutrient that exerts a reducing antioxidant effect, scavenges free radicals, act as enzyme cofactor, excessive reactive oxygen species. So it is very important dietary constituent as well for a periodontal health. So why not add vitamin C? Various studies, I can say 1,000 to 2,000 to 5,000 studies of vitamin C supporting implants and perio. So planning to add vitamin C 500 milligrams per ml as topical application. Last, vitamin E. Vitamin E role in skin, everyone knows. So protective role is preservation of alveolar bone, which has a supporting role in periodontitis, improvement of periodontitis, and it showed in various studies that there was decrease in pocket depth, which is an indicator of disease progression, and also it led to fighting of proteolytic enzymes and reactive oxygen species. So vitamin E helps in the defense mechanism of our body. Various studies which support vitamin E. So vitamin E, 100 milligram per milliliter as topical application. Now you must be thinking topical. I am not going to put any one product as topical. These 6 products have to be added and made into one solution. Magic Os applications, it can be used during implant placement, add on to GBR procedures, treatment of periodontitis, treatment of periimplantitis, treatment of cystic lesions, treatment of endoperio cases. My dear colleagues, I just showed you a lot of slides, lot of cases, PRF, PRP, CGF, MPM. Addition to this, one more syringe of this Magic Os. You are already having a lot of growth factors with you. Inject one more liquid. Inject one more liquid. Whether you are using a bone graft, inject this liquid. Whether you're using PRF, inject this liquid. MPM, inject this liquid. You're not going to fail. You are adding some more, power to your PRF, power to your MPM, power to your PRP. You are adding calcium, you are adding vitamin E, you are adding hyaluronic acid, you are adding melatonin, you are adding calcium. So vitamin D, C, everything you are adding. So it's going, you're bound not to fail, right? Cases with Magic Os, we tried some cases. Comparative evaluation of effects of local application of Magic Os as a biomimetic agent in delayed loaded implant. Now in this case, we can see we have to place an implant in this ridge, expose the ridge for the implant placement. Osteotomy is prepared. Can you see a beautiful osteotomy hole? This is known as the osteotomy hole for placement of implant. Now, I can just place the implant right now. But now tell me, the audience, what do you want me to place inside this socket? PRF? Abhi aapne dekha PRF, PRP. But this time I'm going to use my own product, Magic Os. Why should I use PRF, right? Just joking. You can add PRF plus Magic Os. But in this case, this is Magic Os. The 6 products I told you, topical applications, we have mixed them all, prepared a liquid, and no centrifuge, just a preparation of all these. And we have, can you see, we are placing this inside the osteotomy, placement of an implant. And after 6 months, there was much decrease in bleeding index, there was much reduction in the probing depths, a great pink aesthetic score around the implants, there were very less crustal bone loss, and implant stability, you can see 100% implant stability was observed. Second case, effect of Magic Os on regeneration of intrabony periodontal defects treated with bone graft. Now you can see in this case a great probing depth. Can you see? Now what I do in my practice is I do minimally invasive periodontal flap surgery. The latest MISP, it's known as MISP or MIP, minimal invasive periodontal therapy. In your perio, you must have seen buccal flap, lingual flap, buccal flap, palatal flap, both the flaps together. I do a single flap approach. Either I lift the buccal flap or I lift the palatal flap. Because whenever you lift a flap, there are chances of postoperative recession. Why to give so much recession to your patient? You can easily reach the palatal area from the buccal side. You can easily reach the buccal area from the palatal side, right? So I do a single flap approach. So you can see I have split the papilla. Never ever waste your interdental papilla. It is the most difficult thing to regenerate a papilla. Mark my words, it's written in the books, you cannot regenerate an interdental papilla. It is very tough. So you can see I've given a split incision. Papilla is left intact. Now I'll be lifting the flap and debriding it. Can you see? The papilla is intact. We have debrided the bone defect. This is a mixture of bone graft with magic cause. Yes? So PRF plus bone graft, I showed you the earlier cases. Magic cause plus bone graft. We're going to place this in the defect. We have places this in this defect and sutured. After 6 months, you can see a reduction in probing depth. Compare this X-ray, preoperative. Can you see this bone defect? After 6 months, can you see this bone formation? Amazing results were achieved. So this is what my study with Magicos is going on, and you will be seeing in next 3 to 6 months some more launches of Magicos, some more studies, some more publications, and maybe at some other platform I'll share more cases with you. Hope I could deliver something to you. These are my contacts, and if anyone needs more information regarding any products, you are most welcome. Thank you very much. Any questions, please? All good? You. The one with the specs. She's a great listener. I was just watching how she was listening to the lecture. I must congratulate you. I don't know whether I was the one who's speaking nice or you are interested, or it's a combination of both of us. You were a great audience. I just saw how you were listening to the lecture without any, disturbance, and great. I really appreciate it.
Thank you, sir, for this enlightening lecture. I would like to call upon Dr. Ashish, sir, to please give away memento to sir.
Thank you.
Thank you, sir. Our next lecture for the day is by our eminent speaker, Dr. Abhishek Nagpal, sir. Sir is the head of the department, Prosthodontology at SGT University, Gurugram. Please put your hands together for sir.
A very good morning to one and all. Just give me a minute. The system is traveled all the way from Delhi. It is just booting up, a little jet lag. We've been hearing a very wonderful presentation wherein Sir was telling about the osseointegration of the implants, wherein he has generated a lot of bone. I mean, I think that's a miracle what he's been doing all these years. And once the foundation is good, then our rehabilitation works out well. These things go hand in hand. So today I'll be telling you about how do we fabricate prostheses these days on foundations led by our clinicians, right? Even though we are, a part of the game, prosto, oral surgery, perio, working synergistically. So ultimately the aim is to put tooth for the patient, right? हो गया almost. I would like to thank the team of CynoDent for giving me this opportunity to come here and talk to you regarding this digitization in prosthodontics. Basically, the aim is to digitize the entire process. Once the implants are done, the preparations are done, the whatever procedures for whether it is a complete denture, a removable partial denture, a cast partial denture, or a fixed partial denture, or any implant supported prosthesis, or for that matter, any maxillofacial prosthesis these days. It's very important to know the digital workflow, because as far as your not only fabrication is concerned, the other processes are also getting digitized these days. We've been rehabilitating cases for mucormycosis of lately. After this pandemic, we were the only center at SGT in the near Gurugram area, the area where the college is, wherein people were referred from various places affected by maxillectomy, going right up to the orbit because of mucormycosis post-COVID. And such patients, these are even more tough to handle because there is no bone left. The surgeons just remove whatever is affected, leaving whatever the patients come to us. So we have done almost all type of cases, rehabilitating them with a conventional denture, with an implant supported prosthesis, a cast partial denture, and silicone prosthesis combined with acrylic, and also by implants. And zygoma was the bone which helped us out in rehabilitating these patients. But believe me, doing the conventional impression procedures was very tough. We could not manage all the implants getting captured in one go. Jig trials were wrong. So we resorted to the digital workflow, requested one of the labs to collaborate with us, and we fabricated a prosthesis which worked very well for our patients. I would have definitely shown you those cases also, but then within the limitations of the time, I'll be restricting myself to this. So we all know we can fabricate prosthesis in a conventional manner or a digital manner. So conventionally, what do? Is we select a tray, make an impression, do the model pouring, fabricate the patterns manually, invest it, cast it, and then finish it. As far as the digital workflow is concerned, we do an optical scanning, we fabricate the pattern digitally, then we fabricate the prosthesis either by milling or by printing, and finally the finishing of the product. So today we focus on how do we fabricate this digital prosthesis by these two processes. These two sound similar but are very much different. So first and foremost, what is CAD/CAM? It refers to the integration of computer-aided design and computer-aided manufacturing. So the manufacturing part is either by additive technology or by subtractive technology. So what is additive? Additive, as the name suggests, the additive layer manufacturing is the industrial production name for 3D printing, a computer-controlled process that creates three-dimensional objects by depositing materials usually in layers, one layer by layer. So let's see what is 3D printing. In 3D printing, what happens is the design is being done by the technician, and the design, the 3D, then is sent for fabrication to the 3D printer, wherein layer by layer the material which has been chosen to print is added, and with the help of a laser beam or a projector, the product gets fabricated. The advantage of this technique is that you can build any complex structure using this technique, and you can control the density of the product. That is, a complex structure can be built hollow. You can control the density of the product what you are doing. So you can make any complex shape, whether it is dentistry related or any other thing available in the market. So 3D printing, that is additive manufacturing, is the need of the hour and is the in thing now. You can even replicate yourself using 3D printing. So American Society for Testing and Materials has divided the 3D printing or the additive manufacturing into 7 families. Those are, first and foremost is the vat polymerization. It includes stereolithographic apparatus, which is being used in dentistry these days. Then we have digital light processing, scan, spin, and selectively photocure, continuous liquid interface production. In all these things, what happens is, vat of liquid polymer is cured through selective exposure to light, either via laser or by projector. It results in high accuracy and complexity. Complexity means you can build up any complex shape or procedure the way I showed you. If you've seen an implant prosthesis all on 6 or all on 4, that prosthesis or framework, if you do it with additive technology, serves a lot of advantage. That I'll tell you later. Provides a smooth surface finish, accommodates a large build-up area, and the choice of materials are UV curable photopolymer resins. The next is the powdered bed fusion, which involves selective laser sintering, direct metal laser sintering, selective laser melting, electron beam melting, selective heat sintering, and multi-jet fusion. Out of all these, the first 3 are serving us in dentistry. Again, we have high level of complexity. Powder itself acts as the support material to build up during the build-up. We can use wide range of materials like plastics, metal, and ceramic powders and sand as well. The next we have binder jetting, which includes 3D printing, X1 and voxel jet. Here the liquid agents are selectively applied onto the layer of powdered material. See, the idea behind telling you all this is that the moment you are in the market and you are about to fabricate a prosthesis or open up a lab, you must know what equipment and instrument you must have and what equipment and instrument your lab is using so that you can utilize it to the maximum and obtain the best results from your labs for your patients. So allows for full color printing, high productivity, use a wide range of materials, and we can use powdered plastic, metal, ceramics, and glass and sand. As far as 3D printers are concerned, we have our chair-side 3D printers available these days. You can easily fabricate temporaries for your patients, stents for your patients, bonding, orthodontic bonding brackets for your patients, chair-side, and just cement it across yourself only. Then we have material jetting, which includes polyjet, smooth curvature printing, multi-jet modeling, and projet. Here, droplets of material are deposited layer by layer to make parts using UV light. Again, you have high level of accuracy here, allows for full color parts, and enables multiple materials in a single part, and we can print photopolymers, polymers, and waxes. Then you have sheet lamination, as the name suggests. You have laminated object manufacturing, selective deposition lamination, and ultrasonic additive manufacturing. Here, sheets of material are stacked and laminated together to form an object, either by adhesives or by chemicals. You can do high volumetric buildups here, relatively cheaper, and combination of metal foils can be obtained. The materials are paper, plastic sheets, and metal foils and tapes. Then we have material extrusion. As the name suggests, material is extruded through a nozzle or orifice in tracks or beads and heated and pressed like a thermoplastic material. It's inexpensive and economical. Multiple colors are possible, can use in your office environment, and parts have good structural properties, and you can print thermoplastic filaments, pellets, liquids, and slurries. Then you have direct energy deposition, which has laser metal deposition, laser engineering net shaping, and direct metal deposition. Here, powdered wire is fed into a metal pool generated on the surface of the part, and then later on with the laser beam or the electron beam, it is being fused. So it's mainly used for addition purpose, soldering purposes of broken parts. The choice of materials are metal wires and powders with ceramics. The next and the last is the hybrid ambit. Here, laser metal deposition is combined with CNC milling. CNC is computer numeric controlled milling. This we'll be discussing in the subsequent slides. So, as far as additive manufacturing is concerned, the 3 families and their 4 children are serving us. So, you have vat polymerization, wherein stereolithographic apparatus is working. Powdered bed fusion has selective laser sintering, direct metal laser sintering, and selective laser melting. And binder jetting has 3D printing, which is serving dentistry as of now. Then we move on to subtractive manufacturing. The subtractive manufacturing is the name is an umbrella term for various controlled machining and material removal processes that start with solid blocks, bars, rods of plastic, metal, and other materials that are shaped by removing material through cutting, boring, drilling, and grinding. So let's see how subtractive manufacturing is working for dentistry. Here you see a production of an implant abutment. This is a milling machine. So this is the axis, the spindle, and the lathe working together to customize the abutment for a molar tooth. The dimensions are fed into the machine and the milling unit works. If you see, the spindle was coming straight initially. Now it has changed the direction to a right angle. The platform where the implant abutment is being milled is also moving up and down. There is another lathe which comes down to cut the metallic part off and give the finished product. So this is a 7-axis milling machine which is working in all 5 to 7 axes to produce an implant abutment customized for that particular tooth for your patient. I'm sorry the sound is not working here. Neither I would have wasted more time. I have already taken Sir's slot, I believe. So this is how milling is done. When you are fabricating big processes like all on 4, all on 6, additive technology is better because you can't mill hollow products. When you are milling implant components, this is better. The subtractive manufacturing is better because this is purely numerically fed and the machine works beautifully when producing implant components separately. So the implant abutment is almost through. Now the lathe cuts it. So this is the abutment which is ready for you to place it on the tooth, make the impression, send it across to the lab, and you can have the desired crown over it. So this is a customized abutment which the labs are usually making. So this is what was precision milling. The precision milling is milling along the multiple axes X, Y, and Z as guided by the CAM software. This what you had seen was X, Y, Z, A, B, and C. So all 6 axes the milling machine is working. So what are the 6 axes of milling? The X axis along the length of the bar, Y along the depth, then Z axis the spindle has, then rotation along each axis defines the second component of axis, the A, B, and C. Rotation along the X is A axis, along the Y is B, and along the Z axis is the C. So accordingly we have the milling machines. We have 3, 4, 5, 7, 9, and 12. Depending upon the amount of movement in the spindle, the type of movement of the burr itself, the milling tool, how much of the platform is moving. So the number of axes is defined. So till now in dentistry, we are working with 7-axis milling machine, which is milling in all on the right, left, top, down, back, front, followed by the axis defined by the spinning of the tool, rotation of the part, rotation of the tool head, and movement of the clamping, reclamping, and removing of the part. So 7-axis is a rocket which is working, and the milling speed is quite accurate. The very less, and the milling is quite accurate. It is about 0.8 microns, the accuracy of the milling unit which it is working on as of now. And when we talk about the 9-axis milling machine, when 7 is working so fine, imagine what 9 would do. 9 has a finishing component as well, that the entire product comes out thoroughly finished. You do not need to work on it more. And 12-axis would be something great, yet to see. The other things which can be used for subtractive manufacturing are laser machining, that uses direct heat from a laser beam to remove the material. Simple as that, like a hard tissue laser, right? Then focused ion beam, wherein the gallium ions are used to remove the structure or the surface of a structure to produce the desired product, which are still to be used in dentistry. But since these are, so I thought I'll just tell you what all are other materials. So what are the applications of these techniques? Additive or subtractive, any field of dentistry, any field of human life, everywhere we are using these manufacturing techniques, whether it is automotive, aerospace, electronics, healthcare, or food. Even your food, your chips, anything and everything is 3D printed now when you see similar shapes. Whatever I would say, if it is not backed by evidence, you guys won't believe, right? So as far as the accuracy of the additive technique is concerned, it is dependent upon the layer thickness. As I told you, layer by layer, the material is deposited and it is being cured with the help of a laser or an electron beam, and the width of the curing beam. The thinner the layers and narrower the curing beam, the more accurate the final product is. Increasing the number of layers and reducing the diameter of the beam will exponentially increase the fabricating time. So therefore, beyond a certain extent, we cannot reduce the thickness of the layer and can't narrow the beam much. But still we are getting reasonable accuracy as far as implant prosthesis is concerned. In relation to selective laser melting, we have a reasonable accuracy as far as our implant prosthesis related to all-on 4 or all-on 6 are concerned, the accuracy ranging between 3 to 82 microns. As far as the crown and bridge work is concerned, we are getting similar results for cobalt chromium, whether it is milling, additive manufacturing, or casting. But yes, this has an added advantage that once the files are there inside the system, even if something has gone wrong, you can immediately reprint your prosthesis. You don't have to go back to the patient again to record it, everything back again. Till ages you can keep this information, and if the tissues are the same, they do not change, you've temporized properly, the previous restorations were good, nothing happens, you can immediately just give the machine a command and regenerate your prosthesis. As far as the surgical guides and splints are concerned, these are 3D printed and are quite accurate, ranging between 0.4 to 2 millimeters as far as the horizontal placement is concerned, vertical placement is concerned, and angulation is in the range of about 2 to 5 degrees. So highly accurate, even beginners can place. Frameworks like this cannot be produced by milling. As I told you, you can't mill hollow products, you can't mill complex structures. So for that you need 3D printing. So cast partials are only being produced by 3D printing and are being produced with reasonable accuracy, which are comparable to casting procedures, because till now this is only the process which was being followed. As far as denture bases are concerned, 3D printing has also offered reasonable accuracy. Slight discrepancies in the palatal regions have been observed, but so far this is not very frequently done because of the cost involved. Turns out to be a little more expensive because all the teeth and the denture base have to be milled, but believe me, it's a beautiful procedure. As far as the models are concerned, these are being used very frequently now. The gypsum casts are being replaced, have an accuracy of about 97 to 99%, and can tolerate high temperature, low moisture absorption, and low shrinkage. Beautiful models. Even the articulator gets printed itself. When you scan the bite of the patient, if you have a single crown, you can scan the upper, the lower arch, the bite. It comes out with an articulator so that you can just see how the teeth are in the patient's mouth. It comes with a hinge joint, so you do not need to articulate your models. Then impression trays. These are also being fabricated. If you need a customized impression tray for like an all-on 4 and all-on 6, this is a very nice technique wherein you can generate this tray from 3D printing and record the impressions. Studies still going on, how far the accuracy is there, but believe me, the material is quite rigid, and hopefully the results would be good. As far as night guards are concerned, you can print them and with the same reasonable accuracy as the other ones are. The orthodontic models being used extensively by all the aligner companies like Invisalign and all. They just print all the models of a patient in one go. The entire treatment is recorded, the entire result is on the table, the entire sequence of aligners is being printed according to the models which the software has generated, and you get the entire sequence. This is because the 3D printer is enabling you to do that. Then indirect bonding trays are also being fabricated these days with the help of printing. Then aligners, obviously. Another beauty of 3D printing is that it allows for multiple materials to be printed in one go. You can print n number of things depending upon the printer you have, the quality and the materials it is supporting. Obviously, the cost obviously rises when you have such kind of a printer, but yes, it is possible to print multiple materials in one go. The company which Invisalign is using is Stratasys. The printer itself costs around 2.5 crores, and it has a building speed of about 200 models or so in an hour or so, and that is why they are providing or catering to the entire population in almost the whole world. Then as far as the milling components are concerned, I told you when you're making big frameworks, 3D printing should be your choice. When you're milling implant components, then milling should be your choice because it produces more accuracy when implant products are concerned, because you're feeding in computerized information for the implant abutments. The numerics are being fed in, that is why it leads to better production, and you can see the results ranging between 0.7 mm to 11.3 for the MLS components. And cast abutments are obviously having more discrepancies, about 9.1 microns. As far as ceramics and zirconias are concerned, milling is the only solution as of now. You can't 3D print them. So zirconia, majority of people are working on, and it has replaced a lot of aesthetic materials and given dentists a reasonably good aesthetic material with the advent of the multi-layered blocks, plus other ceramic materials which are providing good aesthetics to zirconia, like Ivoclar has just launched a ceramic wherein you can use core of zirconia and layer it with the ceramic, which is IPS Emax Ceram, they say. So it gives the aesthetics of the Emax crown and strength of zirconia, so that you can use it in the posterior teeth beyond the second premolars. So this is what results. That is why they say when you're preparing or doing a crown preparation for an Emax or a CAD-CAM restoration, your restoration should be rounded. It should not have any sharp angles, because the minimum diameter of the milling tool is about 1 mm. So it can't produce a sharp line angle. So there is a component in the machine where it compensates for any sharp line angle, so which might compromise the fit of the prosthesis. So might as well do it while you're preparing only, so that this error does not generate. That was just a tip. You can also mill dentures, but then again the cost factor is too high. But yes, the adaptability of the denture base produced by milling is supposed to be better than what it was done with the help of 3D printing. But then research still is going on as to provide you substantial results. Milling wax patterns is again a beautiful procedure. You can just avoid doing hand buildup of wax. You can design the wax pattern with the help of a software, print it or mill it and cast it. But these days casting is being taken over by printing. As far as CAD-CAM inlays and onlays are concerned, yes, milling has come out with a good option, good way of production, but then results are similar as far as the production through other mechanisms is there. So you can go with either of them. So in the end, I would just like to tell you what are the basic differences between the additive and the subtractive technologies. In additive manufacturing, layer by layer, the material is being added. In subtractive technology, layer by layer, the material is being subtracted. The manufacturing concept is usually suitable for materials having low melting points, such as plastic, whereas in milling, it is not related to any melting points. You can just mill any product available to you for dental use. The volumetric density of the constructive material of the final component can be controlled during the operation. As I told you, you can control the density of the product. That is why bigger frameworks, hollow frameworks can be built up using 3D printing, which can be lighter in weight because a lot of weight has to come, of the restoration as well. First the framework, then the restoration, ceramic, everything has to come up. So it is better to do a 3D printing procedure for them. For milling, you can't control the density. No material wastage takes place in 3D printing, whereas there is a lot of wastage in the form of chips, scraps, dissolved ions and vapors when you are milling. Complex shapes can be easily fabricated using the additive manufacturing. Subtractive manufacturing has limited capacity in manufacturing of complex shapes. Structures containing fully controlled closed inner hollow parts can be produced. We can't produce hollow parts by using milling. So for printing, narrow range of materials is there. For milling, we have wide range of materials. In the end, whatever the technology is, you need power bank for our country, whether it is Tesla or your mobiles. Thank you. I hope I have briefly tried to cover the basic manufacturing protocols available these days, and I'm sure with this insight, you will switch over to dental digitization in dentistry in your practices as well. Thank you.
Thank you so much, sir, for such a wonderful lecture. I would like to call upon stage Dr. Anmol Bagaria, ma'am, to please kindly felicitate our eminent speaker over here.
Hi. Thank you so much. Just take this.
Our next speaker of the day is Dr. Shaleen Chandra, sir. He is a professor and head of the department at Department of Oral Pathology, Faculty of Dental Sciences, King George's Medical University, Lucknow. Please welcome him with a huge round of applause.
One word, I'm not going to speak pathology, so don't run. कितने लोग fresh graduates हैं? How many of you are fresh graduates? On the stage and behind the stage. कितने लोग fresh graduates हैं? Fresh graduates means interns and just pass out या 1-2 साल हुए हैं pass हुए. Raise your hand, ऊंचा खड़ा करो. काफी, सब आगे आ जाओ. आगे आ जाओ. Come in front. I'm not going to teach pathology, don't worry. My subject is oral pathology. I love oral pathology. I'm not going to teach oral pathology, don't worry. We have been taught oral pathology by 3 persons from today till tomorrow, from yesterday till today. So I'm not going to do that. Sir. हाँ, start कर दो. कौन सा है? अच्छा कौन सा है? I am going to talk about a very basic thing where many of you get stuck and you even get advices from so many people कि पहली चीज जैसे ही एडमिशन होता है बीडीएस में कहाँ फंस गए है ना कहाँ फंस गए बहुत से आ जाओ आगे आगे आ जाओ बेटर इंटरेक्शन होगा इसलिए कह रहा हूँ आगे आ जाओ हाँ ये बहुत बढ़िया है आई थॉट यू डोंट हैव दिस वेरी गुड चलो सो all those off stage because I can see my interns here and in front of stage. First step, एक बार फंस गए तो BDS तो ज़्यादातर 4 नहीं तो 5 नहीं तो 6 साल में पास हो ही जाता है. So congratulations, you are a doctor. There is a big ceremony and then ये इसका light नहीं काम कर रही है. अच्छा, okay, it is quite dull. Doesn't matter. So you are a doctor. And now you are officially authorized to treat patients without any supervision. आप किसी भी patient का कुछ भी कर सकते हो without any supervision because still you are intern. You are supposed to work under supervision. Now, you have passed, but you are actually standing on crossroads because आपकी family आपसे expect करती है. I think बहुत ज़्यादा echo हो रही है. हाँ इको थी, ठीक है। आपकी फैमिली आपसे एक्सपेक्ट करती है कि नाउ यू आर द प्रोफेशनल, यू हैव पास्ड, यू आर द बैचलर, सो यू शुड बी डूइंग समथिंग, एंड यू आर द प्रोफेशनल बैचलर, नॉट एन ऑर्डिनरी बैचलर। आपने BSc BA नहीं किया है कि अब MA करना ज़रूरी है, आफ्टर BDS MDS करना ज़रूरी नहीं है। इट इज़ अ मैटर ऑफ चॉइस वेदर यू गेट इट, नंबर वन, एंड वेदर यू वांट टू डू इट। ठीक है, सो इफ यू डोंट वांट टू डू इट, यू डोंट डू इट। देयर आर सो मेनी कोलीग्स ऑफ माइन हु आर just after graduation they started their practice. They made one attempt for MDS, didn't get through, forget it, start practice. So you are at a crossroads. थोड़ा सा बात करूंगा मैं बीच में ऑफ टॉपिक, अनएम्प्लॉयमेंट वर्सेस अनएम्प्लॉयबिलिटी इन डेंटल ग्रेजुएट्स। बहुत सारे लोग कहते हैं कि डेंटल प्रैक्टिस में फ्यूचर नहीं है। क्यों नहीं है? जॉब्स नहीं है ना, जॉब्स नहीं है। द प्रॉब्लम इज नॉट अनएम्प्लॉयमेंट, दे आर ample jobs. Don't say there are no jobs. The problem is unemployability. Unemployability because आपने BDS के दौरान कुछ सीखा नहीं है। You have passed. I have worked in a private college for major part of my career, from 1998 till 2013. I was working in private colleges. I have seen how private colleges work. I have been through one of the best private colleges to one of the worst. Okay, so I have worked in Rama Dental College, I have worked in Saraswati Dental College, I have worked in Buddha, I have worked in Saraswati and Sardar Patel. Okay, and I have studied in one of a very good college. My graduation I did from this very college. Sorry. And my post-graduation I did from one of the best colleges in India at that time, SDM Institute of Dental Sciences, Dharwad. Okay. As soon as I went there, I fell in love with the college and I joined. Okay. So the problem is less of unemployment, more of unemployability. ऐसा क्यों है? Why is it so? When I did my BDS, there was only one dental college in Uttar Pradesh. In Karnataka, there were about 39 dental colleges. In Maharashtra, there were about 15 dental colleges. Okay. Today, in Uttar Pradesh, कितने dental colleges हैं? किसी को मालूम है? कितने dental colleges हैं? Forget Uttar Pradesh. In Lucknow, we have 6 dental colleges. कानपुर में 2 हैं. Each and every city can boast of 1 or 2 dental colleges, and lucky ones have 5, 5, 6, 6. Okay. So, what comes with that? When numbers go up, the quality goes down. Because जब मैंने अपना कैरियर शुरू किया था, I was the second oral pathologist in northern part of India. अगर आप बिहार और से लेके गुजरात तक लाइन खींचेंगे तो गुजरात को छोड़ दीजिए, उससे ऊपर के एरिया में एक मैं और एक और, there were only 2 oral pathologists. We were in very high demand because everybody wanted to have an oral pathologist. नहीं मिल सकता क्योंकि साउथ से हर आदमी माइग्रेट करना नहीं चाहता है. सॉल्यूशन क्या निकाला? विजिटिंग फैकल्टीज. When I was working in Sardar Patel, I was taking care of whole of oral pathology, dental anatomy, oral histology, as well as taking lectures for oral medicine, because oral medicine faculty used to come only for inspections. ठीक है. और oral pathology oral medicine पढ़ने के बाद आपको पता होगा कि oral pathology और medicine में बहुत ज़्यादा फर्क नहीं होता है. They are basically the same subjects. Actually, in India we have 2 subjects, otherwise subject internationally एक ही होता है. So because of this, 2 things happened. The faculty became lax. Faculty का interest खत्म हो गया. जब एक fresh MDS पास आउट निकलता है तो बहुत सारा enthusiasm होता है कि हम ये कर लेंगे, वो कर लेंगे, सब कुछ आइडियल होना चाहिए, क्लासेस हैं तो पूरी होनी चाहिए, कोई बदमाशी नहीं होनी चाहिए क्लास में. लेकिन जब हमेशा जो करप्शन है ना, वो टॉप से बॉटम जाता है. Always starts from top. जब मैनेजमेंट गड़बड़ कर रहा है तो धीरे धीरे फैकल्टी भी लैक्स होती है, फैकल्टी लैक्स होती है, उसका डायरेक्ट इफेक्ट पड़ता है स्टूडेंट्स पे, स्टूडेंट्स भी लैक्स हो जाते हैं। उन्हें मालूम है कि पास तो कराएगा ही मैनेजमेंट, उनको 4 साल में निकालना है, उन्होंने पैसे पकड़े हुए हैं, ठीक। सो दीज आर द फैक्टर्स व्हाई देयर इज अनएम्प्लॉयबिलिटी। I have done full-fledged practice till 2013 when I joined this college. Even now I am practicing, but I see only my relatives and friends. I don't entertain outside patients for obvious reason. I cannot practice officially, okay? But friends और relatives को देखने से मुझे कोई नहीं रोक सकता है, ठीक है? So till 2013 I must have kept at least not less than 50 dental surgeons under me. और उन 50 डेंटल सर्जन्स में 3 केवल ऐसे थे जो कि कुछ वर्थवाइल थे। उन 3 के मुझे नाम याद हैं, बाकी सबका नाम मैं भूल चुका हूं, ठीक है? उन 3 के नाम मैं अभी भी बोल सकता हूं, ठीक है? तो 50 में से 3, जबकि मैं एम्प्लॉय करता था बाकायदा इंटरव्यू लेके, and my interviews used to be focused. पहली चीज डेंटल एक्सरे करना आता है? I used to ask angulations of X-ray, किस एक्सरे में क्या एंगुलेशन होना चाहिए? I used to ask about techniques of X-ray, ठीक है? ये इंटरव्यू लेने के बाद मैं एम्प्लॉय करता था। तो लोगों को थ्योरी आती थी, प्रैक्टिकल में 0 होते थे। So you need to improve your practical skills. चलो, come to the main topic of the lecture, career options. जब मैंने टॉपिक सोचा तो मैंने वेब सर्च किया, एक जॉब साइट है indeed.com, सबने रजिस्टर करा रखा होगा वहाँ पे, करा रखा है? कितनों ने रजिस्टर करा रखा है? कितनों ने रजिस्टर कराया हुआ indeed.com पे? कितनों ने कराया है? किसी ने नहीं कराया? छोटा छोटा हाथ क्यों उठा दो, लंबा उठाओ। So these are the web search results from that very website. इसको मैंने 2 पार्ट्स में बांट दिया है, एक जो कि एक्चुअली BDS या डेंटल सर्जरी से रिलेटेड है, जिसमें कि आपका ट्रेडिशनल ऑप्शन गो फॉर MDS, बाकी जितने ऑप्शन हैं वो एक्चुअली आफ्टर MDS भी आते हैं, क्योंकि कई बार MDS के बाद भी आप क्रॉसरोड पे ही खड़े होते हो कि आप क्या करें, नो मैटर विच सब्जेक्ट यू हैव डन MDS। क्योंकि जब मैंने कैरियर शुरू किया था वो टाइम गया, जब मैंने कैरियर शुरू किया था मेरे पीछे कम से कम 10 डेंटल कॉलेज पड़े हुए थे, सर आ जाइए, महीने में 1 दिन के लिए आ जाइए, 3 महीने में 1 दिन के लिए आ जाइए, ठीक है? तो अब वो टाइम गया। अब आप अगर ये सोच के चलो कि आपको कॉलेज में जॉब मिल जाएगा, वेरी वेरी डिफिकल्ट, ठीक है? वेरी वेरी डिफिकल्ट, नॉट इम्पॉसिबल बट वेरी वेरी डिफिकल्ट। यू हैव टू बी एक्सेप्शनल फॉर दैट। लाइक हमारे यहाँ अभी पोस्ट एडवर्टाइज हुई है असिस्टेंट प्रोफेसर की, एटलीस्ट 50 लोग अप्लाई करेंगे। सो आई हैव अ वाइड रेंज ऑफ पीपल अप्लाइंग। किसी के 10 पब्लिकेशन है, किसी ने इतनी रिसर्च कर रखी है, तो मैं आई विल ट्राई टू चूज द बेस्ट कैंडिडेट। तो टू बिकम द बेस्ट कैंडिडेट इज नॉट एवरीबडीज कप ऑफ टी। हर आदमी इक्वल नहीं होता है, लेट अस एक्सेप्ट दैट फैक्ट। हर आदमी इक्वल नहीं होता है, कुछ लोगों का रिसर्च बेंट ऑफ माइंड नहीं होता है, ठीक है? सो पहला ऑप्शन आफ्टर BDS और MDS, किक स्टार्ट योर ओन डेंटल प्रैक्टिस। इंडीड ने खाली BDS लिखा था, मैंने MDS स्लैश कर दिया उसमें। नेक्स्ट, कैरियर एज डेंटिस्ट ओवरसीज, देन गवर्नमेंट जॉब, आर्मी जॉब, फॉरेंसिक ओडोंटोलॉजी, कैरियर इन डेंटल कॉस्मेटोलॉजी। और अगर कुछ लोगों ने कल का लेक्चर अटेंड किया हो फ्रॉम धर्मशिला कैंसर इंस्टीट्यूट, कौन आए थे? डॉक्टर फॉरगेटिंग हिज नेम, डॉक्टर पुनीत आहूजा इज फ्रॉम लखनऊ ओनली, ही इज अ वेरी गुड फ्रेंड। डॉक्टर अंशुमन, ओके। सो वन मोर कैरियर इज देयर, यू कैन बिकम oncologist, clinical oncologist, okay, after doing about say 10 years of work, okay, serious clinical work. ये थोड़े से नॉन क्लिनिकल ऑप्शंस हैं जो कि मेरे हिसाब से एक डेंटल ग्रेजुएट के स्कोप में नहीं आते हैं, बट दे आर लिस्टेड and many of my students and my friends have actually pursued them. One girl was working with me in Saraswati Dental College. She actually did MBA and is working in a company. Not a hospital, in a company. So MBA, MHA is Master of Hospital Administration. Then MPH is Master in Public Health. Earlier it was available only in UK, but now it is being offered by so many institutions in Lucknow, in India also. Then dental blogging. You might actually be surprised how much money you can make sitting on that stupid idiot box. The idiot box is now changed. Earlier it was television, then it became computer, and today it is actually there in your pockets. What is there in your pockets actually contains more RAM and more memory than my first computer. My first computer had 128 MB of memory and 1 MB of RAM. The pocket PC that we are carrying today is at least 2 to 4 GB RAM and at least 30-40 GB memory. Okay, so then clinical research. Clinical research, yes, it has great future, but not everybody's cup of tea. Maybe 100 में से कोई एक dental surgeon होगा जिसका इतना research bent of mind होगा, so they can think of going into that. Then as insurance advisor, इंडिया में नहीं है स्कोप. ये वेबसाइट वाले कुछ भी लिख देते हैं, क्योंकि इंडिया में केवल 2 कंपनियां आज की तारीख में डेंटल इंश्योरेंस ऑफर कर रही हैं, एंड द प्रीमियम इज सो डैम हाई दैट नोबडी ऑप्ट्स फॉर इट एक्सेप्ट अनलेस द प्रीमियम इज टू बी पेड बाय देयर कंपनी. ठीक है. देन कैरियर एज ए डाइटिशियन भी उन्होंने लिस्ट किया हुआ है. या डाइटिशियन करना है तो होम साइंस में BA वाज अ बेटर ऑप्शन. नहीं, इतना पैसा क्यों खर्चा किया, इतना पैसा, टाइम, टॉर्चर. BA होम साइंस तो पास हो ही जाते हैं. नहीं, चलो. तो मेरे हिसाब से जो मेरा टेक है, पर्सनल टेक, आई हैव प्रैक्टिस्ड फॉर द मेजर पार्ट ऑफ माई लाइफ एंड आई यूज्ड टू लव प्रैक्टिसिंग. ठीक है. मेरे जिन फ्रेंड्स ने मुझे एडवाइस दी थी कि यहाँ ज्वाइन कर लो, वो जब मिलते हैं मैं आज भी गाली देता हूँ. कहाँ फंसवा दिया. मुझे कहा गया था कि छुट्टियाँ बहुत होती हैं. तो कोई छुट्टी नहीं होती यार. इससे प्राइवेट कॉलेज में कहीं ज़्यादा छुट्टी होती थी मेरी. जब मर्जी नहीं आता था, कोई कुछ कह नहीं सकता था मुझे. आई यूज्ड टू एक्ट लाइक ए किंग. द मैनेजमेंट यूज्ड टू एक्चुअली एंटर बिफोर मी टू कॉलेज. मैं मैनेजमेंट पहुँचता था 10:30 बजे, मैं पहुँचता था कॉलेज 11 बजे. So, chalo. Now, I told you I actually feel quite strongly about dental practice. So, major part of my lecture is going to focus on how, when, why, and tips about that. Now, you are trained to be a dental surgeon. जो आपकी formal training है 5 साल की, वो dental surgeon बनने के लिए हुई है, जॉब करने के लिए नहीं. आपकी प्रैक्टिस MHA करने के लिए नहीं हुई है ट्रेनिंग. Provided you have been well trained. If you are not well trained, then there are opportunities to get well trained, provided you want to become successful in your career as a dental surgeon. Now, बहुत बड़ा सवाल आता है पास होने के बाद, कहीं जॉब ढूंढें या अपनी क्लिनिक खोल लें. I was little lucky because my father was a dental surgeon. He had practiced his whole life, and from class 5 to class 8, I had worked in his clinic as an assistant. I used to get 5 rupees a month, you know. ठीक है. और वो 5 रुपये मुझे एक्चुअली आज तक हाथ में कभी नहीं आया. नोशनल था कि 5 रुपये मिलेंगे. तो दैट इज हाउ आई डेवलप्ड द लव फॉर डेंटिस्ट्री. ओके. एंड बिलीव इट और नॉट, जब हमारे टाइम में CPMT होता था, जब उसका फॉर्म भरा तो मेरी फर्स्ट चॉइस थी BDS. मैंने सेकंड चॉइस MBBS भरी थी. और अगर मैं MBBS भरता फर्स्ट चॉइस तो मुझे कानपुर मिल रहा था मेरी रैंकिंग के हिसाब से. तो मैंने फर्स्ट चॉइस BDS भरी थी, बिकॉज भैया ने MBBS किया था. मैंने देखा था रात भर वहाँ पोस्टिंग लगती है, मतलब ज़िंदगी नरक हो गई थी जब से MBBS ज्वाइन किया था भैया ने। 1 साल आराम से निकला था, अगले साल से नाइट ड्यूटी, ये वो अवार्ड, दुनिया भर का जाम। तो मैंने कान पकड़ा, मुझे नहीं करना MBBS, एंड प्लस आई वॉज क्वाइट स्केयर्ड ऑफ एक्चुअली सो मेनी सब्जेक्ट्स। तो what to do after passing BDS? I believe at least 1% of you might be lucky as me, having a parent or a guardian running a dental practice. Remaining 99% will be in the second category, first dental surgeon in family or second dental surgeon in family, with first one not knowing what to do. मेरी राय है, go to work with a senior or corporate. That will have several advantages for you. बहुत कम तनख्वाह मिलेगी, हो सकता है ना मिले. Let's talk about advantages and disadvantages. हो सकता है ना तनख्वाह मिले. मैंने अपने कैरियर में 2013 तक मैंने बताया मैंने क्लिनिक एक्टिवली की है. मैंने फ्री से लेके 20,000 रुपये तक में BDS रखे हुए हैं. ठीक है. और जो बहुत अच्छे थे उनको इवन कट ऑफर कर देता था कि जो काम करते उसमें कट तुम्हारा, क्योंकि ज़्यादातर तो ऐसे थे जिन्हें मैं पेशेंट छूने भी नहीं देता था. दे यूज्ड टू जस्ट स्टैंड एंड ऑब्जर्व, उससे ज़्यादा उनका कोई रोल नहीं होता था. Pros, the advantages: no investment on your part, regular patient inflow because you are working in a running dental clinic or working in a corporate setup like Clove Dental earlier being managed by our friend, my friend Dr. Puneet. Then exposure to all sort of cases. You learn management of all sort of cases. आपके पास कुछ भी काम सीखने के 2 तरीके होते हैं. जैसे अभी मैं डॉक्टर पवित्र से बात कर रहा था इम्प्लांट्स के बारे में. ही वॉज सिटिंग जस्ट नेक्स्ट टू मी. इम्प्लांट्स के बारे में मैंने इम्प्लांट शुरू किए थे 1998 में. 97 में प्रैक्टिस शुरू की थी, 98 में पहला इम्प्लांट डाल दिया था. कैसे डाला? आई कॉल्ड माई अंकल फ्रॉम दिल्ली. माई अंकल इज ऑल्सो डेंटल सर्जन इन दिल्ली, राइट नाउ प्रैक्टिसिंग इन नोएडा, ऑलमोस्ट रिटायर्ड. ही इज 78 now. So I called him. He came with his armamentarium and everything. पेशेंट में 2 इम्प्लांट लगने थे. पहला उन्होंने लगाया, दूसरा मैंने लगाया. नेक्स्ट पेशेंट के लिए मैंने अपने फ्रेंड को बुलाया, रायपुर में प्रैक्टिस कर रहा है इस समय. पहला इम्प्लांट उसने लगाया, दूसरा तीसरा इम्प्लांट दोनों मैंने लगाया. धीरे धीरे सीख गए. तो 2 तरीके होते हैं सीखने के. या तो आप किसी के साथ काम करके सीखो, साथ काम करके सीखोगे तो बेटर सीखोगे बजाय कि कोर्स करके सीखने के, क्योंकि कोर्स में आपको डमी मॉडल्स में काम कराया जाएगा. कोर्स आर इम्पॉर्टेंट. आई हैव डन अ कोर्स ऑन इम्प्लांटोलॉजी इन 1994, 93 और 94, जस्ट आफ्टर माय ग्रेजुएशन. तो कोर्स से आपको बेसिक्स पता लगते हैं. बट अनलेस यू डू हैंड्स ऑन विद अ फ्रेंड और रिलेटिव और मेंटर, you don't get to know the nuances of or final aspect of that particular thing. जब मैंने दूसरा इम्प्लांट लगाया था अपना, मुझे याद है, it was in second molar area. Okay, second molar area में मेरा फ्रेंड मेरे साथ था. वो बोलता था एंगुलेशन चेंज कर, एंगुलेशन चेंज कर. मैंने नहीं चेंज किया. मैंडिबल की एनाटॉमी में भूल गया था. मैंडिबल यहाँ पे हॉलो होता है. I ended up with a perforation on the lingual aspect. उसके बाद से कभी नहीं हुआ, वो एक ही हुआ. बट बिकॉज माई फ्रेंड वॉज देयर, ही इमीडिएटली आस्क्ड मी टू विथड्रॉ द इम्प्लांट, पुट द ग्राफ्ट एंड अगेन पुट द इम्प्लांट इन विद लेसर लेंथ. ठीक है. तो यू विल लर्न व्हेन यू आर वर्किंग विद अ मेंटर अंडर समबडी. सो डोंट सी द मनी एस्पेक्ट इनिशियली. आप जब तक आपने BDS किया क्या कमा रहे थे? कुछ नहीं, जीरो. You are a total expense on your family. Don't mind, your parents won't mind you being expense for another 2 years. लेकिन जब प्रैक्टिस में बैठो तो इस लायक होके बैठो कि सब तरह का केस मैनेज करो. Okay, so don't see at this part, see at these advantages. Starting your own clinic, advantages. You are the boss. It is your own clinic. Whenever you want, you can just pull the shutter down, put the lock, and put a notice. From this day to this day, clinic will remain closed. खत्म बात. कोई नहीं बोलने वाला क्यों बंद की, क्योंकि लॉस तो आपका ही है. You get recognition. कोई अपनी क्लिनिक खोली है, रिकॉग्निशन तो मिलेगा ही. Then you get to plan your own treatments. Higher profits, sense of ownership. Disadvantage, initial investment is quite high, then growth is slow, and you have to take a long list of licenses. अभी आएंगे उसके बारे में. Plus another cons which I have not mentioned, which I discussed in the last slide in quite detail. Unless you have worked with a mentor for some time, you don't know what to do with quite a few of your patients. You end up mismanaging them, and any mismanagement, one satisfied patient will bring you 10 patients. One dissatisfied patient or unsatisfied patients, unhappy patient will take away 100 patients. So we have to avoid making any patient unsatisfied. There is no problem in calling somebody if you don't know what to do. Call your friend, call your teacher, call your mentor, call your senior. कोई बात नहीं, उस पेशेंट में हमने पैसा नहीं बनाया, कोई दिक्कत नहीं, लेकिन we should not get a bad name. चलो, starting your own clinic. पहली चीज important, location. लोकेशन में बहुत इंपॉर्टेंट आता है. बहुत सारे मैंने कोरा.com एक है, आई केम अक्रॉस दैट. मेरे बगल में 3 डेंटल क्लिनिक है. क्या मैं क्लिनिक खोलूं? एक कहानी सुनाता हूं. मेरा फ्रेंड है रायपुर में, मैंने जिसका पहले भी नाम लिया था, मेंशन किया था इम्प्लांट्स के बारे में. ही स्टार्टेड हिज प्रैक्टिस इन द हार्ट ऑफ सिटी, next to 2 major clinics. One was a leading general surgeon, laparoscopic surgeon of the area, and other was Agrawal Dental Clinic, okay, मुझे भी नाम याद है, having 4 chairs and leading dental practitioner of that area. उसने उस एरिया में जब उसकी जीरो इनकम थी, 27,000 रुपये महीने पे, मुझे अभी भी फिगर उसकी याद है, 27,000 रुपये महीने पे 2 चेयर लगाने भर की जगह ली, 2 चेयर लगाई, एक छोटा सा वेटिंग, एंड स्टार्टेड हिज क्लिनिक. जहां पे पेशेंट आ रहा है, दैट इज अ जोन वेयर पेशेंट इज ऑलरेडी कमिंग. क्लिनिक इसलिए खुली हुई है क्योंकि वहां पेशेंट है उस एरिया में, इसीलिए तो क्लिनिक खुली हुई है. एक छोटा सा सर्वे करने की जरूरत है कि क्लिनिक को खुली हुई है वो चल रही हैं या नहीं. अगर सारे खाली बैठे हैं देन देयर इज समथिंग रॉन्ग, लेकिन अगर चल रही हैं, I assure you, if you do good work, keep your rates reasonable, you will have a good practice. But it will take time. Investment, minimum 4 लाख, no upper limit. 1 करोड़ 2 करोड़ जितना हो सब लग सकता है डेंटल क्लिनिक में, ठीक है. कल डॉक्टर टिक्कू ने बताया चेयर जो है 1.5 लाख से लेके 20 लाख तक की आती है ना. 20 लाख नहीं, एक्चुअली 40 लाख की चेयर भी आती है. You just have to have money. ठीक है. इंडियन चेयर आज की तारीख में 8-9 लाख की आ रही हैं, तो इम्पोर्टेड चेयर की तो आप बात ही छोड़ दीजिए. पार्टनरशिप और इंडिविजुअल सेटअप. इंडिया एक अनोखा कंट्री है जहाँ पे कि हर आदमी अपना बिजनेस खुद करना चाहता है, स्पेशली प्रोफेशनल. हम लोग को डर लगता है पार्टनरशिप करने में कि धोखा होगा. यू सी द वर्ल्ड. अब आज का टाइम और जब मैंने प्रैक्टिस की थी वो टाइम डिफरेंट है. आज के टाइम पे ईच एंड एवरी कॉर्पोरेट चेन इज स्टार्टिंग देयर ओन हॉस्पिटल्स एंड क्लिनिक चेन. आपके खुद के सिटी में जिस भी सिटी से आप देखो, कम से कम 1 या 2 कॉर्पोरेट डेंटल चेन्स आ चुकी हैं. आई की कॉर्पोरेट चेन्स आ चुकी हैं, सो मेनी ऑफ देम. कॉर्पोरेट हॉस्पिटल्स आ गए हैं. It is always better in today's setup to open a partnership clinic. Have 2 or 3 partners. The problem is partnership में जब friends के बीच में partnership होती है especially, we forget about finer points. You have to write down everything. Keep everything in black and white. Make a legal document out of it so that Everybody's role, responsibility, liability and profit share is defined. फिर झगड़ा नहीं होगा. अगर आप कोई भी बाहर की क्लिनिक देखो, हमेशा खन्ना, this and associates. Advantage, anybody can take leave any time. भैया क्लिनिक फुल टाइम जॉब है. अगर आप 3 दिन के लिए नहीं हो, 3 दिन का लॉस है. वो लॉस एक्चुअली 3 दिन का नहीं है, 6-8 दिन का है. क्योंकि जब आप वापस आ गए तब भी लोगों को पता नहीं है कि आप वापस आ गए. सो कंटिन्यूटी इज वेरी इंपॉर्टेंट. इट इज ऑलवेज बेटर टू ओपन पार्टनरशिप. देन यू हैव टू टेक ऑल द परमिशन लाइसेंसेस रिक्वायर्ड. इसकी लिस्ट छोटी सी मैं जस्ट 1 सेकंड में दिखा दूंगा. देन रिमेंबर यू आर इन सर्विस इंडस्ट्री एंड join local doctors body in your area. Very important. Location should be easily accessible. Parking should be there, whether in town or city. Now that is a personal choice. मैंने कल इस टॉपिक के बारे में अपने पीजी स्टूडेंट से बात की थी. उनका ओपिनियन थी कि सर जहाँ पे जोमेटो से खाना नहीं आता वहाँ सेटल होना तो बड़ा मुश्किल है. तो इट इज़ अ पर्सनल चॉइस. ठीक है. बट एक पर्सनल मैं अपना एक्सपीरियंस बताऊँ. मैंने प्रैक्टिस शुरू की लखनऊ में. मेरा एक फ्रेंड है, उसने प्रैक्टिस शुरू की एक पास के स्मॉलर सिटी में. ठीक है. इन 5 years he knew everybody in his city. He was in the who's who list. After 5 years nobody knew me. I knew nobody. ठीक है, except a small circle maybe. So both have their advantages and disadvantages. In a commercial center or residential area, it depends what type of practice you want to build. You want to build a 9 to 5 practice, go for commercial center. You will do very well. Expenses will be a little high initially, but you will be able to run a 9 to 5 practice. थोड़ा सा time लगेगा. Residential area में you might start earlier. Expenses will be lesser, but you will be static. बहुत ज़्यादा growth residential area में कभी नहीं होगी. Whether to open near a successfully running clinic, इसके बारे में हम डिस्कस कर चुके हैं, दोबारा नहीं करेंगे. इन्वेस्टमेंट, सेट योर ओन लिमिट, डोंट ओवर स्ट्रेच. सबसे इंपॉर्टेंट 6 महीने का रनिंग एक्सपेंस जेब में लेके चलो. कोई भी बिजनेस वेंचर, कोई भी रेस्टोरेंट, कोई भी क्लिनिक, कुछ भी, कोई भी वेंचर, स्टार्टअप टाइम मिनिमम 6 months to 1 year होता है. 6 महीने से 1 साल का पैसा आपकी जेब में होना चाहिए. आप उतना रेंट दे पाओ, बिजली का खर्चा दे पाओ, सैलरी दे पाओ और अपना खर्चा चला पाओ. पॉजिटिव एस्पेक्ट इज एट दिस स्टेज मोस्ट ऑफ अस आर अनमैरिड. तो लाइबिलिटी बहुत कम होती है. तो लाइबिलिटी कम होती है तो ये झेला जा सकता है. बट वी हैव टू कीप इन माइंड, अगर हमने 10 लाख रुपये प्लान किया है तो 1.5-2 लाख रुपये बचा के रख लो, ताकि 6 महीने तक टेंशन ना हो दिमाग में कि अगले महीने बिजली का बिल कैसे देंगे, किराया कैसे देंगे. पार्टनरशिप और इंडिविजुअल, मोस्ट इंपॉर्टेंट, हैव अ लीगल डॉक्यूमेंट ड्रॉन. देन परमिशंस एंड रजिस्ट्रेशंस रिक्वायर्ड. DCI registration, CMO or Clinical Establishment Act registration, depending on where you are practicing. Some states have adopted CEA in toto. That means even an individual clinic has to be registered. Some states like Uttar Pradesh, Punjab, Haryana, up to 49 beds and small clinics don't need to have CEA. They can just take a permission from CMO and start practicing. Keep your DCI registration up to date. Pollution Control Board registration, AERB registration, these are must. किसी भी दिन आपके यहाँ क्लिनिक पर चालान हो सकता है अगर आपका AERB रजिस्ट्रेशन नहीं है, क्योंकि एक्सरे क्लिनिक के बिना आज की तारीख में डेंटल क्लिनिक इज नॉट इमेजिनेबल. लोकल अथॉरिटीज परमिशन, लाइक इन उत्तर प्रदेश वी हैव नगर निगम रजिस्ट्रेशन. दिल्ली ऑल्सो आई नो हैज नगर निगम रजिस्ट्रेशन. बाकी स्टेट्स का मुझे पता नहीं है. लेबर लॉ कंप्लायंस. नाउ दिस कम्स इवन इफ यू हैव 1 वर्कर. एक छोटा सा रजिस्ट्रेशन होता है, 1000-1500 रुपये लगता है, एंड इट वर्क्स फॉर लाइफ टाइम. तो बहुत बड़ा खर्चा नहीं है, लेकिन जिस दिन आपके यहाँ लेबर के ऑफिसर आके खड़ा हो जाएगा, वो कम से कम 10,000 रुपये लेके जाएगा घूस में. तो बेटर टू गेट इट डन. देन एनी अदर रजिस्ट्रेशन डिपेंडिंग ऑन वेयर यू आर प्रैक्टिसिंग. इसीलिए मैंने लिखा था ज्वाइन लोकल डॉक्टर्स बॉडी, क्योंकि लोकल डॉक्टर्स बॉडी जब ज्वाइन की होगी तो वहाँ ये सब डिस्कशन होते रहते हैं कि क्या नया है, क्या नया लॉ आ गया है. ओके, देन चेंज योर एटीट्यूड. क्लिनिक के इनॉग्रेशन के पहले जो नक्शेबाजी का एटीट्यूड इंटर्नशिप में है ना, जो पेशेंट देखना है देखेंगे, जो पेशेंट नहीं देखना है नहीं देखेंगे, वो छोड़ना पड़ता है. यू आर इन अ सर्विस इंडस्ट्री, यू आर गोइंग टू सर्व योर पेशेंट, सो चेंज योर एटीट्यूड. बट चेंजिंग एटीट्यूड डज नॉट मीन कि जो पेशेंट कह रहा है वो करेंगे, नहीं. वी विल स्टिक टू आवर प्रिंसिपल्स. देयर इज नो पॉइंट, नो शेम एंड नो बैड नेम इन टर्निंग अवे अ पेशेंट. कोई खराबी नहीं है, पेशेंट को दरवाजे से बाहर भेज सकते हो. भैया, यू आर नॉट माई पेशेंट, योर डिमांड्स डोंट सूट मी, आई एम साइंटिफिकली साउंड पर्सन, आई नो what is good for you. If you don't agree with me, go to somebody who will do it. I won't do it. Then satisfaction of client is of paramount importance. एक satisfied patient 10 patient लाता है. Now, खोल ली क्लिनिक, अब क्या? 5 स्टेज होते हैं क्लिनिक के. मैंने जब छोड़ी थी, I was in almost between growth and maturity phase. Introduction, आपने अभी भी क्लिनिक खोली है, 2-3 साल लग जाते हैं कुछ स्टेबिलिटी आने में. कि आपको मालूम है, चलो आज 6 पेशेंट आने हैं, वो 6 में से 5 तो आ ही जाते हैं. 2 to 3 years period. Average age group 25 to 27 years, age group of a dental surgeon, provided you have taken admission at a fair amount of time and done passed without any much glitches. Learn to be patient and learn to wait. मैंने क्लिनिक स्टार्ट की थी 97 में, till 98 end. Day used to be days. सुबह 9 बजे से 2 बजे तक क्लिनिक खोलते थे और 4 बजे से रात के 9 बजे तक. मैं मेरी बीच में वेटिंग था. लेफ्ट हैंड पे मेरा चैम्बर था विद अ चेयर, एंड राइट हैंड पे मेरी वाइफ का चैम्बर था, गायनेकोलॉजिस्ट. दे यूज्ड टू बी डेज. सुबह से शाम हो गई, एक भी पेशेंट नहीं आया, ना मेरा ना नमिता का, खाली बैठे हुए हैं. तो उस टाइम पे वो जो एक डब्बा कंप्यूटर था 1 GB रैम वाला, वो बड़ा काम आता था. एक मॉडेम लगा हुआ था हमारे पास 14400 kbps का, जो कि की करके डायल करता था. डायल अप कनेक्शन हुआ करता था उस टाइम पे, तो उस पर हम लोग कुछ सर्च किया करते थे. तो लर्न टू वेट. ऐसा नहीं होगा क्लिनिक खोली, पेशेंट की लाइन लग गई. और एक चीज़ बता दूं, आपका इमीडिएट रिलेटिव आपके पास आ जाएगा शुरू में, लेकिन जो स्लाइटली डिस्टेंट रिलेटेड, सेकंड कजन्स, मामा, चाचा, नानी, दादा, ये सब जो है ना, ये आएंगे आपके पास 5 से 8 साल बाद. इससे पहले कोई नहीं आएगा. ये खुद के एक्सपीरियंस से बता रहा हूँ, उससे पहले कोई नहीं आएगा. सो डोंट थिंक कि आपके बहुत सारे रिलेटिव्स हैं तो आपकी क्लिनिक चलेगी ना. शुरू में नहीं आएंगे. दे विल सेंड देयर वर्कर्स टू यू. ये मेरा और मेरी वाइफ दोनों का एक्सपीरियंस है. दे विल सेंड देयर वर्कर्स टू यू फॉर ट्रीटमेंट. जब उनका ट्रीटमेंट ठीक होगा तब उनको हिम्मत बनेगी आने की. वेट, बी देयर फॉर लॉन्ग हॉल. इसीलिए मैंने कहा है कि थोड़ा बैकअप बचा के चलना. सारा का सारा पैसा शुरू में मत लगा देना, सो दैट यू कैन बी देयर फॉर लॉन्ग हॉल. सेकेंड स्टेज, ग्रोथ फेज, 2 से 12 साल. एवरेज एज 27 to 40 years. अब आपका नाम बन चुका है, पीपल नो दैट यू आर डूइंग गुड वर्क. सो इनिशियल जब मैंने प्रैक्टिस स्टार्ट की थी, मेरे क्लिनिक में अगर 10 पेशेंट आते थे, 10 में से 1 पेशेंट काम कराता था, बाकी सब खाली चार्जेस सुन के चले जाते थे. जब मैंने प्रैक्टिस बंद की, उस समय 10 में से 10 काम कराते थे. हालांकि आते 10 नहीं थे, 6 आते थे, लेकिन 6 के 6 काम कराते थे. आई एम नॉट इंटरेस्टेड कितने मैं कंसल्टेशन कर रहा हूँ. कंसल्टेशन इज पीनट्स इन अ डेंटल प्रैक्टिस. Actual work you do is actually your cream and butter or caviar or whatever you say. So there is a good patient flow at this stage with good money, and there is steady increase of income. क्योंकि जब पेशेंट ज़्यादा आते हैं तो इनकम 2 वजह से बढ़ती है. एक तो नंबर ऑफ पेशेंट बढ़ रहा है, दूसरे आपके चार्जेस बढ़ते चले जाते हैं। जो इनिशियल फेज के चार्जेस होंगे इस समय आप उससे कम से कम 6 गुना चार्ज करना स्टार्ट कर दोगे। इनिशियल RCT, I did my first RCT in my practice in 97 for 250 rupees। 98 में मैंने चार्ज बढ़ा के 800 रुपये कर दिए थे, ठीक है। और जब मैंने प्रैक्टिस बंद की 2012-13 में, आई वॉज चार्जिंग 4,000 to 5,000 फॉर RCT। एंड माइंडेड दैट RCT didn't use to cover the build-up का मैं अलग से 2,000 रुपये चार्ज करता था, ठीक है। तो चार्जेस विल कीप गोइंग, सो देयर विल बी स्टडी इंक्रीज ऑफ इनकम, बट एट दिस स्टेज ऑल्सो यू आर यंग, सो द स्पिरिट ऑफ कंपटीशन इज अलाइव। यू वांट कि पेशेंट मेरे पास रहे, दूसरे के पास ना जाए। अब इसके बाद की जो स्टेज है, आप मैच्योर हो चुके हो, यू आर 40 to 50 years, जान देना बंद हो जाता है, ठीक है यार, जितनी जान देनी थी दे ली, लड़ ली बहुत। नाउ देयर इज अ स्टडी फेज। You, at this age, you enjoy the premium and most important, plan for your retirement. Because at this stage, lot of money is flowing in. Okay. So you are established as a long-standing dental surgeon. You don't seek patients anymore. एक हमारे प्रोफेसर थे यहीं KGMC के, वो कहा करते थे डॉक्टर की लाइफ में 3 स्टेज होती हैं। पहली स्टेज में डॉक्टर जो है पेशेंट के पीछे भागता है, दूसरी स्टेज में पेशेंट और डॉक्टर साथ साथ भागते हैं, और तीसरी स्टेज में पेशेंट आगे, डॉक्टर आगे आगे भागता है, पेशेंट पीछे पीछे भागता है। यहीं सर्जरी के प्रोफेसर थे हमारे, आई थिंक ही इज़ नो मोर नाउ, या उन्होंने कहा था ये अपने लेक्चर में। तो ये स्टेज जो है, ये थोड़ा थोड़ा साथ साथ भाग रहा है, थोड़ा थोड़ा पीछे भाग रहा है पेशेंट, वो स्टेज है ये। यू डोंट सीक पेशेंट, ठीक है, जो आ रहा है आने दो, जान नहीं देनी है। यू हैव हाई ब्रांड वैल्यू, आपका नाम एक सोसाइटी में established नाम है। You have acquired all the armamentarium to have good skill. Then you are financially stable. That's why I said plan for the retirement. This is the right time to plan for retirement, because if you don't plan now, in future you won't have money to plan. And major expenses of your life come after this stage. Then this is the right time to infuse future skill set in your clinic. फ्यूचर स्किल सेट से क्या मतलब है? अपने साथ में 1, 2, 3 और डेंटल सर्जन्स को फ्रेश पास आउट को एसोसिएट करो, प्रोवाइडेड यू डोंट वांट द क्लिनिक टू गो इनटू नेक्स्ट स्टेज एंड स्टे इन दिस स्टेज। क्योंकि अगर इंड्यूस नहीं करोगे तो आपकी क्लिनिक जो है ना, वो डाउनफॉल शुरू, इसके बाद डाउनफॉल शुरू होना है। सैचुरेशन फेज, अब आपकी प्रैक्टिस 20-25 साल पुरानी हो गई है, आपकी उम्र मेरी जितनी हो गई है, मैं इस समय 53 ईयर्स का हूँ, ठीक है। तो एक ज़िंदगी से जो है ना वो हो जाता है कि यार बहुत काम कर लिया, इसीलिए ज़रूरी है फ्रेश स्किल सेट को इन्फ्यूज़ करना। नाउ देयर इज इंक्रीज इन एक्सपेंसेस, बच्चे बड़े हो गए, बच्चों की पढ़ाई है, शादी है, बच्चों को सेटल करना है, और समहाउ जैसे जैसे टाइम पास होता जा रहा है, बच्चों की रिस्पॉन्सिबिलिटी कुछ ज़्यादा लेने लगे हैं, पेरेंट्स ज़्यादा लेने लगे हैं, ये फैक्ट है। हमारे पेरेंट्स ने क्या किया था हमारे लिए? कुछ नहीं, वो किया था, ऐसा नहीं है, आई एम नॉट सेइंग कि कुछ नहीं किया, बट अब आज की तारीख में हम ये भी सोच रहे हैं कि बच्चा जब बड़ा होगा, उसकी शादी होगी तो रहेगा कहाँ? अरे हमारे पेरेंट्स ने तो कभी नहीं सोचा कहाँ रहेगा, अपने आप बनाएगा रहेगा, वो कहाँ रहेगा, उसके लिए अलग बेडरूम होना चाहिए, अलग पूरा किचन होना चाहिए, सब कुछ होना चाहिए, मतलब वी गिव टू मच थॉट टू इट। माई सन इज इनटू रेस्टोरेंट बिजनेस, तो हम उसका एक रेस्टोरेंट स्टार्ट कराया, ठीक है, उसने बंद कर दिया कोविड के पहले, उसके बाद अब दूसरा स्टार्ट करा रहे हैं, उसमें भी पैसा लगा रहे हैं। तो मेरे पेरेंट ने क्लिनिक जब स्टार्ट की थी तो केवल डेंटल चेयर के पैसे दिए थे, और डेंटल चेयर मेरे टाइम पे मैंने डेंटल चेयर ली थी, पहली मैनुअल चेयर ली थी, केवल 40,000 रुपये की आई थी। दैट इज़ ऑल द हेल्प आई टुक फ्रॉम माई फादर, ठीक है। बाकी जो है वो नमिता ने यहाँ से MDS किया था, MD किया था गायनी में, सो शी यूज्ड टू गेट सैलरी, तो 1,80,000 वो बचाए हुए थे, उसमें से लगा के वी स्टार्टेड आवर प्रैक्टिस। जगह जिनसे ली थी उन्होंने शायद 5.5 लाख की दी थी, हमारे पास 5 लाख रुपए थे उनको देने के लिए। हमने उनसे कहा बाकी 50,000 तो हम इंस्टॉलमेंट में आपको दे देंगे। वो भी मान गए, ठीक है, डॉक्टर ने कहाँ जाएंगे। हमने धीरे धीरे करके 1 साल में उनको 50,000 रुपये दे दिए। और बाकी जो इक्विपमेंट था उसके लिए बैंक ऑफ इंडिया से लोन लिया था, विच टुक अबाउट 3 years टू कंप्लीट। सो increase in expenses due to children growing up, this is a major factor for our generation, and I am sure it will be an even major factor for your generation, क्योंकि वो धीरे धीरे बढ़ता जा रहा है। Increase in competition, क्योंकि जब आप अपने ग्रोथ फेज में थे और मैच्योरिटी फेज में थे, उस समय जो फ्रेश पास आउट आए थे जिन्होंने आपके आसपास क्लिनिक शुरू की थी, अब वो अपने ग्रोथ और मैच्योरिटी फेज में पहुंच रहे हैं, आप सैचुरेशन फेज में हो। सो मेनी ऑफ योर पेशेंट विल स्टार्ट गोइंग देयर, सो कंपटीशन बहुत ज़्यादा हो जाएगा। स्टिल नॉट टू लेट टू इन्फ्यूज फ्रेश स्किल सेट, क्योंकि आपका मोर और लेस नंबर ऑफ पेशेंट वही है। तो अनलेस दे से कि कुछ नया है यहाँ पे, दे सी कि कुछ नया है यहाँ पे, वो मूव करेंगे। तो स्टिल नॉट टू लेट। नेक्स्ट इज डिक्लाइन। You are nearing 60 or you are 60 plus. Now this is a very individual thing, because I have seen practitioners in Lucknow 70 years and practicing well. Okay. But this phase does come 25 नहीं तो 35 साल के बाद, 60 नहीं तो 70 साल की एज में। क्यों? क्योंकि डेंटिस्ट्री जो है, डेंटल प्रैक्टिस, it is a very skill demanding practice, requires lots of attention. I really wonder, there are my seniors practicing in this city, this very city, practicing from 9 a.m. to 6-7 p.m. continuously, taking a lunch break in between for 1 hour. मतलब इतना कंसंट्रेशन मैं जब 2012-13 में प्रैक्टिस कर रहा था, मेरे में नहीं था। के कहाँ भाग रहा है? अच्छा, हाँ, तो इतना मेरे में नहीं था। अगर 2 घंटा कंसंट्रेशन से काम कर लिया, अगर 3 RCT 2 RCT ओपन कर ली, 2-3 क्राउन कटिंग कर ली, तो आई यूज्ड टू नीड अ ब्रेक। तो ये इंडिविजुअल के ऊपर है, कितना काम कर सकते हो, कितनी देर अपना अटेंशन फोकस कर सकते हो। और एक और चीज़ है, कितना अपने काम की क्वालिटी को ख़राब होने दे सकते हो। Because when your attention level goes down, your work quality also goes down. इसीलिए फ्रेश स्किल इम्पॉर्टेंट है कि आप अपना उस स्टेज पे पहुंचने के पहले अपने साथ 2-3 एसोसिएट डेंटिस्ट रखो, who will look after your practice. Hand over your practice gracefully and retire. क्योंकि अल्टीमेटली आपका नाम ही चलेगा आगे। Money is not everything in life, name is also a lot. So options: close down, hand over to fresh skill. तो हैंडिंग ओवर जितनी जल्दी शुरू हो उतना अच्छा इंटीग्रेशन होता है, जितना लेट स्टार्ट करोगे उतना खराब इंटीग्रेशन होगा। नाउ एक ऑप्शन मेरे हिसाब से और है, अपार्ट फ्रॉम आर्मी एंड गवर्नमेंट जॉब, ओवरसीज। बट व्हाट आई फाइंड, जब हम लोगों ने पास किया था हमारे लिए बहुत अच्छा ऑप्शन था, बिकॉज इट वॉज क्वाइट ईजी टू गो अब्रॉड एट दैट टाइम। आज की तारीख में बहुत मुश्किल हो चुका है, बिकॉज आप फर्स्ट पार्ट कर लोगे एंट्रेंस एग्ज़ाम, पैसे खर्चा कर दोगे, कोई बात नहीं, DDS करना पड़ा, 1 करोड़ भी खर्चा कर दिया। फादर के पास, पेरेंट्स के पास पैसा है, खर्च कर दिया 1 करोड़। बट आर यू श्योर यू विल पास? सेकेंड, वीज़ा, सबसे ज़्यादा डिफिकल्ट होगा वीज़ा प्रोसेस। कनाडा में इवन इफ यू पास you get but license to practice will be given only when you have a permanent residency which is to be sponsored by a local. कहाँ से लेके आओगे? जब तक परमानेंट रेजिडेंसी नहीं होगी आपको कनाडा में प्रैक्टिसिंग का लाइसेंस नहीं मिलेगा। मेरे से 3 साल जूनियर था एक धारवाड़ में, ही वॉज डूइंग BDS, इंटर्नशिप कर रहा था जब मैंने पास आउट किया है। He slogged for 11 years in Canada, 11 long years before he got his practice license. अभी 5 या 6 साल पहले उसको लाइसेंस मिला है, और जब मैंने पास किया था तब वो इंटर्नशिप कर रहा था. I passed in 96. ठीक, तो 11 साल उसने घिसा है, पेट्रोल पंप पे काम किया, टैक्सी चलाई, क्या नहीं किया, मतलब यू नेम द जॉब ही हैज डन इट. तब कहीं जाके उसे पीआर मिली, और पीआर मिलने के बाद उसको लाइसेंस मिला. एंड नाउ ही इज रनिंग अ गुड प्रैक्टिस इन कैलगरी. तो देखने में बहुत अट्रैक्टिव लगता है, 80 लाख की तनख्वाह, 40 लाख की तनख्वाह, बट नॉट दैट इजी unless you have somebody local there to support you. You have somebody local there, a good relative, a near relative to support you, who is willing to support you, you can go for that. But unless you have that, it is a very dicey situation. Because 10-11 साल अपने आप को support करके रखना, not easy. Punchline, no substitute for hard work. So you have to slog if you want to succeed in your life. खाली बैठना पड़ता है, बिना खाली बैठे कुछ नहीं मिलता है, स्पेशली अगर प्रैक्टिस में होते हो. जो हफ्ते में एक पेशेंट आया शुरू में, अगर उसको सेटिस्फाई करके भेजोगे, अपनी पूरी जान लगा दो उसके ट्रीटमेंट के लिए, वो कम से कम 5-6 और पेशेंट को लेके आएगा. एंड डोंट लुक एट मनी इनिशियली, डोंट लुक एट मनी, मनी विल कम. इसीलिए 6-8 महीने का रिजर्व लेके चलना है कि शुरू में पैसे का टेंशन ना हो. ठीक है? सो मेरे ख्याल से मैंने काफी ज्यादा टाइम ले लिया है. 1 घंटा हो गया होगा? नहीं, 35 minutes. Not bad. So thank you for listening. I hope I must have given a few take home points.
Thank you, sir. Thank you so much for this wonderful lecture. I would like to call upon Dr. Anmol Bagaria ma'am to please felicitate our speaker. Thank you, sir. Thank you, ma'am. Our next speaker for the day is Dr. Manu Dhillon. Sir is Professor and HOD, Department of OMDR, Divya Jyoti College of Dental Sciences and Research, Ghaziabad. Please put your hands together for Dr. Manu Dhillon, sir. Welcome, sir.
I'll use this only. A very good morning to all of you. At the onset, I would like to thank the organizers for giving me this opportunity. Since morning, I have been listening to lectures like implants, PRP, endodontic surgeries, maxillofacial surgeries. But after such lecture, I felt little familiar because sir is from oral pathology. Like sir said also, that oral medicine and oral pathology is very linked. Definitely it's very much linked, and sir also told one of the opportunity after BDS, that is forensic odontology. And sir is also here, Dr. Puneet Ahuja sir, I worked under him for quite a time, excellent administrator I must say. And sir also spoke about Dahawad. So I am currently, I'll introduce myself, I am currently working as professor and head in oral medicine and radiology department. Sir spoke about Dharwad, SDM, excellent college definitely, because I went there for 3-4 times for my fellowship. I did my fellowship from there. And under Dr. Ashit Acharya, he is BDS and he did a master's course from abroad, I think Australia, and he is excellent forensic odontologist. So definitely excellent college, excellent weather. It's very, I had a great experience. So today I'll be talking about forensic odontology. To be more precise, I'll be talking about age estimation on dental radiographs. So the topic for today's presentation is dental radiographic indicators are key to age estimation. And this is my college where I am working. We have dental college, this is the college, and we have other institutes as well in the premises. So definitely as human evolved, there is excellent and there is tremendous increase in human intelligence. Definitely it is very much positive, but there are negatives as well, because it also led to surge in war, terrorism, mass disasters, road traffic accidents, crime rates, and other dreadful diseases. In all such incidents, the identity of the disease or assailant or the cause of the death becomes very much important. Investigating the identity of unknown individual is the most important task in forensic medicine. So we all as dentists, we are investigating stuff definitely. We are investigating that is far much complicated. We are working on living beings. We are relieving pain of the patients. So we are investigators by birth as dentists. So forensic odontology is nothing different. It is also investigating, and we as dentists are already doing our part. So it's just an extension of dentistry. It is basically vital and integral part of forensic science that is most widely utilized for identification of living and deceased persons. Forensic is derived from a word. I'll give you a little introduction of forensic odontology. It is derived from a word forum. In Europe, Roman Empire, forum is a place which is called, which is in the usually used to be in the center of the city and where the people used to meet. And odontology, you all know, it's a study of the teeth. FDA defines it as a branch of dentistry which in the interest of justice deals with the proper handling and examination of dental evidence and with the proper evaluation the presentation of dental filings. We'll start with history. It is said that when Eve asked Adam to bite on that forbidden fruit, this is considered as the first bite on the apple. Fine. So it starts that at that time. But the earliest recorded case where teeth used for identification was of Lulia Paulina. She was assassinated, and the king there asked his soldiers to get the head of that the deceased one, so that he can identify the that she has died by examining her anterior teeth, because these were malaligned. So this is the first ever reported case of using forensic odontology. I won't say forensic odontology because this term was not used that time, but the teeth were used for identification of the deceased one. First dental evidence was presented in US court in 1849 in Vienna Opera House fire. Adolf Hitler was killed by Russians in 1945, I guess. I'm not very much sure. And he was buried there. Then later on there was some rumors that he fled with his wife. Then he was taken out from the grave, and his dentition was examined by his dentist because he was having periodontitis and there were so many. You can see the false teeth also. And he was taken out from the grave, and his dentist confirmed that this is the dentition of Hitler, and then he was identified. And there are numerous examples. Zia-ul Haq, the late president of Pakistan, was identified by his dentition because the body was severely mutated. Our own late Prime Minister, Mr. Rajiv Gandhi, was identified by his teeth. In World Trade Center, 20% of victims were identified using dental records. That's a very good number, 20%. In Asian tsunami, you would be surprised to know that 800 plus identified bodies, only near 800 bodies were identified, and 90% were identified by dental records. You have been listening to implants lecture as well in the previous lectures. So by implants placement also the bodies were identified, recognized. Saddam's son also, both the sons were identified using the dentition. And there are numerous applications of forensic odontology. Individual identification, there is mass disaster, dental malpractice, assessment of case of abuse. Day before yesterday only I was reading a news that boy, I won't say boy, he was a man of 30 years old I think. He attempted rape on a 16-year-old girl. And during the attempt, the girl bit on the cheek of that person. Then she approached the police and police caught the person by the bite mark on that person's cheek. That is the recent case, day before yesterday only. It was an incident happened in Pune. Fine. So there are numerous applications. However, it's in a budding stage in India. Intentionally or unintentionally, definitely we are using forensic odontology. You never ask a patient, if you are doing a practice, you never ask a patient's age in developing dentition. If the first molar is developed, first molar of deciduous, you would say the patient would be 6.5. And you say, what is the age? She'll tell or he'll tell, his parents will tell that he is 6.5. So unintentionally or intentionally, you are using age estimation on our day-to-day basis. And the last what I'll be talking about is age estimation. Fine. So it is an expertise in forensic medicine which aims to define in the most accurate way the chronological age of a person of an unknown age involved in judicial or legal proceedings. Now these words are very important, judicial and legal proceedings, right? I'll be talking about two things here, the chronological age and dental age. It's very important to note the difference between two. Chronological age is the number of years a person has lived, right? On the other hand side, dental age is usually based on the maturation of the teeth. So dental age, what you will be telling, chronological age is the actual age of the patient. That is the difference. But why do we want age estimation? Why it's required? It's not required. Why should we check the age of the patient? There are few reasons. There are few supportive things to support age estimation. First is living people who have no acceptable identification documents, like refugees. They have no documentation. There is no birth certificate. There is nothing they have. So it is used for refugees, adopted children of unknown age. For criminal cases, it is very much required. You would be knowing that if a boy or girl is less than 7 years of age, he or she is not criminally liable. But if it is less than 18 years, then she or he will have a case under Juvenile Act. But if he or she is adult, more than 18 years of age, he attains a majority status and will be treated by Indian Penal Code. Labor Acts. Age less than 14 years of age, children cannot work in factories. But if a person is 15 year or equivalent, he can work in as a laborer. Employment and marriage, as you know, the age of marriage, it should be more than 18 years of age. And verification of chronological age to civil rights and social benefits, because you cannot enter a government age if you are less than 18 years of age. Fine. In archaeological search also, age estimation is very much required. We all know this case when Mumbai was attacked, 26/11 terror attacks. Then the Ajmal Kasab was held by our security forces. Then his lawyer said that he is 17 years of age and he should be treated under Juvenile Act. There was a huge case. There were several hearings for that. Then the judge there ordered that Kasab be given a bone ossification test and dental examination by the expert to determine the approximate age. So this was a very good start by the judge that time, and he underwent dental examination test, and his third molars were fully erupted and the root formation was complete. It says that he cannot be less than 18 years of age. He is definitely more than 18 years of age, and he was sentenced to death after that. So there are so many examples which I can tell because of definitely the lack of time. I cannot give you all the examples. It's a very famous quote by dentition. This quote explains why teeth should be used as age estimation tool. What a nightmare. Bodies as of Negroes, blackened, heads carbonized, shrunk, and reduced to nothing, but only the teeth remained. This famous quote was made by Dr. Oscar Romadio, who is considered the father of forensic dentistry. He made this quote, or he told these lines after a fire in Paris where 160 members of Persian society died. Out of these 160, 148 were identified by their jewelries or by the belongings, but rest 30 who were not identified were identified by their dentists. Right? So these lines were given by Dr. Oscar at that time, but I have highlighted this, but only the teeth remained, because everything in the bodies were burnt so much that nobody can be definitely recognized or identifiable. So white tooth is used as the most prominent indicator for age estimation because it is very much durable. It is the most durable predictor of age. You note that teeth are enamel is almost 3 times more harder than bone. In extreme fire or extreme mass disasters, you cannot see the body parts. Bones also are severely mutilated. So, but the teeth usually remains. So that is an ideal indicator for age. If we talk about methods of age estimation, there are 3 methods: histological, biochemical, and morphological. Morphological is considered as the best method of age indicator there are so many systematic analysis and meta-analysis which proved that morphological method is the best method for age estimation. Under it comes direct observation, like I told you just now that we are already intentionally or unintentionally we are doing that already. And other is radiographic, which I will be focusing on in next 10 minutes. That is dental formation, dental eruption, and regressive changes. Right? This is the chart you must have seen in your first and second year's dental anatomy book. That nicely we can see initial calcification starts on 14th week and the canine root formation completes in 3.25 years. It's both for the maxilla and the mandible. So definitely if you take a radiograph and you see that the root formation is complete for canine, you can see that the child is more than 3.25 years of age. Similarly for adults, the initial calcification starts at birth and third molar completes at the age of 18 to 25 years. These are the different calcifications. This is a very simple example how you can determine age. You just have to take a radiograph of premolar. This is the most simple step. But definitely it's not very much accurate, but it's the most simple step. This is you can see here, this is the calcification. You can see if only the tip is calcified, you can see this is for the lower mandibular first premolar. The person would be of 3 years of age. If there is complete root formation, the crown formation, you can say the person is 7 years of age. Similarly, as the tooth progresses, you can identify the age of an individual. If the root is complete but there is no apical closure, it means that the person would be around 12 years of age. But if there is apical closure, the person is 13 years of age. Fine. This is just an example how easily you can identify age of an individual. But what happens if the tooth has erupted completely? Then you cannot see the development. You have to see the regressive changes. Like what are the regressive changes? Cementum apposition, deposition of secondary dentine. You can also see root translucency changes. This is another way for identification of age. Adhesion, there is root resorption. So these are the ways by which you can identify the age once the dentition is or the formation is completed. Now you would be surprised to know that we can estimate the age of prenatal age also we can estimate. We can estimate age of a fetus in utero by radiographs. Definitely live fetus you cannot, but aborted fetus you can estimate the age of a fetus as well. Then there are separate methods for children and adolescents, and for adults the methods are different. There are 2 broad classifications, area assessment and development of third molars, where Ajmal Kasab identification was done by the development of third molars. This is a radiograph. It's not very clear, I think, here, but yeah, you can see, it's not very clear, I think, but you can see initial calcification. This is a radiograph of a dead fetus taken. This is the maxilla, this is the mandible, and this is the development. Because of the calcification, we can say that the fetus was of 14-week in utero fetus. So you can also estimate the age of a fetus by a single radiograph. This is a 13-week in vitro uterus fetus where you can see the initial calcification. This is immediately after birth, the radiograph. You can see the mandible, you can see the multiple calcifications. But the second molar, if you can see here, is initial cusp formation is there. So it is just at the time of birth, the radiograph of a newborn child. These are the stages by which we can estimate the age of the prenatal and postnatal. These are the stages given by Cross and Jordan. You can see 10 stages here, 3 divided into 9 divided into 3 and 10 divided into 5 stages. So this is used for the estimation of prenatal thing. And then definitely age estimation of children and adolescents. If we talk about the accuracy of age assessment, it is best when the person is in developing dentition. Once the tooth is already developed, it is very difficult to estimate the correct age. Bias is long. So the accurate age by which you can estimate is between the birth and till the person turns 21. That is the best age to identify the age of a patient. Now this method, you must have seen this chart as well. Whenever you take a radiograph, you see such radiographic picture in an OPG. You can definitely estimate the age. You can simulate the radiograph with these stages, and it will fall definitely under one of the 21 stages, and you can nicely see. For example, if this is the picture here, this is the picture, and you see that few teeth are like the premolar, the molars, both the deciduous molars and canine is there, and these are erupting. You can say the person is 9 years of age. Definitely there is a gap of and bias of standard deviation of plus minus 9 months. So this is already we are using. This is nothing new for us. Little modification, this is London Atlas method, which was given in 2009. It is similar, but it's a slight modification of the Shore and Messler classification. This is again, you can nicely see this. This is just an example. If you see such appearance, you can see that the person is 5.5 years of age. Next is scoring methods. There are so many scoring methods. I'll only be talking about 2 and 3 best methods that we can use. We personally have done research on almost all of these methods. I'll tell you in the end as well that which method should you follow for Indian population. But I'll be just briefing you with all these procedures, all these techniques. First is Murray's, Fanning and Hunt this thing. There is 14 different stages of tooth development. If you can see, if a person is having a molar whose crown is completely formed till cemento-enamel junction, but no root formation. So it comes under R1 stage. There are different stages. It is used for permanent multi-rooted teeth. And if a person is at this stage, you can see R1 has a different reading. You can see here RI, initial root formation. Then the person is, if he is a male, then it is 7.1, and in case of female, it is 7 years. So this is Murray's classification. Definitely. Next is, this is the case which I did before this presentation. This is the radiograph where you can see second molar here, and there is no crown formation is not complete. So he felt in this stage, in cusp outline complete, and the mean age was 4.7, but the actual age of the patient was 5 years. So it is okay, it is good technique for estimation of age, but not the best. Next is Demerjian method. This is the most acceptable method. Again, in this method as well, you can see 7 teeth are used. Mandibular 7 teeth are used. You should use left side teeth, but if few teeth are missing on left side, you can see the right side of the mandibular teeth. And you can see here, if initial cusp line is formed for molars, it will fall under A stage. And if complete root formation is there for incisors, it will fall under H stage. So there are different stages for all the teeth. Then what happens? We give different staging, and different staging. For example, A we gave for mandibular molar second. The score is 2.1. For central incisor, the stage was H. You can see here. So central incisor we gave 11.8. So this is a chart. This is already given. There is no need to remember this chart. It's already given. You can always take help from these charts. And this is for boys. For girls, it is different. And the formula what you will be using for boys will be different, and for girls it will be different. You just have to sum up all the readings, and you have to put S. S is the sum of all these readings, and you have to just put S in the formula, and you will get the dental age of the patient. This is a case which I did a few days back only for this presentation. You can see that the central and lateral incisor root formation is complete. So we have given HH reading for both. Then you can see canine. We have given F for canine. It is under this stage. So we have given F reading. Similarly, G, F, H, and F. H we have given for first molar because the root formation is complete. Now what we did is we changed the stages from the number which was there on the chart, and we sum up all the readings. It was 93.5, the sum total of all the 7 teeth. Now we have put this 93.5 under this S, and the result was dental age. What we calculated was 14.5 years, but the actual age of the patient was 14.11 months. Slightly more than 11. So you can see there is only difference of 3-4 months that is justified. Right? Next is Nola's method, in which they have calculated they have not given separate readings for every stage, but what they did is you have to calculate all the stages. You have to, again 7 teeth are used in this method. And again, if this is the sum of the stages of 8 mandibular teeth, if the sum is coming out to be, for example, 59.5, so you can say the person's age would be 8. And if it falls between this 59.5 and 66, you can say that the person is between 8 and 9 years of age. Fine. So this is last method in this. There are so many methods, but I have only covered few important methods. Camry's open apices method. This is the done by us only. You can see this is how it is calculated. We calculate the height of the crown, and then we also calculate the open apices width. Once it is calculated, again it is sum up we have to do for all the 7 mandibular molars, and again we have to put it in a formula, and we get the age of an individual. Again, this is also accurate method, but not as accurate as the Demerjian method. Now it has been happened that I've told you that adults also, it is very important to determine whether the person is more than 18 years of age or no. There are so many reasons which I have already spoken about. That reality is determined not by what scientists or anyone says. You have to have evidence for that. And what is the evidence for age estimation? It is the radiological assessment. There are 2 methods. Area assessment of teeth, where we assess the area. Second is development of third molar. These are the 2 important methods. In area assessment of teeth, there is first method is Qualls method. It is, I want to repeat again that it is for developed dentition. It is not for developing dentition. For developing dentition, there was Camry's open apices, Murray's, Demerjian. It is for developed dentition. Fine. This is Qualls method. You can see 3 maxillary, that is central incisor, lateral and second premolar, and 3 mandibular, lateral incisor, canine and first premolar are taken for this study. What is done now is we have to calculate the pulp height, the complete height, and the height from the cemento-enamel junction, and we have to also measure the width of the tooth at 3 different areas. Fine. The areas also are given. It is half of the tooth, then between these one line is drawn. Then again all this is calculated, and again this is put in a particular formula. This is the study done by us only. We have used 900 OPGs for this. And again, the similar three maxillary, three mandibular teeth were taken. And this is the result. In all these results, you can see there was underestimation of the age. So dental age was much more less when compared to the actual chronological age. So that is why I told you in the starting that to assess the age of developing dentition is very easy. It's easy definitely and accurate as well. But if you want to assess the age of an individual where the dentition is fully formed and fully root formation has fully completed, then the age estimation is slightly difficult. And you can see there was so much of standard deviation in that. And the sample size was not less, it was 900 OPGs, which is fair enough. Right? So, but one of the main inferences, if you want to use this method, then 3 mandibular teeth are more accurate when compared to, this is in the decreasing order. If you have choice, use only 3 mandibular teeth. After that, use mandibular first molar, premolar, and after that maxillary second premolar. This should be your choice if you are using this method. Next is coronal pulp cavity index. Again, studies were done in our department, 433 individuals, where it's comparatively easy to do. You have to calculate just the crown height and you have to calculate the crown pulp cavity height, this height. And once you do it, again you have to put it in a formula and the result will come. Again there was bias, it is not accurate because there is overestimation and underestimation of the result. Next is development of third molar. There are 2 methods, Harris and Notje, where there are 5 stages. You can see in the first stage, you can see crown formation is complete and slightly the root outline has also started to begin. And the last stage is complete maturation of the root. Next is Van Heerden method. You can see that in this tooth, the apices are open. So it will fall under stage 4. By that you can determine the age of an individual. These are the different stages. The next is, and this is recent methods. This is a study done from CBCT in our department. We have taken the volume. This is an axial section, if you can see here. This is an axial section. We have taken the volume of a complete tooth. After taking the volume of a complete tooth here, you can see this is the volume of a complete tooth, and adjacent to it you can see that this is the volume of only the pulp. So this ratio is calculated, that what is the volume of the tooth and what is the volume of the pulp. And by calculating this, we can also estimate the age of an individual. But this study was done 7 to 8 years back, so that time the softwares are not that user friendly. Might be if you do similar studies later now, then it will be very much accurate. So this study was done, but the limitation again, what I told you is because the tooth formation is complete here. So there was the plus minus, result was plus minus 7.8 years. That's a massive gap. So this definitely cannot be used. Now we have not done similar studies in the recent past, but definitely that time it was not accurate at all. It is not only the teeth which we can use. Since I am talking about age estimation from dental radiographs, we can use lateral cephalogram also to assess age. Head and wrist, you all know that it can be used. By ossification of laryngeal cartilage, this is the ossification of laryngeal cartilage, and ossification of thyroid cartilages, we can estimate the age of an individual, right? Styloid process calcification, you must have seen similar OPGs so many times, but what we do usually is, we only see the teeth, we do not see other part of the jaw, maxilla, beat maxilla, beat mandible. We will never see what is happening in the sinuses, we will never see what's happening here. But in this patient you can see the styloid process is calcification, there is calcification. So this is also one of the way to estimate age of an individual. Palatine suture closure, this is the axial section of CBCT. You can see that a palatine closure, by this calculating this, the width of this, we can estimate the age of an individual also. Now I have told so many methods, you would be confused definitely that sir has told so many methods, which method should I use? Because as a dentist you can get any case. Any day police can come to you and ask, Madam sir, can you please estimate this? Because we want to put it as a evidence in the court. So he or she can come to you anytime, and you cannot refuse because you have completed your degree. You have to do it. So which method should you follow? How reporting you should do and which method should you follow? First of all, the things what you should take care of is accuracy, what I have told you. Accuracy means your dental age should be as close to the chronological age. So the method, whichever method you are using should be accurate. Second is bias. Bias is the difference between dental age and the chronological age. So the bias should be minimal. Ideally there should not be any bias, but it is not practically feasible. And third is standard error of estimate. It is the how precise your method is. So it depends on that thing. So if we see all the methods, I have already told the difference between dental age and chronological age should be very less. And it should be 0. But ideally I have told you it is never 0, but it should be as close to 0 as possible. Right? So out of all these methods, it's not by our study only. The literature suggests there are so many studies. There are almost 20-25 studies on it, using different methods, age estimation. All the methods. In 2017, there was a systematic review. In 2020, there was a meta-analysis, which all states that Williams method is the most accurate method and the bias is very minimal in this method. So you should always use this Williams method. Now you would say that you have not told this method only, you have told all the methods. So I have told this method because it's just a slight modification of Demerjian method. Fine? Where we have given different stages for all the mandibular 7 teeth. So it's just a slight modification. What is the slight modification? Slight customization was done by Williams in Demerjian's method. How can you customize? The stages are same, but you can customize in the formula. I have shown you the formula. Slightly readings have changed because of the population. They have done several studies in Brazilian population and they found that in Brazil, if you put this formula, if you slightly change the reading, then it is falling accurate. So it should be customized. Williams method should be customized. So it is the best method if you want to estimate age in developing dentition. Again, it is not for developed dentition, it is for developing dentition. So it should be the method of choice. If you do not want to do it, next is Demerjian. Definitely Williams and Demerjian are same. There is slight modification, but Demerjian tends to overestimate the age. On the other hand side, Moore is slightly underestimated the age. So the best method what you should use is Williams method. And this should be your reporting format. I'll not go into detail, but I have to show you two things. One is observation of the dental age. You must tell a dental age. You cannot say that the person can be 10 years of age and can be 18 years of age as well. But the better is, for example, you give 16 years of age plus minus 6 months. This should be your ideal reporting. And this is very important, margin of error. You cannot give the accurate age. You have to give standard deviation. You have to give a range that a person can be between 15 to 17 years of age. So you should always give a margin of error. The future is very bright for age estimation. There are now mobile applications also. The companies are making mobile applications where you click few pictures, you click radiographic pictures and you just press a button on your mobile phone, so you will get the age of an individual. So definitely these are simple techniques, clarity is more and self-explanatory. It is in nowadays that the MRIs will be replacing panoramic radiographs very soon. Not very soon in India, but definitely after 5-10 years, definitely MRI will be replaced by, OPGs will be replaced by MRI. So the age estimation will further simplify. So finally concluding here, I would like to repeat here that you should not go with all the your methods. You should customize a formula. You should never use Williams method alone because that is for Brazilian population. You have to customize that formula for Indian population. For Indians also there are so many studies, you can take that formula, you can refer the articles, you can take that particular formula, you can use it and you will get the most accurate age of the patient, dental age of the patient as possible. Right? So this is the last summary that you can see here. If a children is less than 16 years of age, you can use all these methods. The biochemical you can use, morphological is not that much helpful, developmental you should use. So you can see here, if a person is less than 23 years of age, you can use development methods. What are the development methods? Which I have described just now, all the methods. But if a person is more than 23 years of age, then these development methods will not work because these are not at all accurate. You have to use morphological and biochemical methods only. So this is about not just age estimation, this is about your any scientific literature, any scientific fact that there will be separation, there will be misleading, you will get rejection, people will try to deny the fact, but the scientific literature or the scientific truth will definitely progress. Thank you very much. If there are any questions, I would be. Thank you very much. Thanks a lot.
Thank you so much, sir, for such a wonderful lecture. I would like to call upon stage Dr. Anmol Badaria ma'am and Dr. Ashish Chandra sir to please felicitate our speaker with a memento and a certificate.
Yeah, thank you.
Thank you, sir. Our next distinguished speaker is Dr. Richa Khanna ma'am. She is a professor in the Department of Pediatric Dentistry, Faculty of Dental Sciences, King George's Medical University, Lucknow. Please give her a huge round of applause.
Hello everyone, and a very good afternoon to one and all. At the outset, I would like to thank Team CynoDent, Department of Periodontology, Professor Pavitra Rastogi sir, for this opportunity. So today I'll be talking on a novel intervention called as resin infiltration. So opportunities and outcomes in dentistry that we foresee. Now we as dental practitioners, we have a cognitive overload of materials, their manipulations, techniques, procedures, and so on. Now with this, within this plethora of materials, one material that has revolutionized dentistry are the resins, and that too in direct filling forms. So today we are going to talk about a novel innovation of these resins, which is known as resin infiltration. In this small session of 30 minutes, I would take you through a small journey exploring indications of the procedure, interpreting the outcomes of these procedure, its strengths and weaknesses, and to also analyze the level of evidence that is available in literature for this technique. When we talk about the term infiltration, in the literal meaning, it has several definitions to it. Infiltration, you talk of brand infiltration in the corporate world, you talk of infiltration at the borders of the countries, or infiltration of local anesthesia into the soft tissues. But here we talk of infiltration of low viscosity resins into the tooth structure, and that is resin infiltration. The literal meaning of the term infiltration is permeation of a liquid into a tooth layer. So why was a novel intervention actually needed? What was the need of inventing this intervention? In all fields of medicine, including dental sciences, the focus has now shifted towards prevention and early protection. So is the case with dental caries. When we were traditionally managing dental caries, we had two types of approaches. One was a non-invasive approach, for example, oral hygiene counseling, diet counseling, over-the-counter fluoride rinses, toothpaste, which we recommend to our patients. The evidence in literature for this approach is really very high, but what is the problem is the patient compliance. The second approach which we all follow in our dental practices is the invasive approach, where we manage caries allowing the tooth to enter into a death spiral of restorative life. Again, this is a non-invasive approach. So there existed a gap between these two approaches. And to bridge this gap has evolved some micro-invasive options, and resin infiltration is one amongst them. Now we'll see how this resin infiltration actually works. Now, radiographic classification of where does it work? Now, if you talk of dental caries, caries has been classified clinically and radiographically, and the most accepted classification has been IGDAS. Now, resin infiltration works in these early carious lesions where the caries is not extending beyond the outer third of the dentine. So, outer half of enamel, inner half of the enamel, and the obvious spread into the outer third of the dentine. If you see the clinical classification of caries, again, the initial stage caries, that is IGDAS codes 1 and 2, where there is no surface breakdown and there is no dentine shadowing, resin infiltration is going to work. Now let us see how. If you see the structure of the initial caries lesion, the superficial layer is the intact surface enamel, which is hypermineralized and smooth, because the minerals from the saliva, they replenish the demineralized enamel and keep it intact. Under this intact surface enamel is the subsurface enamel, which is weak and hypermineralized, soft and porous. But still, there is no cavitation. Now, how does it work? These low viscosity resins, when we apply it on initial caries lesion, they penetrate into this intact surface layer, they go into the subsurface layer, they create a diffusion barrier on the surface of this initial caries lesion, and thus stabilize caries. This is the mechanism. Now, an important point here that differentiates this intervention from the traditional approach of caries management is that we are strengthening or stabilizing the subsurface enamel, which we are not able to do by our over-the-counter products. Now, what is the procedure? Let me just take you to a quick through for the steps in the procedure. It's a twin combination where you do microabrasion with a strong acid. The acid used here is 15% HCl, and then you seal with low viscosity resins. So this is just a picture, a representative picture of the kit which is available in the market, and you get two types of kit, either a labial or a proximal kit for the same. You etch with a 15% HCl for 2 minutes, rinsing for 30 seconds, and then drying with ethanol. Ethanol here works as a surfactant, and this is followed by application of the low viscosity resins. This is a procedure where we are using a proximal kit, so the liquid, with a very thin liquid of resin, it flows into the lesion. We allow this flowing for 3 minutes, and then we cure it for 40 seconds from different directions. A reapplication may be required and can be done. So, just not going by the manufacturer's claims, we tried to explore this intervention in our department. So, a disclaimer which I would like to say here is that all this research, it is not sponsored, or it's not, the product is not being endorsed by the department, but this was just the results of the studies which we have done in our department, which we are putting forward in front of you. So the first study which we did was, we explored resin intervention in proximal carious lesion in primary posterior teeth. Now, instead of the routine procedure, we tried to modify the intervention. Over the resin infiltration, we also applied chlorhexidine varnish. Now, chlorhexidine varnish, the reason was that all resins have been reported to have an oxygen-inhibited layer on the surface. So to prevent that and to enhance the antibacterial action, we also applied chlorhexidine varnish. So study design was a split mouth study design. Split mouth is on the one side of the teeth, one intervention was used, one side of the oral cavity, that is one quadrant, and the other quadrant we use other intervention. So what we compared was resin infiltration standard procedure with resin infiltration chlorhexidine varnishes. So 76 lesions were selected and observed for a period of 12 months. So the sample section, again, we use the simple IGDAS criteria for sample selection. We use IGDAS score 2 lesions and also some IGDAS score 3 lesions where frank cavitation was not present. Radiographically, these lesions did not extend beyond the outer third of the dentine. So this is a representative picture of the radiograph as well as the clinical picture of the sample which we included in the study. Outcomes were both clinical and radiographical. We observed how the clinical scores change and how the radiographical scores change. We observed the change in the IGDAS scoring of the lesion. Now what we saw in the control and test, our control was the resin infiltration alone. We did observe that some of the lesions which were at a lower level, that is IGDAS 2 or 3, they progressed to a higher level to IGDAS 4. But in the test group, none of such progression was seen. So the chlorhexidine added to the potential benefits of the resin infiltration. Similarly, for the radiographic outcomes, we tried to quantify the radiographic progression of dental caries. And for this, we use the radiographic scores and also the grayscale areas. Again, similar to the clinical outcomes, we observed that radiographic scores did progress in the control group, but there was no progression to higher IGDAS scores in the test group. Now with the grayscale changes, we tried to actually give numbers to this progression. We use the GIMP software, which is very easily available, freely accessible on the internet. We tried to define the radiological area of the lesion with the help of this software, and we created the histogram of this area. So here you can see a representative histogram of this carious lesion. This is another example of a pre and post-test histogram. So if you see the first diagram, the lines in the graph is spread across when you see the histogram. And the second, that is a post-intervention when we see, it's a very narrow band of points which we can see in the graph. So what we analyzed was that when we were applying this resin infiltration, our histogram analysis showed that the grayscale actually shifted from a higher value to a lower value. Now there is a sufficient support from literature. There's an article from an engineering institute which says that a demineralized lesion will show histogram values which are more towards 0 and 100. Whereas a remineralized lesion will show values which are higher above, that is 150 to 255. So similar kind of results we also observed in the radiographs after applying the intervention. We further explored we concluded that arrest of the lesion was quite evident by resin infiltration, and chlorhexidine further enhanced this arrest of lesion. Now, evidence from literature. Whatever evidence we created, we also matched our evidence from literature. Now, arrest of non-cavitated enamel caries, a very, very high evidence exists. A lot of systematic reviews, meta-analysis, RCTs, and in vitro studies exist. But for the arrest of microcavitated initial lesions, the evidence was low. So we have published our study, and our study have really added to the evidence that existed in literature. We continued our journey into the area of aesthetics for exploring resin infiltration. Now, within aesthetics, the most common aesthetic defect which we all see in our daily practice is the developmental defects of enamel. Here I'm just focusing on the qualitative developmental defects of enamel where there is no surface breakdown. So these are actually defined as visible alterations in the normal translucency of enamel and which result from the dysfunction of amyloblasts. Now we tried to assess the prevalence of these defects, and it's ranged between 3.6 to 22%. Nearly in our pediatric dental practice, we get these kind of patients in a very regular form. So when we explored the traditional approaches of managing these defects, again, we had two types of approaches. One extreme, the strategies that focused on aesthetics of these defects, but did not take care of the function. Now, this involved microabrasion. We have several bleaching techniques and a combination of microabrasion and bleaching. But there are, to the other extreme, there are also strategies that focuses on both aesthetics and function, and that include composite restorations, veneers, and also full crown restorations. So why was resin infiltration applicable in these defects? How? Because earlier we are just looking at the thesis. Now structurally, both initial caries and developmental defects of enamel are similar. Both have a superficial intact hypermineralized layer and a subporous hypomineralized layer. So resin infiltration can strengthen the enamel structure in these defects and also recover the translucency of enamel because these resins have refractive index which is similar to that of enamel. So evidence from literature again for these kind of developmental defects of enamel was moderate and there were lack of quality trials. So we planned a study in a department which was a pre-test, post-test study design, and we selected permanent anterior teeth with developmental defects of enamels with codes 1 and 2. Codes 1 and 2 do not show any surface breakdown. So we evaluated 9-month period more in the test group than in the control group. So what we observed was there was a shift of pixels, that is shift from a demineralizing to a remineralizing zone in the cavity, in the demineralized enamel when observed in the radiographs. So a summary of indications which I can just point out based on our first-hand experiences was proximal carious lesions in primary teeth are a very good indication for resin infiltration. Qualitative developmental defects of enamel for recovery of translucency, provided you do appropriate patient selection, and also under composite restorations to treat demineralized enamel. There are other indications in literature which we have not gone through, which mostly the orthodontists do, is for the white spot lesions after the orthodontic treatment. There was ample literature on this, and therefore we did not try to explore this. So a critical appraisal of this intervention, let's see what strengths, weaknesses, opportunities, and threats it has. As a strength, this intervention is a microinvasive approach. It takes care of both aesthetics and function when you talk of enamel defects. It gives early protection of caries. And for early caries, the evidence level is actually very high, and you can easily use this for initial caries. The limitations or weaknesses that still need to be taken care of is for the other indications beside caries. We don't have evidence, and therefore we cannot translate it into practice very easily. The cost is another factor. Careful patient selection. Some technique sensitivity is involved, and it also requires expertise in early caries detection. If you're not able to detect initial caries, you will not be able to apply this intervention. Also, this intervention may not be able to achieve pre-demineralization hardness values of enamel. Opportunities are ample because we can expand this intervention to different grades, different categories of caries further. Opportunities also exist for incorporating this intervention with novel technologies like newer caries diagnostic methods. Opportunities exist for assessing the quality of life parameters for patients when you apply this intervention, and also for long-term assessment of outcomes. Threats. Low evidence is a great threat because that decreases our likelihood of choosing this as an intervention in our clinical practice. And second, the high cost may again decrease this likelihood of translation. So we come back to our objectives with which we started. The indications of the procedure, interpreting some outcomes of the procedure, the strengths and weaknesses, and the level of evidence that is available. So thank you to one and everyone. And any queries, if you want questions, you can ask just now or email to me on this email. Thank you so much. Yes, yes, sir. Right, sir. So my answer is that the recovery of translucency, it actually improves when the time elapses from the intervention. Reason is because we use 15% HCl and we totally dehydrate the tooth. So after dehydration, when we send the patient back and call him after 1 week, the translucency recovery is much better than the day of the intervention. So that improves with time. Thank you. Yes, we did. As you saw, we saw some 5 of our cases, they progressed to higher grades. So that is actually failure, but that was not statistically significant from our point of research. But yes, 5 cases out of 38 did progress to higher caries lesions. Yes. Thank you, sir.
Thank you so much, ma'am, for such a wonderful lecture. I would like to call upon Professor Pavitra Rastogi, sir, President, UP State Dental Council, as well as Dr. Sanjeev Srivastav, sir, Head of the Department, Sardar Patel Dental College and member of UP Dental State Council of India, to please come up on stage and felicitate our eminent speaker. Thank you so much, sir and ma'am. I would also request Professor Pavitra Rastogi, sir, to please felicitate our Dr. Sanjeev Srivastav, sir. Our next renowned speaker is Dr. M. Siddharth. He is the Dean of School of Dental Sciences, Sharda University, Greater Noida. Please join your hands together for our next speaker, please.
Good afternoon, everyone. At the outset, I would like to thank the team CynoDent, Dr. Anmol Bagaria, Dr. Ashish Chandra, for inviting me to speak in this prestigious podium. I would like to also thank the Department of Periodontology, Faculty of Dental Sciences, KGMU University, Lucknow, Professor Nandlal, Professor Head, Department of Periodontology, and Professor Pavitra Rastogi. Thank you so much, sir. So, greetings from the School of Dental Sciences, Sharda University. I will be speaking on a very basic topic, infection control in dental practice, and this presentation is mainly targeted towards young graduates, both BDS and MDS, who are planning to or who have recently started their dental clinics. It will be, the contents of the presentation will be as follows: simple definition, fundamental elements for infection control in dental settings, standard precautions, transmission-based precautions, little bit about COVID-19, sterilization and disinfection of patient care items, special consideration, and conclusion. Now, as you all know, infection control, the purpose of infection control in dental settings is basically to prevent transmission of infectious diseases from between patient to patient, from patient to dental healthcare professional, and from dental healthcare professional to the patient. We know that infection control, breaches in infection control often occur, and it is mainly as a result of unsafe injection practices, failure to heat sterilize dental handpieces between patients, and failure to monitor autoclaves. Infection prevention should be a priority in all dental settings, whether private practice or institutions, and they should be equipped to observe standard precautions and infection prevention recommendation as per the latest CDC guidelines. I'm sure everybody must be knowing the definition of sterilization and disinfection. It's very common. The basic difference is sterilization destroys all substantial number of resistant bacterial spores, whereas disinfection does not destroy all the bacterial spores. Coming to the fundamental elements for infection control in a dental setting. First, the first step is the administrative measure. One member of your dental team, that is the dental healthcare personnel, should be trained in infection prevention and program coordination. There should be written infection prevention policies. Training must be provided to all dental healthcare personnel or professionals at regular intervals. Immunization of dental healthcare personnel is important, especially with respect to hepatitis B, measles, mumps, and varicella and COVID-19 nowadays. Screening for tuberculosis also should be done, and there should be a mechanism for referral for post-exposure management. The infection control program in a dental setting should also be evaluated regularly. There should be periodic assessments, checklists, and review of occupational exposures to blood-borne pathogens. Coming to standard precautions, it used to be known as universal precautions, but it is now known as standard precautions. Standard precautions refers to minimum infection prevention practices that apply to all patient care, regardless of suspected or confirmed infection status of the patient in any setting where healthcare is delivered. It protects both the dental healthcare personnel as well as the patients. The first step is hand hygiene. Hand hygiene is essential before and after treating each patient. It should be done before putting on and after removing gloves. If the hands are visibly clean, then an alcohol-based hand rub will do. If hands are visibly soiled, then one must wash the hand with soap, that is plain or antimicrobial, with water. And for surgical procedures, a surgical hand scrub is a must. Coming to personal protective equipment, that is gloves. Disposable gloves must be used. They should be changed after every patient. For non-surgical procedures and for checkups, simple examination gloves can be used. But for surgical procedures, sterile surgical gloves must be used. Heavy-duty puncture-resistant gloves should be used for manual instrument cleaning. And if any dental healthcare personnel is having latex allergy, then non-latex or nitrile or vinyl powder-free gloves must be used. Then disposable gowns are a must, and enclosed footwear. Masks, they should be able to block a particle size of 3 microns or less. They should be disposable. They should cover the mouth and nose. They should never be touched during the procedure. And if they are wet, they should be discarded. And they should be put on before hand hygiene is performed. Eye protection. We must have eye protection. The eye protection should be optically clear, it should be anti-fog, and it should be close-fitting, ideally shielded at the sides. Face shields can also be used. They can be cleaned with disinfectant if contaminated, and eye protection should be worn not only by the dental healthcare professional, but also by the patients. Coming to respiratory hygiene and cough etiquette, which has assumed a magnitude proportion nowadays because of the COVID-19 pandemic. This applies to both dental healthcare professionals and patients. They should cover their mouth or nose when coughing or sneezing. They should use tissues and dispose them of accordingly. Hand hygiene should be performed after contact with respiratory secretions. Masks should be provided in the dental setups to coughing patients, and preferably, especially in an institutional setting, a separate area may be demarcated for patients with respiratory infections. Coming to sharp safety, we can use engineering controls in the form of self-sheathing anesthetic needles, safety scalpels, needleless IV ports. Sharp containers must be used to dispose them, especially puncture-resistant containers, and special needle recapping devices may be used. Some of the work practice controls to prevent sharp injuries include one-handed scoop technique for recapping needles. One must not bend or break needles before disposal. Do not pass the syringe with the needle by hand, and burrs should be removed before disassembling the handpiece from the dental unit. And one must use instruments in place of fingers for tissue retraction. Coming to safe injection practices, local anesthetic needles and cartridges should be used for only one patient. Dental cartridge syringe should be clean and heat sterilized between patients. One must disinfect the rubber septum on a medication vial with alcohol before piercing, and single dose vials should be used for single patient use. Additional doses from single and multi-dose vials, if they are required for the same patient, one must use a new needle and syringe. And ideally, we must confine multi-dose vials to a single patient only and discard them after use. Coming to the disinfection of environmental surfaces or environmental infection prevention control, ideally a barrier should be used, a physical barrier in the form of a plastic sheet to protect clinical contact surfaces, and should be changed between patients. Where a barrier cannot be used, one must use disinfectants to clean and disinfect clinical contact surfaces. And cleaning and decontamination of spills of infectious liquids also should be carried out immediately. Coming to transmission-based precautions, transmission-based precautions are always applied in addition to the standard precautions. They are applied for patients with known or suspected infectious diseases that can spread through contact, droplet or airborne routes, that is by skin contact, sneezing or coughing, such as tuberculosis, measles, chickenpox, avian influenza, SARS, Nipah virus, COVID-19, and now recently monkeypox. There should be early detection and management of infectious patients at initial points of entry in the dental setting. There must be rescheduling of non-urgent dental care until the patient is non-infectious. And where the adequate facilities for sterilization and infection control are not available, if the patient is symptomatic, then one must refer to a tertiary care center for where the facilities are available. Coming to few points on COVID-19, one must assess the risk. If it is a low-risk patient, such as those who are vaccinated or those who are RT-PCR negative and they are asymptomatic, all dental procedures can be carried out with appropriate precautions. The high-risk patients include those with COVID-19 symptoms, those who are RT-PCR or RAT positive. Only emergency procedures with standard COVID protocols should be carried out in such patients. And if, as I said, facilities for infection control are not available to handle such type of patients, one must refer to tertiary care centers. And obviously, COVID-19 vaccination is a must for all healthcare personnel. There should be a time-based appointment system for all COVID or COVID suspected patients or during a pandemic. The screening patients should be done at the dental clinic entry, the triage. In the waiting area, there should be visual alerts about respiratory hygiene, installation of glass or plastic physical barriers in the waiting area. There should be availability of masks and hand sanitizers. There should be adequate physical distancing where the patient is seated. The waiting area should be formite free, and there should be a contactless payment. Some of the infection control measures which are to be followed were followed and are also being followed during the COVID-19 pandemic include pre-procedural mouth rinses with povidone iodine and chlorhexidine, high use of high vacuum suction, face shield and N95 masks, use of rubber dam. There should be adequate time between two procedures to allow for the complete disinfection and sterilization protocols. And disinfection of equipment and operatory surfaces must be done between patients with 1% sodium hypochlorite or 70% alcohol. Floor mopping with 1% sodium hypochlorite should be done. Waste management should be as per the current guidelines given by the government. One must disinfect impressions, casts, prostheses and appliances. During COVID-19 pandemic, we should prefer extraoral radiographs to intraoral radiographs. Another important point which has been introduced during the COVID-19 pandemic is the concept of ventilation. One must maintain air circulation with natural air through frequent opening of windows and exhausts, and there should be use of indoor portable air purifiers with HEPA filters. Now coming to the sterilization and disinfection of patient care items and devices as per the CDC guidelines. It depends on there are different 3 instrument categories or risk categories as per the Spalding's classification, that is critical items, semi-critical items and non-critical items. Critical items are those instruments where there is entry into soft tissue, bone or bloodstream, or it comes in contact with bloodstream. Example, surgical instruments and scalers. They should be heat sterilized with an autoclave. Coming to the semi-critical items, these instruments or equipment, they come in contact with mucous membrane or non-intact skin. For example, mouth mirrors, restorative instruments, tweezers, probes, impression trays. Ideally, they should be heat sterilized. If they are heat sensitive, then high level disinfection should be carried out. Non-critical items are those equipments, instruments which contact only the intact skin. For example, radiograph, cone head, face bow, protective eyewear, bib chain. They should be ideally protected with the surfaces should be protected with a barrier, a physical barrier, or they can also be cleaned, followed by disinfection with chemical disinfectant. Coming to reprocessing. What do you mean by reprocessing? Reprocessing in the sterilization process includes all steps necessary to make a contaminated, reusable device ready for its intended use. It is in the following steps. The first step is cleaning, then testing, packaging, labeling, then the actual process of sterilization and disinfection, followed by storage. The reprocessing area where the sterilization process is to be carried out should be a dedicated room separate from your treatment area, ideally. There should be areas for receiving, cleaning and decontamination and preparation, packaging and sterilization and storage in the dedicated room. The instrument flow is always from dirty to clean. The first step is the cleaning in the reprocessing process. One can begin the process of cleaning by pre-cleaning at the chair side by wiping at the chair side. Manual cleaning by hand is to be discouraged. Automated cleaning using ultrasonic cleaner or washer disinfection with chemical agents is ideal. Instruments should be checked after the cleaning procedure. Instruments should be checked visually to ensure that all contaminants are removed. And all instruments should be dried before packaging. Coming to packaging, various forms of packaging are used such as instrument cassettes, pouches of plastic or sterilization wraps. For non-critical instruments, one must use cassettes. For critical instruments, they should always be wrapped. And one must also use chemical indicators, either internal or external, with the package. And the package should always be labeled. Now coming to the essence, steam sterilization. Basically, two types of basic steam sterilizers are used: gravity displacement and high-speed pre-vacuum sterilizers. And steam, the essential point is the steam sterilizers for packaged items must have a drying cycle. There should be regular monitoring of the sterilization cycle using mechanical indicators such as pressure and temperature gauge readings, chemical indicators such as internal and external indicator tapes, strips and tablets, and biological indicators such as heat resistant spores of geobacillus. One must maintain sterilization records. Coming to the storage of instruments after the process of sterilization, they should always be stored in covered or closed cabinets. The wrap packages should always be inspected before use to ensure that the packaging material has not been compromised. That is, if it is wet, torn or punctured, all these compromised packs should be reprocessed. Coming to some special consideration, dental handpieces are always cleaned, lubricated and packaged in sterilization pouches, and after which they are sterilized in steam sterilizers after each patient. Coming to dental radiology, if you are using films, then after the taking the X-ray, the dry film packet, the film packet should be dried with paper towel and should be placed in a container for transport. There should be protective barriers, physical barriers on radiographic equipment, which must be changed ideally after each patient. Contaminated equipment should be cleaned and disinfected with chemical disinfectants, and RVG sensors, which are used very commonly, should be cleaned and covered with a protective barrier and should be changed after each patient. The dental curing light should be cleaned prior to having a barrier placed and should be changed after every patient. Coming to lasers, electrosurgery and air abrasive systems, high filtration surgical masks must be worn by the operator. There should be high vacuum suction to prevent inhalation of plume, and there should be adequate evacuation systems to remove the plume. Impressions should be rinsed with cold running water, followed by an application of diluted detergent, further rinsing and immersion in 0.5% sodium hypochlorite solution for up to 15 minutes. Endodontic files, hand files are to be used only once. They should be only single use and they should be ideally changed after every patient. For nickel titanium rotary files, they should be cleaned again with the disinfectant or enzymatic cleaning solution followed by steam sterilization. Now coming to concluding remarks, dental practitioners must comply with latest and current infection control standards. The dental health care personnel should be trained in infection control protocols. There should be reporting, monitoring and rectifying breaches of infection control protocols. There should be record of workplace incidents and accidents, that is sharp injuries. The immune status of dental healthcare personnel should be monitored regularly. There should be a robust immunization program for dental healthcare personnel. There should be a good hand hygiene program, safe handling and disposal of sharps. And we must, in the dental setting, we must be able to prevent and manage occupational exposure to blood-borne viruses such as hepatitis B, hepatitis C, HIV. There should be environmental infection prevention, and there should be provision for specialist medical management or referral after potential exposure to blood-borne viruses. Thank you. This is some of the references. Thank you.
Thank you so much, sir, for such a wonderful lecture. I would like to call upon stage Professor Pavitra Rastogi, sir, Dr. Anmol Bagaria, ma'am, and Dr. Ashish Chandra sir to please felicitate our speaker with a memento and a certificate. Also, I would like to request Puneet Ahuja sir to please come up on stage and felicitate our eminent speaker. Thank you so much, sir. Our next speaker for the day is an eminent personality, Dr. Puneet Ahuja sir, who is a principal at Babu Banarsi Das College of Dental Sciences, Lucknow. Please join your hands together for our speaker.
डॉक्यूमेंटेशन इसके ऊपर इसका आगे पीछे कहाँ से थैंक यू
Happy afternoon to all of you, my dear students, deans, professors, faculty members. Greetings from Babu Banarsi Das College of Dental Sciences, Lucknow. And at the outset, I would like to thank Anmol, Ashish, and the team of CynoDent for inviting me here for this lecture. And our story starts यहाँ पे हमारे एक यंग हैंडसम डेंटिस्ट हैं और ट्रेन में सफ़र कर रहे हैं। ट्रेन में जिस डब्बे में वो बैठे हैं वहाँ पे एक बहुत ही खूबसूरत लेडी आती है, उनके सामने बैठ जाती है और उनको मुस्कुरा के देखती है। हमारे डेंटिस्ट भी मुस्कुरा के देखते हैं, वो और पास आती है और मुस्कुरा के देखती है, हमारे डेंटिस्ट साहब भी मुस्कुरा के देखते हैं। फिर उसके बाद वो और पास आके धीरे से उनसे कहती है कि अपने जेब में जितने भी पैसे हैं, कार्ड्स हैं, घड़ी, रिंग, चेन, सब मुझे दे दो, वरना मैं अभी बाहर जाके चिल्लाऊंगी कि ये आदमी ने मुझे मोलेस्ट करने की और मुझे छेड़ने की कोशिश करी। हमारे डेंटिस्ट साहब उनको देखते हैं, मुस्कुराते हैं, एक पेपर उठाते हैं और उस पे लिखते हैं कि मुझे बोलना और सुनना नहीं आता। आपने जो अभी कहा मुझे लिख के दीजिए, वो पढ़ती है और वही चीज़ उनको लिख कर दे देती है। जैसे ही वो लिख कर देती है, हमारे डेंटिस्ट साहब वो पेपर लेकर खड़े हो जाते हैं और कहते हैं कि अब आप जाइए और चिल्लाइए जितना चिल्लाना है। एंड दैट, फ्रेंड्स, इज द टॉपिक फॉर द डे, documentation and records in dental practice, an area which is usually not taught in our syllabus, an area which is neglected not only by budding graduates, our interns or postgraduates, but even by majority of the practitioners. And unfortunately, dental colleges also, that we do not keep documents and records as they should be. What is documentation and what is a record? I will just tell you the difference. It is, there is not much of a difference between documentation and records, but I have mentioned it separately. What, how, and why is what we are going to see in this short talk. Anything written, printed in a digital electronic format, and relied upon as proof of record for consultation, diagnosis, investigations, treatment, prognosis, outcomes for a patient done by an authorized person is called as a documented record of treatment. And why should we document? These are the reasons. You have the patient's history, you have the chief complaint, the findings, procedures, diagnosis, prognosis, treatments, and outcomes. It supports your medical care. It aids in identification of the patient. It helps to generate an effective diagnostic and treatment plan. You have all your physical findings, differential diagnosis, procedures, tests, response to the treatment, and it supports your continuity of care. But there are still some skeptical people who will ask, you know, a lot of people ask me that, is there any actual requirement? Why should we fill up so many details? And this I will tell you from my experience when I was working with a corporate chain called Clove Dental in New Delhi. I was working with Clove Dental for about 3 years. And coming from academics to a corporate chain was a sea difference for me. And of course, now I'm back into academics, but those 3 years of working with Clove Dental taught me a lot of important things about certain aspects of clinical dentistry which we forget or which we neglect in our academics. It should be legible. The first thing, that whether you use a long form or a short form to record the patient's details, history, diagnosis, and treatment, please see that your writing is good because it reduces your errors. This photograph on the right-hand side top, I'm sure nobody can understand, and that is why many of the doctors are notorious, and it is called as doctor's handwriting because nobody can understand it except for the pharmacist. The person at the pharmacy is the only one who can understand your handwriting. So legible handwriting is the first thing. And it should be factual. Don't write anything which you have not observed in the patient's mouth or physically or in the history taking of the patient. Please understand, it should be descriptive, objective, decreases misinterpretation later on. Do not use abject words like seems, appears, apparently, well, good. Subjective information is documented with the patient's own words in quotations. Please do not give your opinion on the document. It should be complete and concise, thorough, exact, and brief. Do not go into too much of details. Do not write personal details in the patient's document. It should be clear, it should be to the point, and avoid abbreviations when you are writing down the patient's details. Abbreviations leads to mistakes. Certain abbreviations are not acceptable. It should be in a logical format. Chronological flow of events should be recorded on the document. It works as a database. You have a problem list, you have a care plan and progress notes. And it is all the more important in your practice, especially if you are inviting consultants to your clinic to do certain procedures. Say if you are inviting an orthodontist for orthodontic treatment of your patient, or if you are inviting an oral and maxillofacial surgeon to do a disimpaction or any kind of surgery on your patient, when he or she comes and looks at your notes of what the patient has undergone, the treatment or the diagnosis that you have done for him, if these things are not written clearly, legibly, in a proper chronological order, the visiting consultant may make some mistake. On the other hand, if you have consultants coming to your clinic, please ensure that whatever treatment is being done by the external dentist in your practice should be recorded in the same manner on that document. Because tomorrow, if there is any kind of a judicial procedure, any malpractice suit, which are increasing day by day, especially in metro cities and capital cities. We come across a number of cases every few days in big cities. Now it's gone to small towns also, that patients are suing the doctors, taking them to courts for malpractice. So these are your safety guards. These are your armor. Documentation methods are many. We will concentrate on the most simple one, that is the problem-oriented medical record. That means whatever has been taught to you in your dental college, that you start with the history taking and you record that history taking on a form. The forms can be of different types, but essential documentation like the name, age, sex, address, occupation, chief complaint, dental history, medical history, family history, and then elaboration of the chief complaint should be mentioned on the document. Further to that, any kind of investigations, x-rays, lab investigations, provisional diagnosis, final diagnosis, and then as you keep on treating the patient, please keep adding the treatments on that form. And these will serve as a permanent written communication between you and the patient, between you and the judiciary, between you and any kind of legal implication that may arise any time during or after the treatment. Please remember that there is no time limit for a patient to sue a doctor or a dentist after the treatment has been completed. All right? It is a gray area still. There is no guideline as to if you have done a root canal treatment 5 years back for a patient and given him a crown, and today that root canal treatment fails for some reason, the patient can still take you to court. So at that time, your records, your documentation are going to save you. Medical records are your continuing account of your care status. All healthcare providers can benefit from information and plan accordingly. Communication, financial billing, education, assessment, research, auditing, legal documentation. So friends, not only does it protect you from legal implications, it also gives you a solid background to see that what is your finances with respect to your patients. I'm sure a lot of dentists, especially the busy dentists who are seeing multiple patients in a day, they forget to take the payments from their patients after some time, because their records are so haphazard that they don't remember whether the patient has paid me in full or is there any payment which is still pending from a certain patient. The new patients start coming in, the doctor gets busy with the new patients, then one big case comes, a full mouth, so again he gets busy with that, and that patient where you have probably some 5,000 rupees pending, it gets relegated to the background somehow. And with that, if you have, say, 100, 200 patients of 4,000, 5,000 rupees, it amounts to a huge figure. But if your records are perfect, then you can always go back to the record and check what is the payment pending from a particular patient. You can train your auxiliary or your attendant or your receptionist to follow up with that patient and to recover that money as soon as possible. Confidentiality. Now, along with documentation and records comes this clause of confidentiality, which is a sacred bond between the doctor and the patient. Please remember that whatever a patient tells you, whatever you are writing down on his form or document, whatever his investigations, reports, x-rays, lab reports are, is between you and the patient only. You are not supposed to divulge these details to anyone. Do not divulge it to your friends, to your fellow practitioners, to your professional colleagues, or to your family members. No. The only way you can divulge these details are when the police or the judiciary asks you to hand over the patient's details for any medico-legal case. That is the only time you can hand over the details or the investigations or the pictures, etc., to the police or the judiciary, if it is asked for any kind of legal case. The other time when you can hand over the details are for any kind of research or forensic odontology work. Dr. Manu Dhillon was here. He was talking about forensic dentistry, forensic odontology. He just touched upon one small aspect of forensic odontology, that is age estimation. But actually speaking, forensic odontology is a huge, vast area which is now growing in India. And please remember that the Indian judiciary and the Indian criminology system, that is the police, are making more and more use of dentists who are trained in forensic odontology to help them in medico-legal cases and in criminal cases where a forensic dentist can help them in coming to a right conclusion. So, anytime if your patient is involved in such a case, the police or the judiciary or the forensic dentist is going to come to you and ask for certain details like the cast, x-rays, clinical pictures, CBCTs, MRI scans, lab investigation reports, whatever is available with you, they can ask you for such kind of purposes, and it is your duty to give it to them, and they should return it to you. One thing you can keep in mind is that before you hand over the records to a judiciary or police system, please ensure to keep a duplicate record of those in your clinic. Because somehow our filing systems in judiciary are not very enhanced, so they might lose your records, which is your loss. So to overcome that, make a duplicate, hand over the other ones to them, but keep a copy with you in your clinic. And of course, in research work, especially in academic institutions or in research institutions, when we do any kind of research in forensic odontology, that time also the records and the documents are required. So, all these are important. What are the components of an ideal medical or dental record? So, these are the things that you should remember. Personal identification sheet, consent for treatment. I will just touch upon the consent at the end. Treatment summary, diagnosis notes, clinical progress, treatment progress, surgical report if any kind of surgery has been done, whether it is minor surgery or major surgery. Investigation reports like X-ray, pathology, etc., and follow-up reports. Consent form should be signed by the doctor and the patient. The patient identification details should be complete. All essential information should be recorded, dated, and signed. The dental assistant should take care that all the notes or documents, if you are keeping it in file format, are filed in the clinic. Medication, surgery, anesthesia, principal diagnosis, treatment procedures, reports, referral, discharge summary if you have an inpatient in your hospital. All these are the typical dental records. All these are what we are learning in the dental colleges. The medical history, dental history, bleeding disorders, cardiac disorders, family history, pregnancy, physical and emotional tolerance for procedures. Now this is a new thing which has come, which is called as the emotional quotient in dentistry. And it is my earnest request to the budding doctors, to practitioners, that when you are writing down the details of the patient in your document, please write this particular aspect, that whether the patient is physically or emotionally fit to undergo that procedure. Because believe me, this will save you a lot of trouble later on if the patient suddenly refuses to go ahead with the treatment once you have started any kind of treatment which is multiple visits. Say an implant procedure or a full mouth rehab or an aesthetic procedure. Records will be primarily clinical in nature. Meticulous record keeping should be done. Now here, let me tell you the slight difference between document and record. Document is what we write down on a sheet of paper or a file, or we write it down on an electronic form of record in the computer or a laptop. When we record it and we store it in a recording system, and we also keep with us their pictures, x-rays, lab investigation, models, casts, whatever physical records we have, then we call it as a dental or medical record, which is now being recorded and been kept in the clinic for a certain amount of time. Legible entries is most important. I've already told you, otherwise you end up with very peculiar and awkward situations. Maintenance of dental records. Electronic records are always preferable, friends. I would request all of you, there are very reasonably priced ERP solutions or dental softwares available throughout the country. My advice would be to go for electronic records. You can keep a paper record with you. You can get the patient's details filled on a paper form on the first day. But eventually, shift it to an electronic record, because, mind you, it will be a permanent record. You will not lose it. And you can always add any kind of details that for an ongoing treatment on the electronic record, which may not be possible on a sheet of paper. Of course, there are people who disagree. You know, the old-timers are always with their papers and files, and if you go to our institutes, in my own institute, we have one huge room which is full of patient records, OPD papers, for the last, I think, 15 years. And I'm trying to get a machine to cut those papers and dispose it. But yes, that is the sad truth. You should also differentiate between active files and passive files in a busy practice, or especially in institutional settings, where you have hundreds and thousands of records of patients. Once the patient's treatment is done, please define a certain period. After that, put it into an inactive file so that your clinic does not get cluttered. There are certain things to be understood, like I just told you in the beginning, that avoid writing personal, derogatory remarks on the patient's document. Your remarks should be factual, to the point. Maintain chronological order, because all these things, if recorded correctly, are the ones which are going to come handy to you in any kind of a judicial case. Retention of records. Now, a lot of dentists, students, they ask us that how long should we retain a patient's record in our clinic, a hospital, or a dental college. So again, this is a slightly gray area, friends, that different organizations have given different time limits for keeping these records in a dental practice. For example, our defense forces say that the records should be kept permanently, but if you have space constraints, then you can keep it for records, x-rays, study models, correspondence for 11 years after treatment. For children, till the patient is 25 years of age. And for orthodontic models, retain the original pre and post models permanently, discard the intermediaries after 5 years. Now, this kind of retention of records may not be possible once your practice reaches a certain growth phase of 5 years or 7 years, because you won't have space for anything else in your clinic or in a college or hospital. It will be full of the patient records. So, this is what it's going to be, a never-ending list. And that is the reason why I tell you to switch to electronic records. Otherwise, it's going to be a bhul-bhulaiya. What does Dental Council of India say? Dental Council of India says that minimum period of 3 years from the date of commencement of treatment in a authorized format by the council or any standard mode of documentation. This is what Dental Council of India says. And they have also mentioned that if there is any request for the medical or dental records by authorized attendant or legal authorities, it should be issued to the competent authority within 72 hours. What does IDA say? Indian Dental Association mentions that all records should be maintained for a minimum period of 8 years. We have already done this, confidentiality. I have just added a small slide of communication with the patient. Now, these are soft skills. I also speak on soft skills in dentistry because that was one of the finer aspects of clinical dentistry that I came across, especially in corporate world when I was with Clove Dental. And of course, being in academics, being a teacher for more than 32 years now, soft skills are something which our dentists lack, unfortunately. And most of the communications that we have is a very professional type of communication where the patient doesn't get the personal touch. Our professor of pharmacology yesterday and Dr. Professor Tikku sir also mentioned that जो हाथों की शिफा है, वो हाथों की शिफा कहीं खो गई है डॉक्टरों से. And that is why I would request the young doctors, the practicing dentists, that listen to your patient. Listening to your patient is going to solve half of his problems. The other half is given to you by the patient himself. Otherwise, it leads to confusion. And the patient can sue you on many aspects. Treatment not done properly. You have given me somebody else's x-ray. The time taken for the scaling was very less. I still have pain after endodontic treatment. My bleeding did not stop. You did not give me the correct medicine. You did not tell me the correct procedure. You charged me too much. There are hundreds of questions which the patient can raise. And friends, you will be lucky if they don't go to court with these questions if your records are not kept properly. So if your documentation and record is good, and after that, your communication has been perfect to the patient. After that, if the patient accuses you of something which you have not done and tries to take you to court, this will be your kavach. This will be your armor against any kind of malpractice suit that the patient can put against you. Please give them realistic expectations, especially from aesthetic procedures, especially from orthodontic treatment, especially from implant placements and the implant crowns that you're going to give. You have to give them a realistic picture. I remember one young lady a patient of Clove Dental in Delhi. She was continuously accusing that particular clinic in my zone, where I was the zonal head in Delhi, that I am going to sue you because your orthodontic treatment did not give me the promised result. And the promised result was what? Apparently, the orthodontist who had seen that lady first, she was a young girl of 25 or 26 years, and she was about to get married. And apparently, the orthodontist had told her that she will get Aishwarya Rai smile once the treatment is over. And now that the treatment was about to get over, the debonding was about to be done, and when she used to look in the mirror every day or probably 10 times a day, she used to see that thing and she said, I don't have that Aishwarya Rai smile, so your promise is false and I'm going to sue you. So for such things, patients, and especially corporate dentists or corporate chains, are soft targets for patients, believe me. I used to handle at least 3 to 4 complaints every day of the week, being in Clove. So I can understand that how patients target these corporate chains and practitioners nowadays. Do not cut costs by using substandard materials or, like our good friend here who is doing the treatment on webcam or online. Consent forms, there is one general consent form for all routine treatments which you should have. It should be in English and it should be in the local language of that area where you are practicing. If you are in Assam, it should be in Assamese. If you are in UP, it should be in Hindi. And you have to explain it to the patient in Hindi. Get the patient's signature. You should sign, the practicing dentist should sign, and store it in your clinic for any further malpractice suit. And of course, for certain surgical procedures, there are separate consent forms. Nowadays, if you look up on the internet, there are consent forms given separately for other separate treatments also. Like endodontic treatment, you have a separate consent form. For orthodontic treatment, you have a separate consent form. Implant treatment, you have a separate consent form. So if you wish, you can get it filled up, but please get it filled. Explain to the patient, he should understand, sign it and give it to you. You are safe. Payments, of course, like I said, please see that the payments are taken on time and communicate well to the patient. As teachers, it is our duty to communicate to the patient when the student, to the student also, how to communicate with the patient when they enter into the clinics. And to conclude this topic, let's recap that please listen and communicate with the patient, record, treat, document, communicate and follow up with the patient. It requires a certain amount of teamwork, not only between the dentists, but also between the auxiliary staff of the dental clinic, hospital, or the academic institute where you are treating the patient. Thank you very much for a patient listening.
Thank you, sir, for this wonderful lecture. I would like to call upon Dr. Pavitra Rastogi, sir, Dr. Anmol Bagaria, ma'am, and Dr. Ashish Chandra, sir, to please felicitate our speaker. Thank you, sir. Thank you, sir. Thank you, sir. Our next speaker of the day is Dr. Ratika Solanki. Ma'am is an eminent pediodontist and she is practicing presently in Dehradun. Please welcome Dr. Ratika Solanki.
Hello, good afternoon to one and all. So the topic for my presentation is child psychology in dentistry. So what can you all depict from these pictures? Anxiety, certainly yes. So these all are suffering from one or the other form of anxiety, and everyone has feelings of anxiety at some point in their life. For example, you may feel worried and anxious about sitting an exam or having a medical test or a job interview. So these all are anxiety. What we want to basically understand in this is talking of the dental fear. So dental fear and dental anxiety, these effects are involved in majority of people, but they appear to develop mostly in childhood and adolescence. So we must aim to reduce this stress with the knowledge of individual psyche, for which different theories have been given, for which I will be explaining this in the further presentation. And the children who do not want any treatment to be done just because of the fear and the anxiety of dental office, this is the most common feature which is seen in children and adolescents as well. So with the use of psychological interventions, dentists may reduce barriers and resistance, and they may strengthen the treatment alliance. So it's now drilling down on dental fears. So starting with the child psychology introduction. A successful dental practice, it is basically dependent on any interaction between a patient as well as a dentist, and it requires an active cooperation from the patient throughout the necessary and lengthy dental procedures. There have been great psychologists who have studied human mind for years, and they have developed theories according to their understanding of the psychology and its development over the years. So to understand its clinical implication in our day-to-day practice, we must first understand the psychological development of humans. Psychology, what is psychology? It is a scientific study of behavior and mind as defined by Passer and Smith in 2007, and is also defined as a study of behavior and mental processes as defined by Kuhn and Mitrer in 2007. Coming on to the clinical psychology in dentistry, what it aims at. So what we need to know is knowing the patient better, and we need to understand the behavioral problem psychologically. We need to deliver dental services in a very effective and a meaningful way, and we should also establish effective communication and gain patients' confidence. There have been various classifications of theories of psychology. First is the psychodynamic theory, which includes psychoanalytical theory, psychosocial theory, and the cognitive theory. And second is the behavior learning theory, which includes the classical conditioning, operant conditioning, hierarchy of needs, and social learning. So starting with the psychoanalytical theory, this was given by Sigmund Freud in year 1905. And he was the first to discuss the unconscious mind and its role in human behavior. He believed that there are three levels of consciousness. First is the unconscious mind, which exists outside of your awareness all the time. Second is the preconscious mind, which includes all information that you are not currently aware of, but that can be recalled. And finally, the conscious mind, which is your state of awareness. So this theory includes three parts of personality. First is the id, which is the biological component of the personality, and it is always selfish and needy, and it operates according to the pleasure principle. And then there is ego, which is that part of the personality which makes your decision last, and is the superego, which is basically concerned with what is socially acceptable. It stands for instinctual drives, and it is mostly unconscious, and it is governed by the pleasure-pain principle, which aims at satisfying the libidinal urge that is immoral, illogical, and it lacks unity of purpose. Ego is integrating or mediating part of personality, and it develops out of interaction of it and the environment, and it has perception of both the internal and the external world. For example, hunger must wait until the food is being given. Third is superego, that is the internal part of any individual which makes judgment, and it acts as the individual's conscious and is idealistic. Talking of the erogenous zones, so Freud believed that there are at different stages of life, human beings, they feel tension most intensely in different areas of the body, and this requires pleasure-producing stimulation to reduce or for elimination of the tension which has been created. So these areas are termed as the erogenous zones. Talking of fixation, so the concept of fixation is that it desires for the it changes from age to age. However, there are some individuals who never lose their desire of particular kind of gratification, such as oral stimulation, and this is what we call as fixation. So what are the causes of fixation? When a child gets extremely frustrated in the pursuit of pleasure, or if he is over-gratified by it, the person becomes continuously concerned with obtaining the pleasure. So that leads to fixation. Moving ahead with Freud's psychosexual stages of development, which includes oral stage, the anal stage, phallic stage, latency, and the genital stage. Talking of the oral stage, in this the child gains pleasure from sucking, biting, chewing, and then he develops a sense of comfort through oral stimulation, and during this stage they are totally dependent on their mothers. So what are the symptoms of oral fixation? Firstly, a child is completely dependent on others, and they do not take any initiative on their own, and they also have a very laid-back attitude. Next is the anal stage, and in this what happens, the child gains a sense of control over the environment as their mother try to toilet train them. So this pleasure comes from using the bladder and the sphincter muscles, and this is how they can control part of the environment, and they are no longer dependent on their mother. So what is fixation? It denotes an object relationship with an attachment to people or the things in general persisting from childhood into an adult life. A person fixated on the anal stage may be messy or disorganized, a condition known as anal expulsive, or they might be anal retentive, which is uptighting and controlling. Talking of the phallic stage, in this the pleasure feelings are mostly associated with the genitals. So what Freud believed was that the kids in this stage, they feel sexually attracted to their opposite sex parent, and they get jealous of the same sex parent. So in this what happens that the boy, they develop attraction for the mother. What are its clinical implications? They basically include the presence of mother for a male patient in the operatory is very much desirable. And the castration anxiety, it comes from the fear of punishment from the fathers for the desire of their mother. So this is the clinical implication. A similar Electra complex for girls was given, in which girls get attracted to father, and the clinical implication includes that at this stage the presence of a father for a female patient in the operatory is very much desirable, as was for a male patient. What are the symptoms of phallic fixation? A person who has this thing is very much weak, confused, and has a very confused sexual identity, and he may also be afraid of or incapable of close love or intimacy. In the latency stage, a child focuses on areas like academics and athletics, and the same-sex friendship developed during this time, and other characteristics like mastery over skills, maturation of ego, they also take place during this stage, and this phase ends in puberty. During this age, the modeling is done by showing same-sex and age individual having his or her treatment being done very calmly. And then this child may behave in the same calm way. So if he is showing a treatment or any procedure being carried out in a smooth way, in a calm way, so he will also enact the same thing when this thing is the procedure is being performed onto him or her. And this extends from onset of puberty until young adulthood. The primary objectives are ultimate separation from dependence on and attachment to parents and establishment of mature relations. Coming on to the clinical applications in dentistry, we have anxiety neurosis. This term was introduced by Freud to describe a syndrome of general irritability, anxious expectations, attacks, and breathlessness. Like, for example, the extraction of patient might become very anxious and he may start complaining of irritation or breathlessness. Erickson's stages of psychosocial development is is a comprehensive psychoanalytical theory which identifies a series of 8 stages in which a healthy developing individual should pass through infancy to late adulthood. So these are the 8 stages of psychosocial development, and I will be explaining these one-on-one. First is trust versus mistrust. In this stage, the initial stage is emotional development, and the basic trust or lack of mistrust in the environment is developed. So a strong bond should be developed between a parent and a child. The clinical implications in early age is that the treatment is preferred always in parents' presence. And at a later stage, a child with limited sense of basic trust and is extremely frightened and uncooperative. He will also need special efforts to establish rapport and trust with the dentist who's performing the procedure and the staff which is involved there. Second is autonomy versus shame and doubt. So this stage begins at around the age of 2 years, and it is often said that the child at this age seems to be undergoing the terrible twos, that is uncooperative and frequently obnoxious behavior. The child moves away from the mother, but is still, he will try to retreat her in threatening situations, and this will develop a sense of individual identity and autonomy. So for obtaining cooperation at this stage, the child needs to think whatever the dentist wants for his or her choice. Offer the child reasonable choices whenever possible. For instance, you may either provide her with the green or yellow napkin for the neck, and you should allow parents to be present during the treatment. The next stage is initiative versus guilt. So in this, the development of initiative, it takes place when the child is, he continues to develop greater autonomy, but now he adds on to planning of the vigorous activities. Initiative is shown by physical activity and extreme curiosity. The clinical implications in dentistry is that the child is very much curious about the dental office and is very much eager to learn. An exploratory visit with the little treatment is made for a better dental experience. Talking of industry versus inferiority, at this stage, the child is entering into a competitive and a working world. So the influence of parents as role model and the influence of peer group, they come into action. The clinical implications in dentistry are that children, they are trying to learn the skills which define their success in any situation. So clearly telling the child how to achieve those goals and positively reinforcing those goals in them, it gives a sense of accomplishment to the children. And this, instead of saying, if you wear this appliance, your bite will be better, tell the child that his teeth will look better, and this is going to motivate him more. So that is the approach which we'll use as a clinical implication while performing any procedure. Next is the identity versus role confusion. So in this, the adolescence is a period of physical and psychosocial development in which unique physical identity is acquired. This stage is marked by emerging sexuality, will have changes in physical ability, increase in academic responsibilities, career possibilities begin to be defined. So the clinical implications is that since parental authority is being rejected, such as orthodontic treatment if we are talking of, it should be done only if the patient wants it and not just to please the parent. So we need to seek permission from them as well. The adolescents, they are more aesthetic conscious, so with their consent, the treatment should be provided, which is more aesthetically pleasable and as well as functional. Also, approval of the peer group is extremely important at this stage. Talking of intimacy versus isolation, it begins with compromise and sacrifice, which leads to partnership and career goals. The clinical application is that the adults seek dental treatment like orthodontic treatment, diastema closure, bleaching, for improvement of their appearance, that they can attain intimate relationships. Next is creativity versus stagnation. So guidance of the next generation is a major responsibility of the next generation, and it becomes successful and supportive if the parents are cooperating with the same group of people. So the clinical implication includes that dentists should always motivate parents to guide their children and teach them the importance of a good oral health. Next is integrity versus despair. In this, there is attainment of late integrity, and there's a feeling that one has made the best of his life situation and has made peace with it. An opposite characteristic of this is despair. The last stage is despair. In this, the individual will face new sense of self, overfill bodies, and need for care, and they will achieve a new sense of wisdom. So the limitations are that it is subjective and it cannot be generalized, unscientific, very little free will, and patients may even reject if they are not willing for the procedure, and it may also be very difficult to prove them wrong. So these are the limitations of this theory. Talking of the cognitive development theory, which was given by Jean Piaget, who worked for several decades on understanding children's cognitive development. So what do we understand by the term cognitive? It means the process of acquiring knowledge and understanding through thoughts, experiences, and senses. All organisms, they adapt to environment in which they survive, often by means of very complex adaptational mechanisms, which include operation, schema, assimilation, accommodation, and equilibrium. Operation is an action in which the child performs mentally and which has an added property of being reversible. Schema represents a dynamic process of differentiation and recognition of a knowledge which results in evolution of behavior and cognitive function apparatus for the age of child. So for example, a child who has just learned the word bird, he will try to assimilate all the flying objects into his idea of bird, and when he will see a bee, he will probably think that it is a bird and probably say, look, it's a bird. However, it is not in real. So this is about it. Assimilation, it concerns with observing, recognizing, talking upon an object, and relating it with earlier experiences and categories. Accommodation accounts for changing concepts and strategies as a result of new assimilated information. Equilibrium is a stage in which there is a result of new knowledge to the child, and it helps explain how children are able to move from one stage of thought to the next. From the perspective of cognitive development theory, life can be divided into 4 major stages. The first stage is the sensory motor period. The second is the pre-operational period, then is the period of concrete operation, followed by period of formal operations. In sensory motor stage, child's interaction is mainly non-verbal and object permanence is learned here. So that is, the object do not disappear when the child is not looking at them. Second is the pre-operational period, and here what happens is that main characteristic which start happening in a child is beginning of language development, egocentrism, animism. They have this inability to conserve and irreversibility. The pre-operational stage can be divided into preconceptual, which is marked by the start of symbolic activity, and a stimulus begins to be taken when the child can represent other objects. The clinical implication is beginning of language development. So if a young child, he fails to consider important features such as function, so they may understand some words quite differently from the adults. In concrete operational period, the child becomes capable of logical reasoning. The conservation of property and reversibility of thoughts take place. For example, now the child could watch the water being poured from one glass to another, for example, and then he can conclude that the amount of water remains the same no matter whatever the size of container is. So he has that specific thing in mind. Now he can differentiate the objects very particularly. Last is the period of formal operations. So in this, what happens, the adolescent, they develop the concepts of imaginary audience and personal fable. In imaginary audience, the adolescent, they believe that they are constantly on stage, being observed and are being criticized by those who are around them. Whereas in personal fable, the adolescent feel that he or she is unique or special. The clinical significance is that due to this concept of imaginary audience in personal fable, it becomes a challenge for the dentist to help them more clearly see actual reality that is surrounding them. Coming on to the theories of learning and development of behavior, we have classical conditioning theory and operant conditioning theory. The classical conditioning theory was given by Ivan Pavlov. It is a type of learning that had a major influence on the school of thought in psychology known as behaviorism. Classical conditioning is learning that results from association of pairing of two stimuli in the environment. It is a type of learning which requires a capacity to evoke a response which was originally evoked by another stimuli. So this is a famous example of classical conditioning where the conditioning bell experiment was used on dog, where the bell was the neutral stimulus and the food was the unconditioned stimulus. So during conditioning, the bell along with the food showed unconditioned response, that is salivation, and after conditioning, the bell became conditioned stimulus, which had conditioned response of salivation. So the clinical implication is that in first visit, a child sees a white coat doctor, which is a neutral stimulus, and the pain of injection is an unconditional stimulus. And this will stimulate the response, which is fear and crying. So here the child associates white coat with the injection. In the second visit, this white coat becomes conditioned stimulus, so the sight of which gave him fear and anxiety and crying in response. So now this would be adaptable for him. Alexander et al. In his study concluded that about 62% were scored as anxious children. Of all anxious children, 69.9% had preference of colored attires of the dentist, and 66.8% of children prefer dentists with the protective wear. So the female dentists were preferred by 66% of the children. Behavioral theories in relation with classical conditioning are systemic desensitization, aversion therapy, and flooding, which include coping strategies in which therapist teaches the patient and progressive expression. The aversion therapy is exposed to a stimulus when the patient is subjected to some form of discomfort, for example, habit-breaking appliance such as thumb guard and palatal cribs. Flooding is an accelerated version of systemic desensitization, and either through mental visualization or real-life contact it can be achieved. Talking of operant conditioning, this was given by B.F. Skinner. It is a significant extension of classical conditioning, and the basic principle of operant conditioning is that any consequence of a particular response will affect the response which is occurring in similar situation. So there are basically two kinds of reinforcers. First, in which the probability of occurrence is there, and second, in which the probability of occurrence of target behavior decreases. The four basic types of operant conditioning, according to Skinner, are positive, negative, punishment, and omission. In positive reinforcement, the response strengthened by presentation of pleasant stimulus affects behavior. The clinical implication is, for example, a child is given a reward such as a toy for behaving good during her dental procedure visit. So she is more likely to behave well for the further dental treatments which are going to be treated her for, and this behavior was positively reinforced. Another example is that treating the child in the presence of mother, this will act as a positive reinforcer in her behavior. In negative reinforcement, response strengthened by the removal of unpleasant stimuli is there, and as an example for its clinical implication in dentistry, a child who views a dental visit as an unpleasant experience may throw temper tantrums to go there. If this behavior succeeds in the further visit, it will become a negative reinforcer and is more likely to occur in every dental visit. So we can ask the child to send his mother out of the dental operatory, and if he does not behave well, the fear of having alone with the dentist, the procedure being carried out alone with the dentist without his mother might make him behave well during the treatment. So this will act as a negative reinforcer. Talking of omission, if a child who throws temper tantrums for his favorite toy being taken away for a short duration of time, the probability of similar misbehavior gets decreased. And another example includes sending the mother out of the dental operatory, as I just told you, in order to make her child behave well in the operatory. In punishment, response is strengthened by presentation of an unpleasant stimulus. One mild form of punishment is what we can use is voice control. So what it involves is speaking to the child in a firm voice to gain his attention and trust for the dental procedure to be carried out in the operatory. The most suitable reinforcement in the dental offices are positive and negative reinforcer. Moving ahead with the observational theory, which was given by Albert Bandura, recently named as social cognitive theory. Albert Bandura conducted a Bobo doll experiment, which is shown by a clip of women hitting Bobo doll to make small children. 88% of the children copied the same thing, and this experiment showed that children change their behavior in response to what they watch. So this type of learning appears to be distinct. Much of a child's behavior can be learned from observing siblings, other children, or even the parents, and if their procedure is being carried out and the child is being made to see the procedure carried out, so even he will cooperate in the next visit. There are two distinct stages in observational learning. One is acquisition and second is actual performance of that behavior. The clinical implication is that if we allow a younger child to observe the elder one calmly, receiving dental treatment from the same, this would greatly increase the chance that he will behave in the same calm way. Faisal et al. Conducted a study to offer a suitable method with psychological base to establish children's calmness on dental visit, and he concluded that the technique of telling story to the children made them more familiar and cooperative and had more comfort and confidence, which decreases stress and fear during the dental visit. So coming on to the conclusion, people who often view dentistry as a fearful and stressful procedure, so what we need to do is we need to familiarize the procedure and theories of psychology, which would aid as a behavior modification part for an individual as per the situation, and this would help in getting a better response during the treatment. So we need to have a thorough knowledge of a psychology of the child's psyche and development, which would help us to better understand the related issues of the patients and elicit behaviorable and favorable response to cope up with the stressful dental situations. Thank you. Any queries? Good to go. Thank you so much.
Thank you so much, ma'am, for this wonderful session. I would like to call upon stage Dr. Pavitra Rastogi, sir, UP State Dental Council President, Dr. Arafat, who is an endodontic consultant at Sardar Patel Dental College, as well as Dr. Anmol Bagaria, ma'am, and Dr. Ashish Chandra, sir, to please felicitate our speaker with a memento. Also, I would like to request Dr. Shivam to please come up on stage for the felicitation of our speaker.
सर आप सर का आपका सर का
Please give them a huge round of applause. Thank you so much, sir. Our next eminent speaker of the day is Dr. Vinay Gupta, sir. He is a professor and head of the department at Department of Public Health and Dentistry, Faculty of Dental Sciences, King George's Medical University, Lucknow. Please give him a huge round of applause.
Okay. Good afternoon, respected chairperson, And thank you, organizer, to give me this opportunity to speak on. My topic is tobacco cessation and dentistry. So, greeting from Department of Public and Dentistry, which was recently developed, and now we got post-graduation also in this department with the 3 seats. So, tobacco, as we हम लोग सुनते आ रहे हैं कि टोबैको, तम्बाकू, इस तरह की उस तरह की, मगर अगर हम इन फार्माकोलॉजिकल टर्म में देखें तो टोबैको इज़ द ओनली लीगल ड्रग दैट किल्स मैनी ऑफ द यूजर्स व्हेन यूज एग्जैक्टली एज इंटेंडेड बाय मैन्युफैक्चरर. मतलब जैसा मैन्युफैक्चरर चाहता है उस तरीके से ही यूज़र यूज़ करता है. सो टोबैको किल्स मोर देन 8 million people globally every year. In India, approximately 1.25 million. So more than 7 million deaths are from direct tobacco use, and 1.2 million are due to the second-hand smoke. Second-hand smoke is maybe most of the people don't know. Then if you're nearby like area, somebody is smoking and you are inhaling that smoke, that is second-hand smoke. So there's a global adult tobacco survey which was first conducted in 2006 and 7, and second one is 2016 and 17, which has seen in in India, the tobacco consumption has been decreased from 34% to 28%, but in UP, especially in UP, that consumption has been increased drastically, especially in smokeless tobacco. So tobacco shares most of the common risk factor, as in chronic respiratory disease, cardiovascular disease, diabetes, cancer, and other non-communicable disease. So it shares the common risk factor. And one of the factor is the tobacco. So if you go into Gates 2 Global Adult Tobacco Survey, it has seen mostly into global Gates 2, the most of the people want to quit the tobacco, but they are not having the facility how to quit. So later on I will tell how to quit and what facility government has given. So understanding that nicotine addiction and tobacco cessation. So why do people not quit? The fear of managing craving, because people are having user of tobacco, so they are having difficulty, they are getting difficulty in quitting. So because nicotine is an alkaloid and having additive potential more than heroin and other thing. So it's very difficult to quit. So need support for quitting. So loss of primary coping mechanism, emotional attachment, self-reward. Worth is believed everyone has to die. The most of the tobacco user, especially in rural areas, they think सबको मरना है तो क्यों इसकी चिंता करना? Because we are in public health, we are going in society, sometimes in oral screening, and the people are using tobacco. So they used to say सबको मरना है साहब. कभी कभी कहते हैं कि मेरे फादर को तो इतने सालों से 20 साल से खा रहे हैं. तो ऐसा नहीं है. एवरीबडी इज हैविंग डिफरेंट रेजिस्टेंस मैकेनिज्म, डिफरेंट इम्यूनिटी फॉर दैट. तो द जंगल बिलीव दैट एवरीबडी विल कॉज कैंसर, कि कोई ना कोई चीज़ खा रहा है तो कैंसर तो होना ही होना है. सो दीज आर द criticism from the user side coming. So when you're taking the puff or nicotine, within 10 seconds it reaches to the brain through the blood, and it releases the dopamine from the receptor in the middle, basal ganglia. So when dopamine is the self-rewarding hormone chemical, so it gives the person to kick or feeling good. So that's what again urges to having this tobacco consumption. So that complete the pleasure circuit. So what is the role of dental professional in the tobacco cessation? So dental professional are the unique position to help the tobacco user by providing cessation assistance. Because patient you can see is very easily the patient having poor oral hygiene and with the stain and other. Even you can see the person is using what type of tobacco. If it is having gutka, if it is having smoking, if it is having canny, so we can see what type of a stain is coming from all these things. So identify and pool 6 studies that shows a benefit of tobacco cessation counseling by dental professional. Intervention by dental and other stuff can increase the tobacco abstinence rate 6 months. So, skill for rendering the tobacco cessation, like what are the things persons should have, tobacco cessation counselors should have, even in dentists. So, communication, you have very good communication with the patient or user. Clinical, even when you are going in the oral cavity, you should identify. Negotiation with the patient, problem solving, motivational and assessment. So, dental treatment integration. So, integrate assessment of tobacco use for every patient. Whenever any patient comes, always ask, are you using tobacco? That habit should come in the dentist, that every patient, you have to ask from every patient. So, identify tobacco user and recommend non-user to never start. Tobacco use and oral health in general. Teachable movement, utilize chairside time, like whenever you are treating the patient, always ask with the patient, are you using tobacco? And if you are using tobacco, how to quit? So, even sometimes patient is not willing to quit. So, there are many factors also. So, sensitize patient of tobacco use and impact of dental treatment outcome. Address, follow up and schedule well. Make patient aware of total economic cost attributable to the tobacco use, like how much you are spending. That is also a factor to, like, patient ko bataya ja sakta hai ki how to, like how much money you are spending that and how you, why you need to quit. So, there are behavioral intervention in tobacco cessation. So, why do tobacco cessation? So, minimal intervention, like less than 3 minutes if you are spending with the patient, so the chances of 13% cessation rate. If it is 3 to 10 minutes, it's 16 minutes, and more than 10 minutes, 20. So, described in the study if you are at all. So, number of session, like 12% of one for one session and 24% for the program at least 8 session should be there. So, why like use of pharmacotherapy, just like nicotine, nicotine replacement therapy and like antidepressant drug. So, if people are using, or even sometimes we need to refer to the psychiatrist for those severe addicted patients. So, there is a Prokaska and diclementa cycle for mode of change in the behavior from the pre-contemplation phase to like relapse. So we have to like in pre-contemplation phase, the patient generally no intention of changing the behavior, like they don't want to quit that tobacco habit. And in contemplation phase, like aware a problem, usko मालूम है कि हाँ उसको problem है, मगर वो no commitment for the quit. In preparation phase, intent upon taking action means okay, he's ready, and now come to the action. And later on in maintenance phase, and sometimes patient in maintenance phase, patient relapse again for tobacco use. So the cycle is going continuously. So developing a quitting plan is a star. So set a quit date as soon as possible, focus approach, and motivate to achieve your goal. Tell your family and friends, just ask like we are quitting the tobacco, so don't talk about tobacco and away from these friends and family members. So anticipate challenging upcoming quit attempt, like just to divert your like whenever, because tobacco nicotine is coming, like every time you will not have those withdrawal symptoms. It's a sequence of like once you are having you are having craving, that part is only for 2-3 minutes. अगर आपने वो चीज़ निकाल दी, then it will come after later on. So for that you need distraction, few exercises. So just to tell the patients also. So remove tobacco related products from the environment, like minimize tobacco use. So brief intervention by frame like feedback of personal risks and impairment, emphasis on personal responsibility for the change, clear advice to change, menu for the alternative option. Just give them option ki other than other things relation for the tobacco, like you're quitting, like many things are coming in the like saunf and lychee and long. There are many things are there. So give the option for changing tobacco. Dental professional need the empathy facilitate silent self-efficacy. There are 5 approach, there are 5R approach, motivational interviewing, and added nicotine replacement treatment, integrated dental care. So there are algorithm for delivering brief tobacco intervention. Patients, once ask the patient about tobacco use. If it is using tobacco, then advice should be clear, strong, and personalized. If it is not using, then ask, do not not to use tobacco, and don't allow to use tobacco nearby. So, and if it is like using, then after the assessment, assess if patient is ready to quit. If they are ready to quit, then assist and arrange. If it is not, then there are 5R approach for intervention. So 5A model is give 5 to 15 minutes for the patient about ask, advice, assess, assist, arrange. So in asking the patient, like systematically identify all tobacco users at every visit. Whenever patient is visiting to your clinic, ask the patient about the tobacco use. Ask all of your patient at every encounter if they use tobacco, and register the information in the patient dental record. Just like when a patient, sometimes patient is going for medicine and other department, so doctors are writing like BP and sugar, these things. So always write on the note about tobacco use. Make it a part of your routine with the patient. So advice is persuade all tobacco users they need to quit. Should be clear. It is important that you quit now, or I can help you. Cutting down is not enough. It should be very clear. Sometimes patient says like, "Sir, मैं कम कर दूँगा." It's not like that. You have to stop or set a quit date also. Strong as your dentist, I need as your dentist. You just mention the patient like, as your dentist, I need you to know that quitting tobacco is most important thing you can do to protect your health now and in future. We are here to help you. So personalize the advice like related tobacco use to the health concern and social factors. Assess the readiness to quit. Ask 2 questions in relation to the importance of self-efficacy. So would you like to be a non-user? Do you think you have a chance of quitting successfully? There are Fagestum tests to check the nicotine dependency in the patient. There are a few set of questions. Just ask the patient, like most important things. Sometimes patient, like when tobacco user get up in the morning, within 5 minutes, if he is using tobacco, it means it's a severe kind of dependency. And ask the how much of tobacco use. So there are a few set of questions for nicotine dependency. And assist, help the patient develop a quit plan, like a start, let's say set a date, tell the family and friends about last slides. So provide practical counseling, provide inter-treatment support, provide supplement material including information on quit line. There is one quit line, national quit line, toll-free number, which if any patient is using tobacco, he is not having any facility, so they can call them, and the quit line and the series of things are there, so they will help you. So recommend the use of approved medication if needed. Arrange a follow-up contact with your dental patient, either in patient or by telephone. Refer the patient to the specialist support if needed. Sometimes like psychiatric department support is needed for the patient in severe cases if it is not able to, like from the counseling and behavioral thing. So cost calculation for tobacco use strategy, so just mention about how much tobacco you are consuming and what the cost of that, and just calculate that, and you can mention that in a year you are spending that much of amount and later on you can buy it. So that thing is also there in the tobacco session. So common withdrawal symptoms which patient are tobacco user are feeling, like irritability, fatigue, insomnia. So for that, what is the coping strategy for these all symptoms? So like 5D approach for coping. Sometimes, as I mentioned, like this nicotine craving is only for 3 to 5 minutes. If it's that time, you pass that time, so you will not have craving. So there are 5 practices, D practices, like delay just wait for, sometimes patient is taking बार बार यूज़ करने लगता because of these. So delay the movement, drink water, deep breathing, distraction also, and discuss with the family and friends. So there are 5 approach: increase the motivation to quit, relevance, risk, short-term risk, long-term risk, reward, about health benefits, and also monetary benefit. Roadblocks, what are the barrier comes in when you are quitting the tobacco. So repetition, when every visit the patient, you have to mention about tobacco use. So relapse, lapse and abstinence, these are the cycle going side by side. So pharmacotherapy in tobacco suggestion. So indication: use tobacco within a first 30 minutes of waking up. Use more than 20 cigarette, a score of more than 6. In Fagerstrom term, they tell there is a mild, moderate, severe. 1 to 5 is mild, 6 to 8 is moderate, and then more than 8 is severe. So on the Fagerstrom nicotine dependence. So there are the different nicotine therapy like patches, gums, lozenges. So NRT, nicotine replacement therapy. We are giving nicotine outside other than tobacco, in the nicotine in the form of nicotine gums, like it available in the 2 and 4 milligram, and nicotine patch available in the 7, 14 and 21 milligram, or nicotine lozenges 2 and 4. Basically in India it's very common this nicotine gums, but now is this patches is also coming, because once you are taking the patches, so 1 milligram of nicotine is released in the blood, so the withdrawal symptoms, whatever withdrawal symptoms is coming, so it will not come. And depending on 21 milligram or 14 milligram or 7 milligram. So nicotine gums doses, if it is patient is having 1 to 24 cigarette or BDs, then 2 milligram 9 to 16 pieces per day for 12 weeks is recommended, and for more than 24, 25 like cigarette and BD, 4 milligram 9 to 16 pieces per day for 12 weeks. So there is a method of chewing this nicotine gums. You have to chew, जब तक chew करना, जब तक taste उसका खत्म नहीं हो जाता, then after that you have to park the chewing gum between the area of premolar and buccal pad. Duration for treatment, like maintain for 6 to 12 weeks, followed by gradual reduction in the 6 to 12 weeks. For a strong dependent user, a long period of nicotine replacement therapy may be advised to prevent relapse. Nicotine patches, if you smoke more than 10 cigarettes, then step 1, 20 milligram step for 1 to 6 weeks, and step 2, 14 milligram from 7 to 8 weeks. Then step 3, 7 milligram. It's in a decreasing order. Once the level, after that we have to tapering. Ultimately we have to quit this thing from the nicotine. So if you smoke 10 more than 10 cigarette or less than, so start from the 14 milligram to 7 milligram. So nicotine lozenges is also available in the market. Common contraindication of NRT use: gastric ulcer, recent like cerebrovascular accident, uncontrolled hypertension, acute MI, unstable angina, and under 16 years, relatively contraindicated. So this is the drug. Basically, generally, dentist, special tobacco counselor, or provide this bupropion. Basically, this is given by this drug is antidepressant and given by psychiatrists. So we are not using this drug, but basically most of the places dentists are using this because it's a safe drug. So this can be used for tobacco counseling, tobacco cessation. So there is a role of technology in tobacco control. There are few places M suggestion app register. There जो patient हैं जिनको आप बता सकते हैं कि this is the app, you can register over there, and after that they will tell how to go for tobacco quit. So or toll free number 1800112356. This is a good number. It's in Delhi. The TB Chest Institute is there. There are many counselors are sitting over there, and they regularly, from time to time, they will ask the question and mention how to quit it. So there are many available resources for training for tobacco cessation. So in conclusion, in the training of dental healthcare professional, educate people in community, advise all persons using tobacco, counseling and dental care, harm minimization of tobacco use among exposed and unexposed patients. Thank you.
Thank you, sir, for this wonderful lecture. I would like to call upon Dr. Anmol Bagaria, ma'am, to please felicitate sir with a memento.
Can you repeat again, ma'am? Can you repeat again?
Usually, sir, when patients come to us, it's their family members who are worried. So the patient itself, the tobacco consumer, he is not interested at all. So other than saying, "Aapko cancer ho jayega," what do you suggest that we can ring the bell that they have to do this?
Yeah, that's what I'm telling, that most of the time patient says, but if, as per our experience in the department, most of the patient comes like when they are having patches and problem in the health, like BP, if you tell them properly, like I mentioned that your advice should be very clear and motivational. So most of the time patient want to quit, but having difficult, definitely it is difficult for them to quit. So you have to follow up, like आपको वहाँ जाके मतलब even you have to call them. They are not like उनको नहीं चाहिए, मगर because we are in the government institution, तो हम we are used to call them also कि आज आपने लिया तो नहीं लिया, तो we have this.
So you were talking about people who come to you for help. What about whose family members are asking for help और हम उनको बस patient को बता सकते कि आप छोड़िए, quit कीजिए, आपको कैंसर हो जाएगा. Anything else जो मैं बोल सकती हूँ? नहीं,
basically क्या है ना कि anything else नहीं, patient को तो अगर आपने देखा होगा कि इवन पाउचेस पे लिखा होता है, गवर्नमेंट इस तरह से काम कर रही है, जो कोटपा एक्ट है 2003 का, उसमें जो वार्निंग शाइन है उसमें क्लियर कट मेंशन किया हुआ है कि इवन आज की डेट में सिगरेट या टोबैको के ऊपर भी आपने देखा होगा, दे मेंशन द पिक्चर ऑल्सो. इवन देन दे आर नॉट लाइक खाने वाले लोग, क्योंकि मैंने क्या बोला कि जो टोबैको का एडिक्शन है दैट इज मोर एडिक्टेड देन हीरोइन एंड अदर दिस अब्यूज जो भी.
तो एक और चीज़ बता दीजिए अदर देन कैंसर कि कैसे डराया जाए.
बेसिकली अभी रिसेंटली हम लोग इसमें ये भी जो मेल आदमी है उनको ये भी बोल देते हैं हम कभी कभी, ये है ऐसा भी है, इम्पोर्टेंसी के लिए हम बोलते हैं समटाइम्स कि एक्चुअली ये रिसर्च में भी देखा गया है कि जो स्पर्म काउंट है इट हैज़ बीन डिक्रीज एक्चुअली. तो पेशेंट को जब ये बोलते हैं तो थोड़ा घबराता है, क्योंकि मेल पेशेंट को यही, अगर मेल को इस तरह की चीज़ें बताई जाती हैं, जनरली हमारे पास ये देखा गया, हमने जो हमारे पास आते हैं कि पेशेंट को अगर दिक्कत है कोई तो रियली दे वांट टू क्विट, दे वांट टू क्विट. अगर कोई भी हेल्थ प्रॉब्लम है, स्पेशली लीजन अगर है तो बहुत जल्दी क्विट करने की कोशिश करता है, वो डेली चक्कर लगाता है कैसे ना कैसे, गलती से उसको और भी दिक्कतें हो रही हैं तो डेफिनेटली वो छोड़ता है, कोशिश करता है. मगर मैं ये नहीं कह रहा कि 100% रिजल्ट है इसमें. टोबैको सजेशन अगर 20% तक भी है तो बहुत अच्छे रिजल्ट है, तभी तो इस तरह से बढ़ रहा है. आप देखेंगे टोबैको का कंजप्शन किस तरीके से बढ़ रहा है आज की डेट में, तो और खासकर रूरल एरियाज में बहुत ज़्यादा है. यहाँ पे तो लोग पढ़े लिखे हैं तो चलो एक बार के लिए सोचते हैं, जैसे अभी हमारे KGMC में ही अब बहुत लोग ऐसे होते हैं, जैसे हम स्कूलों में जाके लोगों को अवेयर करने की कोशिश करते हैं बच्चों को. अब टीचर खुद ही खा रहा है, यहाँ इंडिया में तो ये बड़ा कॉमन है ना, अब गाँव में जाके टीचर खुद खा रहा है, तो हम टीचर की भी काउंसलिंग करते हैं, पहले टीचर ट्रेनिंग करते हैं. मगर मैं ये नहीं कह रहा कि हम जो दे रहे हैं उनको 100% वो कर देगा. कभी कभी तो हम अभी रिसेंटली वी आर डूइंग वन PhD थीसिस, तो टीचर प्रिंसिपल और टीचर खुद कह रहे हैं मैम कहाँ हमको फंसा रहे हैं. तो एटीट्यूड हैज़ टू बी चेंज. जो मैंने आपको जो साइकिल दिखाई है, बिहेवियरल साइकिल स्टेजेस दिखाई हैं, प्री कंटेम्पलेशन, फेज टू कंटेम्पलेशन, देन एक्शन, तो वो उस चीज़ पर लेके आना है हमको पेशेंट को. और वो ऐसा नहीं आपने बोल दिया आ गया. देयर मैनी अदर थिंग. अगर ऐसा होता तो आपने देखा होगा मूवीज़ में नीचे लिख के आता है कि टोबैको या अल्कोहल इज इंजurious टू द हेल्थ, नीचे लिख के आता है जब भी कोई यूज़ करता है. ये बेसिकली जो कोटपा है 2003 का एक्ट है उसकी देन है कि जब भी कोई मूवी में या किसी में दिखाया जाए तो नीचे यह मेंशन जरूर किया जाए कि टोबैको इज इंजurious टू द हेल्थ। तो तब भी पेशेंट नहीं छोड़ना चाहता, जब उसको दिक्कत होती है तब वो छोड़ता है, इसमें कोई डाउट नहीं है, वो तब छोड़ता है, रियली में छोड़ता है। तो इसीलिए मैं क्या कह रहा हूँ, पेशेंट को, डेंटिस्ट एक ऐसी जगह पर खड़ा हुआ है जहाँ पे पेशेंट को अगर आप बताएं, जब भी पेशेंट आपके पास, बिकॉज इट्स टाइम टेकिंग प्रोसीजर ऑल्सो, तो डेंटिस्ट डोंट बॉदर अबाउट दिस थिंग, बिकॉज डेंटिस्ट आपने देखा होगा प्रैक्टिस में कभी डेंटिस्ट बच्चों को ज़्यादा टाइम नहीं देता है ट्रीटमेंट करने, ओल्ड एज को ज़्यादा ट्रीटमेंट नहीं देना चाहता है। तो ऐसे इसमें टाइम देने वाली बात है, तो बेटर है कि आप पेशेंट से पूछिए और उसको रेफर कर दीजिए जो काउंसलिंग कर रहा है।
Thank you, sir.
Thank you.
Sir, for your points.
Thank you, sir. Dr. Anmol Bagaria, ma'am, please come up on stage and felicitate our speaker. Thank you, ma'am. Thank you, sir. Our next speaker for the day is Mr. Deek Parasini. Sir is a motivational speaker and public figure from Dubai. He's the founder of Life is All Positive Foundation. Please put your hands together for Mr. Deek Parasini.
You want to give my introduction? No? I had to give it? You want me to give it? 1 second. Just give it. There are senior people here also, right? So, just 1 second. So that will be just doing something else actually. You have time, no? Any more people are coming in? Do I have a handheld mic? Where's my introduction? Here you go. What's the introduction? You want to go? Okay. She's going to give my introduction, then we can continue. So you guys have an overview before I start my talk. Go ahead.
Our speaker today is Deek Parasini, who believes that life is always positive and negativity doesn't exist. Give him few minutes of your time and he will prove it. I know you all might be thinking, how is it possible? But Deek is here to tell you how. With over 20 years of work experience in marketing, sales, engineering, and psychology, gives him a wide-spanning experience to draw from. He is working as a regional sales manager, Middle East and South Asia. He has completed Bachelor of Science from USA, MBA from Birla Institute of Technology, India, and then MSc in Business Psychology from the UK. He has talked to thousands of people of various age groups and touched their life with positivity. Majority of his sessions are Q&A sessions, as he believes whatever motivation is given, people, if their core problem is not solved, then no motivation can help. He is active of social media with over 500,000 people in his community and has a WhatsApp group with over 10,000 plus members, where daily positive messages are shared among the group members. Please join me in welcoming Deek Parasini with a huge round of applause.
Thank you. I think most of you already know me. I was there yesterday, and I see few of the people have already learned from the message which I gave yesterday, which is when you have an opportunity of a speaker in front of you, always come and sit as close as you can so that there's a reason behind it, right? When a speaker speaks, there you go, come on, let's come forward. See, I'll tell you that I know some of the faces. You guys didn't take the action. These 6 people took the action. So you see, that makes the difference over here, right? Willful ignorance. I remember I told many of you how great is willful ignorance all about. See, this is the other smart way to bring the audience closer, right? So thanks a lot, whoever came forward. Now, the people who was there in my session and sat back, what you got to learn over here is even though you had the message yesterday, you couldn't take the action today. So what is happening here? This group took the action, this group didn't take the action. That clearly shows that they are always ahead of you when you compare yourself to them. It is not life not giving you the opportunity, it is you willingly ignoring the message which you get in some form or the other and making it useful, or just say, it's okay, my friends are sitting at the back, I will also sit back. So that's the learning experience I can tell to people who still sat back and who was there in my last session. So how many of you was there in my last session? Just to understand the hands. So these are all new, new, and new, and new. Okay, fine. So they are the people who are sitting back. So good. So I'm a person who believes that life is all positive, negativity doesn't exist, which means sadness, frustration, anger, addiction, all that is generally created by human beings because of various reasons. As a baby, we were always happy in everything, and we were all positive. People who were there in my last session, just ignore the 5-10 minutes of my talk, because there's a new set of audience which I have to respect. So I'm just going to give them a little bit of what you already heard, so maybe they will also trigger and understand what I'm up to. So as a baby, we are always positive. We are all born positive. That's how God has created us. But with time, we tend to be an adult, thinking that tension is the way of life, frustration is the way of life, stress is the way of life, and all these various factors is the way of life. And you think that that is what life is all about. That's where the problem is. If you're born as a baby, my concept is live like a baby and die like a baby. If in the last session I already told you, I can roll on the stage right now lying down if I want to. If someone asks me, sir, can you do that? I will do it. For me, it doesn't matter, because I'm a baby right now also. Most of my sessions is a question-answer session. You can ask me any question from birth to death. Any questions which is bothering you, any questions which is irritating you, any questions which you genuinely want an answer, which you are searching in your life. Most of my sessions, not most, all my sessions I do as a giving back to the community. All my sessions are always done free of charge. Now, many great people who's in business-minded people will think that, okay, later he might charge. As long as I'm alive, all my public sessions and private sessions will always be free. Many of you would have already talked to me personally. I didn't charge for that, right? So that's what I believe by, because positivity is something which you have to give people and not even expect anything in return. That's what I have believed. Now, how do you ask questions? You can ask me a topic-based question, which is anger management, or I heard a topic of addiction in the previous conversation, how to get out of addiction, how to get out of, smoking was the topic, no? How to get out of smoking. I'll tell you how to get out of it, right? If you ask me, right? Because I believe that only if you ask, I'm going to say, because my main objective of the session is not to give you the answer. At least if you stand up and ask, you will get the answer. And when you get the answer, next time you have another speaker like me, you'll ask there also. And then next time you have a teacher to ask a question, you'll ask there also. That helps you to grow faster. The more you ask, the faster you grow. That's what I believe in. What are you doing in your school? Asking for different doubts, questions, books, read the books, and you write the exam based on the information you have, you grow. So we as human beings is constantly growing because we are asking. The day we stop asking, we stop growing also. That is the truth of life. You can say that, yeah, no, it's not like that and all, but you're all asking for something. If you want a promotion, you have to ask. If you want the girl who you want to get married to, you have to ask. Right? If you want extra marks, you got to go and ask your teacher. Try it, you will get that 10 marks. I always got. Right? But many people don't ask what teacher will think. Yeah, 10 marks is more, or what teacher is going to think is more. You ever try this? When you get low marks, and if the teacher has control over the marks, go and ask her, ma'am, 5 marks, please. If you get that 5 marks, good, no. But we are not asking. We have the huge self-respect which we have. As I keep saying, self-respect is the most negative word in this world. We have this self-respect which we keep. And that is what creates all the problem. There's 3 ways you can ask me a question. One is a topic-based, anger management or whatever it is. One is a general question which is your problem. Like, the ma'am asked yesterday. I have this problem, and there's this problem. You can ask me directly that way, which is what I would prefer. Or the third option you have is, my friend has this problem. Don't tell it's your problem. So no one, or you don't get disclosed by any means, right? Some things could be a very, very personal question that you can ask me after the session also, if you want. But why I say if you want is, my belief is, meet me once, clear all your doubts, and forget me. I'm not here to make followers. I'm not here to sell a book. I'm not here to sell a course. I'm not anything of that. Meet me once, clear all your doubts, and forget me. That's the overview of what I do. This is all you need to know about me, because that's how I do my sessions. It's a Q&A. The more you ask, the better for you. The more you don't ask is easier for me, right? Because life will teach you regardless, right? Whatever I'm telling you, I won't say anything new. Now, whoever is my previous session, whatever I told or whatever I tell is already what you know, but I tell in a different twist so you understand and realize that where it is actually getting wrong. If you ask me a question, I will never give you a personal answer. I will give a general answer so it benefits everyone. And then I give 1-2 twists, and that might trigger you or get you the answers which you're looking for. Questions? Whoever is new, I know you might have planned for your questions. So I hope you planned for your questions. If not, then I got to ask the other people to trigger the talk. Any questions you have? Who was there? Yes, ma'am. What happened? A feedback? Okay. Guilt of what? Something in the past you feel heavy, like... So is this a breakup or something like that? Kind of, okay, fine. So let me explain. Right? See, now if you ask me half the question, I'm only going to give the half the reply. If you ask me, ma'am yesterday asked all the questions, I gave 100% reply and she's freed from it. So you ask me half the question, I give half the reply. You give me the full question, you give me the full reply. If the full question is too private, ask me privately, right? Now, first of all, let me tell you why do breakup happens, right? That's the most important factor, because if you don't know why the breakup is happening, it doesn't make sense. Now you'll ask, this speaker is talking of breakup. 70% of the girls and boys who come to me came with a breakup issue only. Not education, not concentration, nothing of that sort. Everyone came with a breakup issue. I said, I don't know why people are going in the first place. So let me tell you how love works. You want to know how love works? Yes or no? I know you are all in the problem, some way or the other, right? So I'll tell you how love happens. I know I'm going to talk a non-medical talk over here, but what I believe is, if you have a love issue, how much if you try in a concentration of studies is not going to come. I'll tell you now. So my problem is to solve all these problems so you can easily go after your career, easily go after the marks which you're worthy of. So basically making you more worthy for the society. That's my main duty if you really ask me what I do. How love happens? You want a girl's point of view or a boy's point of view? Girls? Okay, since I'm a boy, I'll take a boy's point of view, right? You can replace boy whichever way you want. It all starts with me looking at a girl. Right? You look at a girl, and then what happens? You will compare with a celebrity who you like. That's how your first attraction starts. You can say infatuation or what, that's how the first attraction starts. Then you will tell your interest to your friends. And the friends will say, hey, go propose. Well, do it, man. Good match. You'll get, yes. Whenever you directly go and propose a girl, generally she will say no because she doesn't know you. So whoever gone and proposed directly, you're doing stupidity. Best is to start with friendship. That's what smart guys do, right? So first you start, or you become her friend's friend first, and then use that angle. I'm not telling how to propose, but this is how most people get into, right? So I'm okay with friendship. I have no problem with friendship. But what happens is sometimes friendship generally stays in your 5 senses, and sometimes it goes to your mind. But friendship is okay. Girl and boy, best friends is also okay. There's nothing called love at first sight. It only happens in the movies. You won't see he coming in the horse, the flower falling, and all that, right? It doesn't happen. It only happens in the movies. But what you're going to understand here is that it's not only the guy going after the girl also. Always remember, the girl will also, move her hair like that, come and stand in front of you, and all that different levels also they attract you. Because that is how our instincts are. Friendship is okay. But when do you cross this friendship and move into an unnecessary relationship is when the first statement, if a girl or a boy says that, my problem is your problem is my problem. That is when you cross, many people are smiling, right? So you might have heard this dialogue coming here, oh, whatever problem I am there for you, right? That's how my problem, your problem starts coming into the picture. Now, when you say my problem is your problem is my problem is your problem, slowly you will think that I cannot live without you. Problem solver, no? I want this permanently in my life. So that is how you get and assume that from first it was senses, she is good looking, then she solves all my problem, now I want her forever. Now, if both girl and boy goes into the heart, it's okay. But 99% at this age normally can't go both to the heart. Some people put it in the eyes. For example, the guy, why I'm taking time to make you understand is because if you figure out this, half of your life is set. That's the reason I'm taking time to make you understand. So when you cross the line is when you become friends and all that. And after that, when you are in this relationship, sometimes the breakup happens. Now you'll ask me why. One reason, let me give you a boy's example. Boy only put the girl in the five senses. She looks good match. When I'm walking, your friends will say, oh yeah, good girl you got, man. What a great pair you both are, and blah, 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 blah. So you think that is really good. So you walk. Another beautiful girl comes. He will start looking at her. That time the irritation, jealousy will start stepping in. Right? Because he's only kept in the senses. So once a new better sense comes, oh, good looking, irritation will come, friction will come, breakup will happen. Now let me give a boy's point of view also. You know, boys in this love, they go very helping mode. Right? Whatever is there, I'll help you, I'll pick up your bag, I will drop you here, I'm there for you. You come up with that statement. Right? When you go at that statement, you help, slowly you will get tired, no? How much you going to carry the girl and walk? And when you put her down just to take a break, she will say, oh, you got some other girl to carry now? You don't have time for me? And friction, the breakup will happen. Yeah, you took a break. But no, she wants you to carry. Why she wants you to carry is a gap filling. Gap filling in the sense means somewhere around I didn't get my mother's care. Somewhere around I didn't get my father's attention. Somewhere around I got some injustice between my brother and sister. This guy gives me that temporary attention. This girl gives me that temporary care. I assume that is love. Once you're satisfied with that, you want another one. Right? So you are getting into the relationship just because of that gap which that guy or girl is filling for you. Once the gap is satisfied, you'll get bored of the guy, break up. Once another beautiful girl comes, you're going to look and break up. So breakup happens when there is a difference between the mind. So there's three processes, no? Eyes, senses, mind, and heart. That's the process it goes. When there's a difference, the conflict will come and the breakup will happen. How to get out of breakup? Why do breakups happen? To make you realize that you're dumb at selecting. Right? We all make mistakes. So somewhere around we are dumb at selecting the guy or a girl. So learn from it. Many people who have past relationship and go on for a second relationship, I can sign and tell you that is also ending up a breakup. Why? You're in search of filling the gap. You got this guy. You're going to do. As long as you are the same, the boys who come into your life also will be the same. As I told even yesterday's talk, the more you hate someone, that person will keep repeating. The more you want a certain type of people in your life, they will also keep repeating. Why? You are dependent of them to keep you afloat. Now, after the breakup, first thing is, don't find out that why he left me or why she left me. Be thankful, God, that he left me so I know who's the right guy. Because most of the things, what they do is after breakup, they find out why he left me, slowly it will move, it is my fault, because the love is still there, no? You can't blame the love too much. So what you do, you come back and say, blame yourself, And then you say that I am wrong, I am wrong, I am wrong. That is when the guilt steps in, which means I made this big mistake. No, he made the big mistake that he's not worthy of you. It's the other way around. You like something, you can clap it, not a problem, right? Right? So it's the other way around which is actually happening from that perspective, right? So people are not worthy of you, that is why they're leaving. Or people are coming into your life to teach you that there is much more better person who's worthy of you. So all these people are throwing you away is telling you're much more worthy than that person who you are. But then you stay as a thrown away person is when the another person will come to throw you again. Right? So if you don't change, it will keep repeating until you change. So be thankful to the guy he broke up with you. Then there is no more guilt anymore. Be thankful to the person that they left me to show me that this is not the type of relationship I should be in too. Because if he wouldn't have come, or if she wouldn't have come, you would get married to the person and then the breakup will happen. There, not only your life is getting spoiled, your family's life also gets spoiled. If you have kids, the kids' life also gets spoiled. And then you go divorce, then you find out another person, you mess up their life also because you are still the same again. So if breakup happens, be thankful to that person. When you're thankful, no, you see him as a teacher, teaching you that you're dumb at selecting and you chose this wrong guy. Many people in this gap filling also goes into the physical relationship, which is stupidity again. Most guys will say, let's see, chalta hai, let's see however it goes, we'll go on and see future, who knows, kisko pata hai, kya hone wala future ko, let's enjoy right now. Yeah, that's all scammy dialogue to misuse you. So if some guy says, I can't give you commitment, there is no future in the relationship, full stop. That's what I believe in. So if a guy says, no commitment, we'll see future, no commitment physically also, no commitment talking-wise also, and get back out of it. The last thing, when you're getting into the relationship, many mistakes girls and boys do is make sure the caste, religion, and what's one more thing? Religion, caste, and status or whatever it is same. Now you say love is blind. Yes, love is blind when you go deep. Before going into that, my problem is your problem. Hey, caste, religion, same? No, okay, no. Because your biggest challenge is going to be your parents. I'm telling you, many girls and boys come to me asking, sir, I love this guy, I had this physical relationship, how do I tell my parents? That was the first session's question I got. Now it's too late. You're gone physical. How do you get out? It's a question which you can. But obviously, there's a way to get out of everything. Don't worry, because life is the beautiful thing. It teaches you in different ways and shows you where your weakness is. And never feel that you made a mistake. You had, God or universe had to give you the experience, so next time you wisely choose the guy who you're going to get to live forever. Because if you don't learn from this experience, you'll attract the same guy. And many people get in the relationship for time pass. Always remember something, if you're being in a relationship from a time pass perspective, the future wife or husband who's coming will be a time pass guy also. Many guys especially have this thing that, I will time pass. Girls are like, enjoy. But the wife who come also will be a time passed one. Because God is very smart. Have faith in that guy. God or universe or whatever it is. He will only give you what you're worthy of. Right? And the other thing is, okay, that's it. I don't want to go more deep. Everyone has gone so serious thinking into a relationship. Oh God, am I messing my life up? But at least I can make you think. If it's not the right relationship, get out of it. Or else, someone is going to cry, and generally it will be you. Did I clear the doubt from A to Z? How to get out of it? Or still the guilt is there? Why do you want to convey? He is useless to you, no. A robber robbed you and went. Would you go to the robber? Why you robbed me? It's his profession, man. Let him do his stuff. See, everyone wants the answer why he left me. Hey, it's his wish. As long as you're searching for the answer, you won't get the answer. Slowly you'll drive back and you will be having this guilt feeling, thinking that I did something wrong. No, he threw you. He did something wrong. And when you start seeing that, that's his problem. But thank God he left me now, not after marriage. That is, be happy. Because after marriage he is gone. Your life is completely gone. Right? So confrontation, why do you want to confront people? Like when you know he robbed you, stay away from robbers, man. Don't go again and confront, and then again he will rob you. He'll say, no, sorry, yaar, man, I'm very sorry. And he will say his smooth dialogue, you'll fall again. And then he'll have another physique, and he'll again dump you. And again you're broken, again you'll say that I'm not worthy enough. When someone dumps you, stay. Many girls ask me, sir, after breakup, can I be friends with them at least? Right? Typical question. Right? Friend, sir, friendship is there, no? Yeah, a robber robbed you. You want to be friends with the robber again or what? It's common sense. Because once a robber robs you, he knows how to get into your heart. And he will figure out a way to get out of it if you open the door. Now many people say, sir, I can't say no to the relationship. If a robber comes and tells you where the gold is, would you tell where the gold is? No. Think everyone outside that relationship, which I keep saying, the 5 relationship, can always rob you with time and when situations come. So forgive him. And thank God he broke me. So now I know my true worth. Now I know which guy I'm worthy for. Now I know which type of person I have to be so that I can get that guy which I'm truly worthy, not a broken girl who needs that gap filling, and he comes with that gap and misuses me. It's only if you love you. Now, even loving yourself, I don't know, there's 2 sessions I did morning, I don't know which and when and what all I talked. Loving yourself is a very simple way to understand. When you look at the mirror, do you see you or someone else? How many of you see you? Everyone is raising their hand seeing you. Okay, when you look at the mirror, when you see your hair, do you see, oh, my hair is not that good? No? If the answer is yes, you're comparing that hair with someone else. If you look at the mirror and see that I'm dark, I have a scar on the face, oh, my dress is not good. Whenever you say that I am not good in one form, there is a comparison going on somewhere else. And as long as you're comparing, you can never, ever love yourself. For example, okay, thank you. Right? You can never love yourself. I'll tell you why. I can talk in front of you like this. I have no problems. Right? I'll talk the whole session like this. I have no problems. Because I know I love myself and what I'm doing is worthy enough in some form or the other. Right? See it from that perspective. Doubt clear now? Over from guilt? It's a choice. Right? At the end, it all boils down to the choice which you have to take at the end of the day. If you still want the answer, you're going to knock the door, give up, and again you will come back to the guilt. Why he left me? His wish, no? Why he left me? His wish. He doesn't like chocolate now. He likes strawberry flavor. He left this chocolate. Like why he likes chocolate? What is your point of view? That is his call, no? Why he likes chocolate and strawberry? That's it. So leave the people who are not worthy in your life. Don't go and question why. Because they will find a reason to justify you in there also. Because he knows how to get into your heart. As long as he knows how to get into your heart, he can manipulate you anytime. But why is he getting into your heart? Gap filling. So be careful. This gap filling is the biggest problem in this world. Stand up from that gap. What is he filling me? Is it the attention? Is it that recognition? Is it the acceptance? Is it that good love word which your mother or father is not giving? What is that thing he's giving me? Go and give it to yourself or ask your friend to give you, ask your parents to give you, then you don't need that. Now doubt clear? Oh, good. Go ahead. More questions? Anxiety management. Anxiety, what I believe is, anxiety normally happens somewhere around is, let me make it very simple. All these scientific people makes words so complicated, anxiety, depression, disorder, and make it so fearful. Let's make it very simple. What is anxiety? Something in future which you don't know about is called anxiety. Simple English meaning for anxiety. If you go and open the dictionary, you'll have a lot of weird meanings. This is the simple way. Something has happened, you don't know about it. But what people have done right now, the smart motivational speaker or the smart speakers, they said have only one goal and plan A, go focus on the plan A and go after it. If you only have plan A, anxiety will be there. Because you don't know, if I don't get plan A, what's my plan B? Right? So anything you're anxious about the future is because somewhere around you only have one plan for that. If I don't get this, I don't know what to do. For example, which college do I have to join for my master's? I have college A. This is the thing, this is the good things, this is the bad thing, this is the pros, this is the cons. Can I go? Will my parents allow? All that factor and find out. And it needs 90% of marks. If I don't get that 90% marks, 80%, which is the next college. Because marks is not in your control. I tell how much ever you plan your marks, 10 can go up and 10 can go down. Whatever you plan. Right? Because you know what, teacher's bad mood. Everyone, 10 marks are gone. Right? Teacher had a fight with a husband. 10 marks are gone for all of you. You know, that's the truth. Like, accept the fact. See, some things we don't expect. I expected 100 and I got 90. Teacher's bad mood that day. What are you going to do? Right? So sometimes the college will come. You won't get it. So have plan B. Have plan C. Have plan D. As much as plan you have, anxiety will step aside. But when you have only one plan and put all your eggs in one basket, you're always worried that will this basket survive or not? If this basket falls, what's my next plan? If this basket falls, what's my next plan? Until the anxiety drops. More the plan, lesser the anxiety. But then, once the plan is made, fully focus on plan A. Sometimes you will get plan B. But then, after 3 years, I finished my master's, PhD, how can I get into that college again? So again, you're back to the same plan A. But many people are forced to tell you that, no, focus on plan A, focus on plan A. It is dumb. Right? Because why? They want you to fail, and then they will say, please read my book, How to Plan Properly. Right? And they will tell you that. You will see, you know, that's how they pitch you. They tell you that you're not worthy enough. They tell you that, you know, you don't have it, I have figured out, I get up early in the morning, I have made this much money, you don't know how to do, so I will tell you. Yeah, everyone knows how to figure out their life from my perspective. But what they need is permanent solutions to the problems which they're genuinely going through. As long as you don't have that solution, no motivation can help. Doubt clear about anxiety? 100%. You can counter me also if you think I'm saying something wrong also. Not a problem. Right? Questions? Ask, yes. See, they will all misuse me. They know me, you know. I do what I do, right? So she was the best. Yesterday it was 5 questions from her whole team I took. Go ahead, yeah. Okay, good. Overthinking management. Overthinking, make it very simple. Overthinking is equal to free time. Full stop. Yeah. So that's what. So one step is overthinking generally is because of free time. The other reason of overthinking is unanswered questions about the past and unanswered questions about the future. Go and find the answer, overthinking will stop. Why he left me when I'm working? Why he left me? Why he left me? Why he left me? Why he left me? Yeah. 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 So then your mind will stop. Why not? So yes, it is a guilt, but I told you that it's good he left you. Why are you blaming yourself for that? General addiction. So I think this will link to the previous session also, which is come into. Addiction is generally, let me make a, do I give an example? Or let me give a point. Let me tell you what is addiction first of all. Addiction is you're doing something to forget something much more bigger. Addiction is any action which you're doing to suppress or forget or trying to forget something in the past. That is a simple meaning of addiction. If you open the dictionary, you'll get confused. How is addiction coming? You know Devdas and Paru? Everyone knows? There's anyone who don't know, raise your hand, so I won't tell the example. Everyone knows Devdas and Paru. Good. Devdas had Paru's love, and somehow the breakup happens. And that gap is created of Paru's love not being there. He fills that love with alcohol. So you can never stop a smoker from being a smoker or an alcoholic from being an alcoholic. You can only solve that core problem. Which means after a breakup, which Devdas happened, that gap he didn't solve it. That Paru is not worthy for me, Paru is not the right girl for me, and blah, blah, blah. He didn't justify the relationship, so he had to pick alcohol. Same applies to smoking, same applies. So everyone who you're addicted, you see most of the people play this game and social, PUBG and all that. That addiction is not because they're addicted to the game. They are worried that they're going to fail in the exam. What are you going to do? Get into PUBG, So you forget that I'm going to fail in the exam. See, whatever I'm saying is the general truth of life. If you want to accept it, accept it. If you don't want, leave it also. Life is going to show you a specific way of understanding. But if you really look at it, every addiction's core is that gap, is that frustration, is that stress. So my job is to clear that gap, clear that frustration. Now guilt also, why do many people get alcoholic guilt? Right? I've messed up my life, let's drink alcohol. And then just forget temporary. Now even party. Party is also one way of removing stress. You see in organization, they have this yearly party. That is 1 year of frustration remove over here. Right? You give gifts, you give awards, and man of the day, month of the... All this is to remove that stress which you're giving. But then, if you start loving what you're doing, you're never stressed. Now you tell me to speak for 3 hours, I will stand and talk for 3 hours. I have no problem. The more I talk, the more I'll have energy. Why? I'm loving what I'm doing. When you're loving what you're doing, there is no stress, there is no frustration. None of these negative feelings will ever come close to you. Like maximum, I've gone virtually 3.5 hours speaking. Like if I go to a college in the morning, I leave in the evening only. Right? Because I have no problem. The more I speak, you will see me getting energetic and energetic. That's what I say. When I talk, I meditate actually. Right? Whenever you love anything what you do, you are meditating in some form or the other. Yes, ma'am. How do you ask an addict is first you got to play their game, which means support them to do the wrong things. Support them or be a part of it. Like if your kid is too much on phone, go and play that game first and build their trust. Because if you don't build their trust and you constantly say don't drink or don't smoke, don't drink and don't smoke, you become an enemy of them. So how can I be a part of them first? How can I give them that hug which they need? How can I give them that love which they're looking for? Can I keep giving it for 1 year? That one fine day, that person, an alcoholic, will talk about Paru to me. And that is when you change that person. Not, don't do. More you say don't do, they are alone. And more they feel alone, they will go do that more. More you got to be part of it. Like for example, some parents ask me that, how can I control my kid from social media? Go into social media. Say hi on social media. Know what is happening there and why my son is stuck on social media. Give him the alternative to that, which is maybe going outside or giving him that recognition with the likes which he is getting in social media. If a mother starts giving that same likes physically or with that love, he wouldn't need that like which is on social media. And that's how you get out these. So there's some gap. When they are going to open up, I have no idea. But if you give love or if you give that care and attention which he's wanting, he will open up one fine day. But when, it depends on how deep he's in the relationship or if he genuinely wants to change. There's the other factor there, right? If he doesn't want to change, you can't do anything about it. But then if you keep giving love or keep giving that attention, keep giving that care, keep filling that gap, unknowingly or knowingly, one fine day he will touch that love. And when he touches that love, he'll say, oh, why not I give a chance? And that is when you take him and get him off. Right? There's an age factor involved in it. There's a criticality of the information. The other things is friends is also very important. If you can't get him out of that certain set of specific friends who's into it, he'll always go back to the friendship and bring that energy back and get it out. So the other question you have to ask is, can I be a very good friend of mine so he doesn't spend that time of his with that friend who are alcoholic? Right? So that's the other factor also. You got to think in how to get out of this. There's many factors if you start talking it out. But these are the few things to get. Yes, ma'am. See, different people have different roles in life. Right? If it's a wife and a husband, don't get tired. Keep doing until you die. Because at least when you leave this world, God or universe will tell you have done the best role which I have given you. Because when you leave this world, whoever sent you to this world will only ask you 5 questions. Where are you a good daughter? Where are you a good wife? Where are you a good mother? Where are you a good grandmother? Where are you a good colleague? Where are you a good friend? If your answer is yes, he'll be happy for the reasons why he sent you. But if you go and tell my husband was alcoholic, my children's mistreated me, I say like, that's their problem and not your problem. When he dies, I will have that discussion. Right? Everyone has to go and discuss. But from my point, I've done justice as a wife or a daughter to change my father or change my husband in a certain way, or my brother, whoever it is. I have done my best. And I'll keep doing my best because that relationship is given to me by God. He can kill your husband also if you want to. If your husband or your brother who's alcoholic is still alive, he can kill him anytime. But he's kept alive. Why? There is some service you need to do with him. Keep doing that and leave everything to the person who is sent. Because he has a different learning experience. And that's how you got to do it. Doubt clear? No? Yeah. See, when you escape from that, if you're frustrated with the alcoholic issue, you'll slowly see that your husband also will become alcoholic. Because you are, okay, ma'am is clapping means, okay, okay, perfect. All thanks to God for ma'am. Thanks a lot. So what happens is, the problem is when you start hating something and when you give up on something, why you got an alcoholic father? Why you got an alcoholic brother? There is a problem with you to get that worthy guy into your life. You have 2 options. Win over it. Help him to get out of it. But I'm not involved emotionally in it. When I'm talking to you now, you have talked various personal issues yesterday. I'm not emotionally bonded with you. I'm just here to help you, and I step back. So your father or brother, whoever it is, help them. But don't get emotionally bonded and you want them to change is when the problem is. I have done my duty as a daughter. I have done my duty as my wife or son or whoever it is. Full stop it there. See, I do my talks. I don't expect anything back. You can't control me. I'm never going to be emotional. If I hear some stories which I hear, I see, oh man, this will only happen in the movies. Right? I've talked to girls who got raped. I got talked to girls who got harassed. I talked to boys who suicided. No, not suicide, attempted, and they want to get out of it. Like I've talked to some stories are, it's movie material only sometimes I feel. Right? But then you can also get them out of it. But the point is, are you still in hate, grudge, guilt? It'll keep repeating. If you forgive, if you do your best, don't expect them to change. If they change, they will change. But I'm going to do my duty, full stop. Whatever question you ask me, I'm going to give 100% answer to that, full stop. You like it, you don't like it. That's your call. No, so now if you stop the grudge, which means if he or she comes alcoholic, you'll just smile there. Yeah, which you'll do. But smile, now there's 2 types of smiling. One is suppressed smiling, one is genuinely smiling, which you experienced yesterday. What is genuinely smiling? So when you see your father or brother alcoholic, is a genuine smile coming? Or why my father is like this? Smile. So if you why my father is like this and you smile, that pressure will build up, and one fine day you will see anger stepping in or frustration stepping in and all those stepping in. But if you forgive him and if you work towards improving him, you won over that irritation of someone being alcoholic. Right? Because that irritation is won over. So that your husband is also won't be that kind, or else he will also repeat. And if you don't learn from your husband, your child will be alcoholic. He will repeat. Until you forgive alcoholic people, then he will stop us. That's what I keep saying. Any person you hate will be there repeating in your life. Noticed? True or false? Anyone you type of people you hate, they will repeat. You are still, yes ma'am. Yeah. Yeah. Yeah, so that's what. No, whatever you hate, the person will come. So stop hating so God can send what you're truly worthy of. You see, you look at life. If you hate, they will repeat and repeat and repeat. When you change, they will. Like many people, many girls after marriage, they say, I hate my in-law. That's a typical excuse most girls tell me after marriage. What I did, be the best daughter-in-law you can be. Serve her equally as your mother. Two things will happen. Either you will move out of the family, which means you will get a better job, or your husband will get a job and you'll move out, or she will die. Wait for it. No, seriously, no. No, you become so positive that she's not worthy of a daughter-in-law like you. She has to leave this world and go. Because she's there in your life to teach you to leave her, forgive her. But you're not learning from it, then what happens? She lives longer, and the other part is, your son's in-law will also repeat in your life to show you the same lesson if you would have forgiven. Or your son's daughter will be the opposite of you, and you become the mother-in-law, and that time you might forgive the relationship. Because that relationship will keep repeating regardless of what we do. More questions? Yes. New faces. Yeah. Now, first of all, leave introvert people if they are happy. Right? Like I know many people, they say, sir, I'm introvert, my friend says be extrovert. Yeah, if you're a happy introvert, be happy introvert. No. Like what's the point? Like the most happiness is being a happy introvert. Great scientist is a happy introvert. Great doctor is a happy introvert. Right? Genuine doctors, they go zone, and artists, finance people, they are all generally introverts if you really look at it. But they're happy there. Right? So first of all, leave the introvert if they're happy. Now, if they're not happy, what do? Make him a better introvert. You get it, right? See, don't complicate life unnecessarily. Right? So what you need to do is, if he is an introvert and you know it's, yeah, you stay alone. You be happy in your alone life. Try to find happiness being alone. He'll be happy there. But you no. Come out, man. Let's go out. Yeah, he is getting more frustrated with you. That is point number one. Second thing is, he's genuinely hurt or whatever it is, then you help him out. Help him once, help him twice. If he doesn't want help, leave him. He will figure it out. Because if you over-intervene into any relationship, if you over-intern in any relationship, God is never happy with it. Why? God have a lesson for that introvert. You go and try to make an extrovert, he'll say, why are you involving in his life? I will give you extrovert problems. Figure it out. That's why he's left alone. Right? So help once, help twice. If he is not willing to stand up, leave him. Right? Now you'll say, sir, he might go and suicide. Let him suicide. At least he's introvert, he dies and he reaches where he has to reach. No. Right? The burden is over. Yeah. Right? See now look at the beauty of life. Just me talking, he came and became an extrovert for that minute. See, we changed him, no? Right? So now you ask the question on his behalf, he understood his point and he made him an extrovert for that few seconds. He came off it. Right? So that's what it should be. If you are a happy introvert, be a happy introvert. Don't try to push them to be an extrovert. Rather, it's much more better to make them more introvert. Right? More questions? Yes, ma'am. Good question. I love these serious questions. Okay. Destiny, there's two types of destiny. One is supreme destiny, which is already written, which means this is written, me walking this way is written, you moving your hands, it's all written in supreme destiny, which we don't have as human beings access to. Then there's a human level of destiny, which is completely in your control, which means I want to jump from here and I'm going to break my leg. It is my choice if I want to jump or break my head. For example, now I'll talk about simple destiny. Maybe you are all, few of you, whoever was not there in my last session, whoever don't participate, who was there. How many of you drink soft drinks? Raise your hand. How many of you raise? Raise. Let me see. All you drink soft drinks. Put your hand down. How many knows bad for health? Everyone knows. Who's creating destiny of a bad health? So don't tell me destiny is good. But what happens, no? After the health starts hitting, God, why you made my health so bad? That poor guy will also get confused. Like, what the heck, man? She's going and messing up and now you're blaming me. So nowadays, people use God as a blame stuff. Right? So as long as you use God as a blame stuff, He will play more with you. He's blaming me, no? So let me mess it more. See, God is the funniest part. When you doubt Him, He'll always do the opposite. Right? Because you're doubting, no? So that is the thing. So, supreme destiny is uncontrollable. It's there. Other human level destiny is 100% controllable. You can change it. So whatever you can change, go change. The destiny will change. For example, if a person is born and in his astrology, now I'm coming slowly destiny to astrology, right? In his astrology, it says that he is going to die at the age of 20. But once he understood the truth from the astrology that he is going to die at the age of 20, after the age of 10, he starts helping people from death or saving people's life. For the next 10 years, he saved 10 people's life. I'm sure that guy won't die at the age of 20. Right? So that's how the destiny changes. Right? You have complete control over it. So if you know you have a bad destiny by astrology, keep doing good. When you keep doing good, the good will supersede your astrology with time, which means karma supersedes your astrology, because astrology is written during your birth stars. With karma, the birth stars changes. And when the birth star changes, the result also changes. Now the other thing about astrology, what if the astrologer is having a bad time? Possible, no? He is also human. He can also have a bad time. So that time, is his guidance correct? Like everyone has a bad time, you have a bad time, so he's also human, he also has a bad time. And when the bad time you both meet, messed up completely. So astrology, just see it as a pathway. Some error is going to happen. Because this error is happening, I need to be a little bit alert to figure that out. So I will do good things so that it doesn't repeat. Now you come back to the supreme destiny. Even though in the supreme destiny it says that you are going to get a hit, you will get a hit. But the intensity of the hit depends on your karma. Which means you will get a very good slap, is also a hit. You will get a touch, that's also a hit. So when your karma changes, when you take the positive action, the hit, because it's written in the supreme destiny, will come. But the intensity could be reduced by the karma which you do. Doubt clear about astrology? Now superstition also. Superstition, you have any superstition, test it. Now biggest superstition is when the black cat crosses, you cross that line, there is an issue. How many of you believe that? Okay, few of you believe that when the black cat crosses, that's superstition. My question to people whoever believes that, what if it's a white cat? It's a problem? That's a question you got to ask. Is it only a black cat or is it a white cat? Now what if it is half black and half white? Right? What is going to happen? Because you got to see these things, no? How much of black impacts? What if the head is black, remaining body? Maybe it's okay. Right? So whatever superstitions you have, test it. Try it with consciousness. Or as what happens, a black cat crosses. With a fear you're going, black cat cross, black cat, something wrong. You won't see the stone. You'll trip over the stone. And you'll just see, I saw the black cat stone. Yeah, the stone you could have seen down, but you're looking up and cat crossed, God help me, God help me. So superstition is tested. Now other thing is there's religious things which you might assume it as superstition, but there could be some other truth behind it. Go and search of the truth and then reject it. Right? Some people say, what happens when you put a malas on something or do this prayer or do that? Go and research about it, what happens and why thousands of people are doing it. Something they might have got. So that is why they might be doing it. Doubt clear on that? 100%? Superstition, destiny, astrology. Go ahead. More questions? Yes. In what sense? See, self-personal development is what I keep saying is, don't complicate personal development so much. Keep improving every day in your life. Which means if you're a son, keep improving as a better son. If you're a good speaker, try to be a better speaker with time. If you're 80% student, try to be an 85% student. Automatically, your personality will improve. But when many people are there, I am like this, and people have to accept me the way I am, that is when you mess up your personality. Because I'll tell you why. Roles are changing. Now you're a student. After that, you're going to be a husband. After that, you're going to be a father. After that, you're going to, all that role, you have to change your personality also to meet that role. So my thing is, what is that you are feeling good, like bad about yourself? Improve. Not improve because someone else is doing. Improve because genuinely it is stopping you from growth. Many people, I know I've been told by many people, sir, many people that work on your weakness. No. Work on your strength only. Only work on your weakness if it's an obstacle to your goal, or else never ever work on your weakness. Which means if you want to be a Hindi teacher, learning English is a waste of time. But many people learn English, why? No, my friend knows English, no, so I have to learn. That is stupidity and waste of time. So your personality is who you are, and how do I improve and grow from it is the question you got to ask. Doubt clear? Yes, more. Yeah. Yeah. Oh, that's a very serious question. Okay, let me go back at it. Now you tell me you have a daughter. Let me see, it's very simple to understand. See, I'll tell you, I'll make it very, very hard. Question is very, very simple answer. If you have a daughter, would you tell her to go and sleep with the guy and get married? You have the answer. If you have a daughter, right, would you tell him go sleep with everyone who you want and then get married to who you like? Would you give that recommendation to your daughter? That is the answer to that. Forget religion. Why are you bringing religion? Religion is based on different beliefs and cultures and basis which they come. So the simple question is, would you give that recommendation to your girl child? Yes. Yeah, let it go bad. No, see, now you're back to let me talk to you personally on this, right? You know what? She's asking me half the question. Right? That's why she's just revolving around and I'm not getting to the answer. Right? See, now her friends are saying yes, because I know when people ask half the question, I know where the problem is. Right? Go ahead, more questions. Yes, ma'am. Oh, let me take a new person. Okay, anger management. Anger management is normally, hey, how's this? You're enjoying now? I'm not boring you, no? Oh, good. Okay. So, and let me give you a simple example of pressure cooker of anger management. We are all somewhere a cooker, right? You take this cooker and put it underneath a flame, right? The flame is someone calling me a bad word which irritates you. And when you put it underneath the flame, slowly the bubble will come, slowly the blister will come, slowly the whistle will come, and that is called anger. Now it is your call, for example, if your friend is pushing you to an extrovert, that is a flame. Right? If you have some past suppression about life or past irritation about life, if you have guilt, if you have various other negative experiences which are suppressing within, slowly the flame will start starting. Like yesterday's call, I told the dog example, right? Do you want to know the dog? Did I tell you the dog example? I did, no? You want to know the dog example? Okay, if someone calls you a dog, would you feel bad? No? If someone calls your mother a dog, there you feel bad, right? But what if, I'll go fast because they already know, what if of you and talk, I have no problem, right? But then what happens? See the amount of stress which girls go through in general. You have the straight hair, slowly you'll start curling, pressure, panic, tension, right? How much of stress you're actually going to take? See the pressure which you get. Yeah, I have my curly hair, I accept this, my hair is curly. Done. But the problem is the beauty parlor will have a loss. That's a different thing. But what is going to happen to you? You are free. Real independence. Many people, girls and boys, sir, I want independence. love yourself, you have all the independence which you're looking for. Right? But we don't love ourselves. We are constant time, be someone else, be someone else, be someone else. Confidence drops. And why they want to confidence drop? Only then they can take my product. No, then you'll get the confidence. Look like the heroes. No, you'll get confidence. So you need to be like someone else, which is not true. And when you try to be like someone else, that is when the mental issues start coming into your perspective and life. Right? That's why nowadays a lot of mental health and all that crap, I call it crap, right? Which is coming into the picture now. Right? Because it's easy, Mental things cannot be solved. So anyone can give advice of mental health. Right? That's the other thing, as a medication to the mind can never medication to the mind can never solve a problem of the heart. Right? Anyways, I've answered the question. What is next? Yes. Same question. Someone X means? Someone X, so I think my X is there. Okay. Which you are not doing. Which you have done. Okay. Good. But not the way he's getting appreciated. Yeah. So that's what, right? You're constantly comparing yourself to someone. And the beauty of life is, whoever you compare will always do better than you. Have you noticed that? Yes. Good question. Why am I? You can compare with person once. Learn whatever. Like if you want to be Sachin Tendulkar, study the Sachin Tendulkar for 1 year, I have no problem. After that, close Sachin Tendulkar and be who you are. Most people, what they do, they get into fan following, see every Sachin Tendulkar's match. Your energy is going to him. Never think that great celebrities and great sport artists is because, yes, their skill is there, their hard work is there. But most of the things is your energy is also there. Celebrities are celebrities not because they're celebrities. Celebrities are celebrities because they're using the fan follower energies to become the celebrities who they are. So, when you have some idol, learn about the idol, and the idol is dead for me. I'm going to be the best idol which I can be. Now, the other joke of life is whoever you compare will always do better, because comparison and jealousy is a form of prayer. I did talk last time. It's like a prayer. When you say this girl is a topper, he gets more appreciation. What are you saying? This girl is a topper, this girl is a topper, this girl is a topper, oh, this girl is a topper, oh God, this girl is a topper, topper. There, all your energy of your prayer is also going to make her a topper. You see, whoever you're comparing will always do better than you. That is the beauty of life. So stop comparing. How can I be a topper? How can I be better? I don't want recognition. I don't want people's validation. I'm going to give my best and do the best. Let God or universe, whoever is seeing me, will recognize me when it is the right time. That is what perfect, thank you. That is what I keep telling. Be the best student you can be. The right teacher will come. Rather than going in search of, sir asked me, sir, we need a mentor in life. We need a guru to get in life. Be a good student, the guru will come. That is much more easier. And that time, which guru will come? Who you're truly worthy of. But when you go in search of mentors or search of gurus, they will manipulate you also, because you don't know if you are worthy of that student or not. So make sure that clarity is also there. Next question. Hey, my job is done. I can continue, no? Okay, I can, no? Time is done? No, I can continue, no? Someone is waiting for me? Okay, I can continue. Okay, good. Good luck for you guys. Yeah, go ahead. No, anyone new? Yeah, go ahead. No, that's also not new. Anyone new? No? Coming back to the old people then. Okay, go ahead. Salty means introvert. I can continue? Okay, good. Okay. Be happy, no? The people's problem, no? Their problem, no? See, you are happy introvert. Live that happy introvert. Sometimes, extrovert people can't see happy introvert. That is the other problem. Like, how is so peaceful doing nothing? Like, I can't do that. Hey, come be introvert, be introvert, be introvert. Right? So that's why I say, introvert has to be the best introvert and extrovert have to be the best introvert, and that is how you got to work towards. Right? Parents don't understand their problem. But then, is it you're worthy of being an extrovert? That I don't know. Because if you're not worthy of, like maybe you have the capacity and because of some other personal problem, you've closed your doors into that, that's a problem because your husband, you'll get an extrovert to make you the real person who you truly are. So if you're hiding in the name of extrovert that, my life is all messed up and I still find happiness in the introversion, some people are there, they go take their zone. If that is a zone, your husband will again pull you. So I don't know if you're extrovert or introvert, but that you got to decide. Got it? More questions? Yes. Let me take a new person. Habit pattern. Any specific habit you want to win? So I can specifically talk about it. Laziness is a choice. Okay, he's talking how to improve laziness. Laziness is purely a choice. I'll tell you a simple example. If I tell you, come every day at 4 a.m. and 4:05. 4 a.m. and 4:05. You have 5 minutes. Every day you come in this hall. Behind this, you will get 1 crore rupees. I'm sure that day you won't sleep. 3:45, you will wait outside. Sir, please, I need to go. I won't tell you why. 4 o'clock, there is something for me I need to reach. You will request. You will figure out a way to reach over here, removing all your laziness issue. But what if I say it's only 10 rupees? Then the laziness, 10 rupees, who's going to pay all the cab and come all the way till here and then get that 1 lakh? So it's a choice. Second thing, when your mother makes your favorite food at home, before even she puts the dining table, you're in the kitchen eating. Right? Do you say, I'm lazy, let it come on the table, then I will eat? So all these laziness is a pure choice. Whatever is important and you have the value behind it, you will do it regardless. But if you don't have the value, you will take it easy. That's a simple definition and understanding of laziness. Doubt clear? So habit is a choice. Now, for example, why do you brush your teeth every day? Because in a childhood, when the tooth came out, your mother has put the fear, if you don't brush your teeth will get pain. So still you're brushing and going, a habit has come. Because you know the value. And one fine day you'll miss it for 2-3 days, toothache will come, again habit will come. So the pain, the value is there. So you're brushing every day. And one fine day you brush, nothing is happening to your teeth. I'm sure one whole year you won't brush. Nothing is happening, no? But then the pain comes, then again brush, and you'll start. Doubt clear on laziness? Yes. No, anyone new? Ask any question, any age group. See, I've done sessions to 5th grade students. Done? Okay, so my time is done. Okay, last question I'll take and my time is done. I'm here as long as you people want me to be here. Even though I cut this conversation, I will sit here until I clear everyone's doubt and then only I will go. So don't worry that you're going to lose me out. I'm going to be here as long as you clear all your doubts and go. That's why I say meet me once, clear all your doubts and forget me. So you don't call me afterwards, sir, I had this problem, right? I'm here, make use of me so you don't come back. Yes, last question I'll take and wind it up. I can take last question? No problem? Okay, done. Last question. So focus on life when family problems comes. First thing is, can I solve my family problem or not? Is the first question. If my mother and father is fighting, can I fix it or not? Because if you can't fix it, don't try for it. Because when 2 elephants are fighting, if you go in the middle, what happens? That is one reason. Now, if you have your family crisis which you control, which means you have a financial crisis which is happening. Can I get a quick job? Can I work it on and get that money in and figure out the life? Go get a job. That time don't say, I have a career, I have my life, I need to work it out from there. Right? So that is one step you need to figure it out. So if there is a family crisis, try to see if I can fix it. If you can't fix it, the focus will never come. That's point number 1. Second thing in family crisis is mothers and fathers use children as a garbage bin. Right? They have this family, Beti, your father is like this, Beti, like that. And they put the garbage onto your head. Then again, you can't focus. Maybe you stop the garbage, mother and father will fight and they will fix it. But you are there taking the garbage. So mother finds it easy, throw it to her, she will take it. That will disturb her focus. And then she will go in unfocused way. That's what I say. Fix the things which you cannot fix. Fix the things which you can fix. Accept or ignore the things which you cannot fix. Right? and move on in life. Now, the value. My family crisis, can I fix it? Fix it. If you can't fix it, go focus so much that maybe your family is in your life just to give you this birth. Then you got to figure it out on your own. Because different people have different role based on the karma cycle. So maybe they have just come to you to give this beautiful birth, and once the beautiful birth is given, you go figure out your life. Right? And if you believe in God, great. God becomes my father, God becomes my mother, and go with that energy if you want. Right? So when you start seeing it from that point, you ask me half the question, so I'm only giving half the reply. Right? If you ask me the full question personally, I can further tell you. So that's it. I'm just closing my talk. And thank you all for making it very interesting and asking me questions, because if you didn't ask the question, it would never be interesting. Right? And special thanks to everyone in the CynoDent team. I think they're all busy working out various stuffs, for giving this opportunity, for being of some service to you in some form or the other. I just want to close. I don't know if I closed this last time with the same thing. Every tear which falls out of your eyes is something life trying to teach you. Every tear which falls out of your eyes is something life trying to teach you. If you learn that lesson, the tear will stop. If you don't learn that lesson, the tear will keep coming through different people or the same people, to the different situations or the same situations. It will keep hitting you, telling you, please change. All life was doing you with tears is requesting you, please change. The day you change, the tear will stop. The day you change, the people will change. And when you really change, the whole situation and the whole universe will change for you. Right? And that's what you got to focus on. It is a pleasure talking to you. If you have anyone have a personal question, feel free to meet me personally. I'll be somewhere around, walking around the corner. So make sure you get it. You have a question? Okay, she's already booked me, so I'm going first there. How many want to talk to me personally? Holy, oh God, around 20, 30 people. Okay, I'll stay here until everyone's personal questions are answered, or provided Anmol don't kick me out. She's all busy there. Anmol, don't kick me out of the hall, right? So, is there any presentation more? Yes, so if there's a presentation more, sit, listen to that. Oh, validatory round, okay, that's fine. Okay, so thank you everyone, it's a pleasure. I don't know what it means anyway, so I was just worried if there's a speaker, right? It's a pleasure, guys, thank you, and I hope, you're perfect. Thank you very much. Thank you, right? And see you some other time, whenever time calls, right? Thank you. That's it. My job is done.
Hello. Thank you so much, sir, for this wonderful session. I would like to call upon stage Mr. Rajesh Bagaria, sir, and Dr. Anmol Bagaria, ma'am, and Dr. Ashish Chandra, sir, to please come up on stage. Also, I would like to request Professor Pavitra Rastogi, sir, to please come up on stage and felicitate our speaker of the day. Thank you so much, sir. We'll be starting with the valedictory function shortly. Someone's iPhone is there on the phone. Kindly collect it from here. Somebody's iPhone and power bank is here on the stage. Kindly collect it from the stage. we welcome our chief guest of the valedictory function, Shri Ashutosh Kumar Dwivedi ji, IAS. Please welcome him with a huge round of applause.
A very warm good evening, ladies and gentlemen. I would request all our dignitaries to please grace us on the stage with their presence. A big round of applause. It feels honored to welcome amongst us our guest of honor, Registrar KGMU, Shri Ashutosh Kumar Dwivedi, Sir, IAS Officer. I would like to felicitate him. I again wish you all a very good evening. Ladies and gentlemen, galaxy of intellectuals, Yours Excellency, invited guests, faculty members, and all the participants from different prestigious colleges across India. On behalf of the team CynoDent and Indian Society of Dentistry, I, Dr. Ratika Solanki, your anchor for today's valedictory function, extend a very warm welcome to all of you. I could see a unique and talented mix of delegates who made this happen and who came from every corner to attend this event. My heartfelt gratitude to all. I would now request Dr. Angela to felicitate our dignitaries on the dais. I would request Professor Nandlal Sir, HOD, Periodontology. Professor Pavitra Rastogi, Sir, UP Head President, UP President, Dental Council. Dr. Anmol Bagaria, founder and CEO of CynoDent, founder president, Indian Society of Dentistry. Dr. Ashish Chandra, co-director of CynoDent, vice president, Indian Society of Dentistry. Professor Nandlal Sir, HOD, Department of Periodontology. Before beginning of any event, it's our tradition to seek the blessings of Almighty. For the same, I would request Dr. Biyoshi Das to thank God with her singing of song from Saraswati Vanna.
Hello. ईश्वर सत्य है सत्य ही शिव है शिव ही सुंदर है जागो उठ कर देखो जीवन जो जागर है सत्यम शिवम सुंदरम सत्यम शिवम सुंदरम सत्यम शिवम सुंदरम सुंदरम आ सत्यम शिवम सुंदरम शिवं सुन्दरं सुन्दरं सत्यं शिवं सुन्दरं सत्यं शिवं सुन्दरम् रामावध में काशी में शिव कान्हा वृंदावन में दया करो प्रभु देखो इनको दया करो प्रभु देखो इनको घर घर के आंगन में राधा मोहन शरणं सत्यं शिवं सुन्दरं सत्यं शिवं एक सूर्य एक सूर्य है एक गगन है एक ही धरती माता दया करो प्रभु एक बने सब दया करो प्रभु एक बने सब सबका एक से नाता राधा मोहन शरणं सत्यं शिवं सुन्दरं सत्यं शिवं सुन्दरम् ईश्वर सत्य है सत्य ही शिव है शिव ही सुंदर है सत्यं शिवं सुन्दरं सत्यं शिवं सुन्दरम् सत्यं शिवं सुन्दरम् Thank you.
Thank you, Dr. Bhayyashi, for the soulful singing. Now I would request Dr. Ashish Chandra, Organizing Secretary, to kindly say a few words.
Respected dignitaries on the dais, respected Registrar Sir, Dr. Nandlal Sir, Dr. Pavitra Rastogi Sir, Dr. Anmol Bagaria, a very good afternoon everyone. I, Dr. Ashish Chandra Pandey, Organizing Secretary of the conference, greets you all from the depth of my heart. I hope it was an amazing experience for all the dignitaries present over here who took their time from their busy schedule and joined us from all parts of the country and made it a great success. It was a great scientific and cultural extravaganza which the delegates showcased over here. We promise you all to bring more good educational programs in the coming futures. Thank you, Dr. Anmol Bagaria, Dr. Pavitra Rastogi sir, and entire KGMU and the entire CynoDent team for being a constant support and making this conference a great success. Thank you all.
Thank you, Dr. Ashish. Now I would like to request Dr. Pavitra Rastogi, sir, to kindly say a few words.
Thank you, Ritika. Respected Registrar, King George's Medical University, Shri Ashutosh Kumar Dwivedi ji, IAS. I'm thankful to you, sir, for coming on a very short notice. We are really thankful to you, sir. Head of the Department, Periodontology, King George's Medical University, Professor Nandlal, sir. Organizing chairperson of this conference, Dr. Anmol and Dr. Ashish, and all the dignified guests, students, and dear delegates. As we all know that today at this time we are gathered here for this valedictory function. We all know that every mega event concludes with the valedictory function. But I personally believe that this function is not the valedictory. This is the starting or beginning of the new one. So this is the beginning of the next series. Sir, I would like to tell you, जैसा कि हमारे यहाँ आज़ादी का अमृत महोत्सव चल रहा है, 75वां आज़ादी का वर्ष है, तो जो हमारी थीम थी, तो उसमें हम लोगों ने 75 की नोट स्पीकर्स रखे थे. वी फोकस्ड ऑन डिफरेंट टॉपिक्स ऑफ डेंटिस्ट्री. उसकी वजह से 75 की जो थीम है सर उसको मेंटेन किया है और 75 डिफरेंट स्पीकर्स थे. तो एक बार आज़ादी के अमृत महोत्सव पे जोरदार तालियां हो जाएं. हम सब लोग आज़ादी का अमृत महोत्सव मना रहे हैं, तो उसी आज़ादी के अमृत महोत्सव पे ये पूरा कार्यक्रम इसी थीम के उस पे था. और वी फोकस्ड ऑन टू मेनी वर्कशॉप्स ऑल्सो सर फॉर द बडिंग डेंटिस्ट्स. हम लोगों ने बहुत सारी वर्कशॉप्स की हैं सर. हम लोगों ने लेज़र पे की है, इम्प्लांट पे की है, साइकोमोटर स्किल पे की है, फेशियल एस्थेटिक्स पे की है, ट्राइकोलॉजी पे की है, कैसे गम एस्थेटिक्स को, कैसे लिप रिपोजिशनिंग को, कैसे हम बायोप्सी करें, इस सब पे बहुत सारी वर्कशॉप्स की हैं सर. 4 दिन का सर एक मेगा इवेंट था. 16-17 को वर्कशॉप की सर, एंड 18th and 19th को ये पूरा स्पीकर्स के लिस्ट यहाँ चल रही थी. So I am very much thankful to all the team members, all the organizing committee members of the CynoDent, and I am really thankful to all my residents from Department of Periodontology. Please give them a big round of applause. They and both the teams did a lot. From last 1 week, 24/7, they worked hard. So again, I am thankful to all the delegates and all the speakers who come from across the country and give their lectures here. And I am thankful to all who are present here. Thank you so much.
Thank you, sir, for your wonderful words. I would request Dr. Nandlal, sir, HOD Department of Periodontology, to kindly say a few words.
Good afternoon, everyone. Thank you, Registrar Sir, for accepting our invitation to become the chief guest of today's function. Ultimately, it ended at a very happy note, and every function ends at last. It may be a happy ending or other ending. So it was a very happy ending. So I am very thankful to all the delegates who have come all across the country. I am thankful to the speakers who were since 2 days here in the King George's Medical University. It is our tradition as Georgian to welcome all the speakers, delegates, but since last 2 days you are here and you learn a lot of things. You were guest in the Lucknow. So I thank all the organizing team members, especially CynoDent, our residents who have worked very hard, our faculty who led to the success of this conference. So thank you very much.
Thank you so much, sir, for your wonderful words. Now I would request our chief guest for the evening, Registrar KGMU, Shri Ashutosh Kumar Dwivedi, sir, IAS, to kindly say a few words.
आदरणीय नंदलाल सर, पवित्र रस्तोगी सर, आशीष सर, मैडम और सभी उपस्थित आदरणीय जन, सब चीज़ जो ज्ञान विज्ञान के अनुभव के आदान प्रदान और अमृत महोत्सव के कंसेप्ट के क्रम में उसको और आगे बढ़ाने के संकल्प के साथ जो कार्यक्रम यहाँ संपन्न हुआ, उसके लिए सभी को यथायोग साधुवाद। काव्यशास्त्र विनोदेन कालो गच्छति धीमताम। बुद्धिमानों का समय काव्य शास्त्र ज्ञान विज्ञान के आदान प्रदान और उसके अभिवर्धन के समस्त प्रक्रियाओं में लगता है, बीतता है। तो ये काव्य शास्त्र का विनोद ही हम कहेंगे। और व्यये कृते वर्धते एव नित्यम विद्याधनम सर्वधनम प्रधानम। ये सभी धनों का श्रेष्ठतम धन है, और जितना व्यय करेंगे उतना बढ़ेगा। ये विलक्षण धन है, अश्रेष्ठतम धन है। तो अपने अनुभव का, ज्ञान विज्ञान का जो भी विशिष्ट स्वरूप है, उससे एक दूसरे को लाभान्वित करते हुए समस्त समाज को, देश को, मानवता को जो महत्तम हम उपकार, लोक संग्रहार्थ, लोक कल्याणार्थ काम कर सकते हैं, उसी की प्रक्रिया का एक ये बिंदु है। और इसमें ऐसे बिंदुओं को, ऐसे कार्यक्रमों को, ऐसे स्वरूपों को हमेशा प्रोत्साहित किया जाना चाहिए। यहाँ प्रोत्साहित रहा है। 7वीं शताब्दी में एक कवि हुए थे, दंडी, महाकवि दंडी। उन्होंने एक पुस्तक लिखा था काव्यादर्श। उसमें उन्होंने एक लाइन लिखा था, इदम अंधतमः कृत्स्नम जायेत भुवनत्रयम यदि शब्दा होयम ज्योति आसंसारम न दीप्यते। कि सूर्य चंद्र और की उपस्थिति में भी यह संसार कब का घुप अंधेरे में डूब गया होता यदि शब्द और ज्ञान रूपी ज्योति इस जगत को प्रकाशित नहीं की होती। तो ये सारी प्रक्रियाएं वैसे ही जगत को प्रकाशित करने के लिए हैं और उसी के साधन संसाधन हैं। तो इस भांति भी सभी लोग साधुवाद के, प्रशंसा के पात्र हैं और अनुदिन अनुभव ज्ञान में अभिवृद्धि हो और एक दूसरे के लिए सहयोगी भावना के साथ हम सब आगे बढ़ें, इसी कामना के साथ सबको धन्यवाद अपने लेवल पर।
Thank you so much, sir, for enlightening us with your words of wisdom. Now I would request Dr. Anmol Bagaria to deliver her vote of thanks.
Good afternoon, everyone. I, Dr. Anmol Bagaria, the organizing chairperson of the conference, once again welcome you all to the valedictory function of 4th World Dental Sciences and Oral Health Conference. The theme of the conference was bringing the future of dentistry now and beyond. Every ending brings a new beginning, as Sir said. So it's not just an end, but a new beginning. I wish to extend my heartfelt gratitude to those who have made this possible. Firstly, all thanks to God. We are lucky that our conference was on the days of Janmashtami. So we have the blessings of Lord Krishna with us. I wish to extend my heartfelt gratitude to the dignitaries on dais, our Honorable Chief Guest, Shri Ashutosh Trivedi, IAS, Honorable Registrar, King George's Medical University, Lucknow, Head of the Department Periodontology, Professor Dr. Nandlal Sir, Dr. Pavitra Rastogi Sir, Dr. Ashish Chandra. Thank you for giving us your valuable time this evening. I wish to thank all the HOD members, faculty members, and all the delegates present here. I also extend my sincere thanks to the Department of Periodontology, especially Dr. Nandlal Sir, whose guidance have made this entire event a successful one. All the residents, all the JRs, and also all the professors who have guided us and supported us in this event. I would like to thank our dearest Dr. Pavitra Rastogi sir, who is the convener of the conference, who has constantly supported us and guided us. Thank you so much, sir. I wish to thank Dr. Ashish Chandra, the organizing secretary of the conference, for his effort in making this conference a successful one and to be remembered in the history. I would like to thank all the organizing team members, all the organizing committee of CynoDent, Indian Society of Dentistry, Department of Periodontology, and King George's Society of Periodontology, who have worked hard for making this event a grand success. I wish to thank all the speakers who have traveled from all the zones, from north, south, east, west, from their busy schedules and made it here. A big thanks to all the delegates who have also traveled from all the zones, and all the clinicians, academicians who have joined us to enhance their knowledge and skills. And we promised you to get few more things for you in the coming year, in this year, in the coming months. I'm sorry if I have missed any names, but I am highly thankful to one and all. Thank you for trusting us. Thank you for supporting us. Thank you for coming here. Thank you.
Thank you so much, Dr. Anmol. I would request all the dignitaries to kindly felicitate the organizing team of this conference. First is Dr. Yash Sharma. Dr. Ratika Solanki, Dr. Anu Vashisht, Dr. Sarita, Dr. Shivam Bhardwaj, big round of applause, everybody. All the team members of CynoDent and the Department of Periodontology have worked hard to make this event a grand success. Dr. Sarita. Dr. Shivam Bhardwaj. Dr. Sachin. Dr. Sachin. Dr. Anam Siddiqui. Dr. Noman.
Dr. Akansha. Dr. Ria. Dr. Ria, Dr. Prateek, Dr. Palak, Dr. Subhojit, Dr. Ahana, Dr. Rahul, Dr. Pradeep Sharma, Dr. Malika,
Hello. Now we would like to felicitate the postgraduate students, the residents of the Department of Periodontology. First is Dr. Ayan Saxena. Big round of applause, everybody. Dr. Priyanka Gupta. Dr. Manisha Verma. Priyanka Gupta, Manisha Verma, Dr. Shashank Yadav, Dr. Yusra Akhtar, Dr. Mohammad Amir Khan, Dr. Pooja Singh, Dr. Vishakha Gupta, Dr. Hira Ismail, Dr. Hira Ismail, Dr. Amir Khan, Dr. Sakhina Tariq, Dr. Vishakha Gupta, Dr. Pooja Singh, Dr. Hira Ismail. Big round of applause, everybody. Dr. Sakhina Tariq, Dr. Nehil Saran, Next is Dr. Sheetal Sharma. Sheetal Sharma. Dr. Ahad ul Haq. Dr. Masood Kamal. Dr. Masood Kamal. Next is Dr. Prerna Hirkane. Next is Dr. Vikas Jayant. Dr. Disha Dikshit. Dr. Disha Dikshit. From team CynoDent, Dr. Deek Parik Singh was left for the Dr. Deek Parik Singh. Dr. Milushka Pankaj. Dr. Milushka.
I would request Dr. Deek Paik Singh to please come up on the stage. A big round of applause for him, everyone. Dr. Rahul. Dr. Rahul from Team CynoDent. Dr. Rahul Singh. He's not there.
Next are our interns. First is Dr. Akshat Srivastav. Dr. Akshat Srivastav. Interns. Next is Dr. Angela Fatima. Dr. Angela Fatima. Next is Amritanshu. Amritanshu. Dwij Trivedi. Dwij. Angela. Abhilasha Ghosh. Abhilasha Ghosh. These are all the undergraduate students who have helped us. Abhilasha Ghosh. Next is Ayushi Jain. Next is Pushpendra Singh. Pushpendra Singh. Mansi Raj Saran. Mansi Raj Sharan. Next is Yashashvi Singh. Next is Prakhar Mittal. Prakhar Mittal. And Nasiruddin.
The volunteers for the workshop, Shubhangi Dwivedi, Samriddhi Soumya, Shrishti Pandey, Ankita Kamal. Now we have the undergraduate students who have performed in the cultural event in the form of dance. Avantika Singh, Neha Singh, Shivangi Yadav, Khushbu, Mansi Singh, Abhishek, Sejal Arora, and Parul. Next, we have the participants for Rangoli making. Shweta Tomar, Anu Poswal, Smita, Jenny Vori, Shivangi Dubey, Shivangi Yadav, and Nishant Rathi. Now we have the winners for the scientific session. For the category amongst faculty and practitioners, the first prize in paper presentation goes to Dr. Prachi Goel, ma'am. The second prize goes to Dr. Akansha Bhatt, ma'am, and Dr. Sandeep Dubey, sir. Third prize winners are Dr. Mamta Singh ma'am, followed by Dr. Akriti Goyal ma'am and Dr. Somi Fatima ma'am. They are not present. For the PG category, paper presentation, the first prize goes to Dr. Hira and co-authors. The second prize is shared by Dr. Khushbu Arif and Dr. Sumedha Sharma. Second prize, Dr. Khushbu Arif and Dr. Sumedha Sharma. Third prize goes to Dr. Sunny Sikarwar, Dr. Khirod, Dr. Monica, and Dr. Naina. Third prize winners, Dr. Sunny Sikarwar, Dr. Khirod, and Dr. Naina, followed by Dr. Monica. Under UG category for paper presentation, the first prize goes to Jasmine. Anshul. First prize winners Jasmine, Anshul, Jessica, and Meghna Dikshit. The second prize is shared by Sumit Tiwari, Tanishka, Aditi, Khushi, and Nikki. Kindly come up on the stage, please. The third prize winners, Sakshi Gupta, Himani, Chavi Yadav and Priyanka, followed by Rajeshri Singh. Please come up on the stage to collect your certificates.
Next, we have undergraduate poster presentations. The first prize goes to Ashutosh and Vanshi. From slot 1, Ashutosh and Vanshi. This is slot 1, first prize, Ashutosh and Vanshi. Second prize from slot 1 goes to Khushi, Mishra and Nikki. Khushi, Mishra and Nikki. Second prize. The third prize is a tie between two teams, Ayushi and Bhavya, and Amisha and Kirti Rawat. Ayushi and Bhavya, and Amisha and Kirti Rawat. We come to slot 2. First prize is shared by 3 teams, Pushpendra and Yashasvi, Pushpendra and Yashasvi, Angela and Shubhangi, Pushpendra and Yashasvi, Angela and Shubhangi, and Yashasvi and Riya. Pushpendra and Yashasvi, Angela and Shubhangi, Yashasvi and Riya. The second prize for slot 2 goes to Aishwarya and Diksha, followed by Nidhi. Aishwarya and Diksha, followed by Nidhi. The third prize for slot 2 goes to Rachneet and Diksha, Devansh, Riona and Shreya. Rachneet and Diksha, Devansh, Riona and Shreya. First prize in slot 3 goes to Dr. Unnati Rastogi and Dr. Sia Khanna. Unnati Rastogi and Sia Khanna. First prize in slot 3. Big round of applause, everybody. Congratulations to all the winners, Unnati Rastogi and Sia Khanna. Second prize goes to Rishabh Rana and Pragya. Rishabh Rana and Pragya. The first prize in slot 4 goes to Nandita Verma and Akanksha. Nandita Verma and Akanksha, and Shweta and Tanu Walia. Shweta and Tanu Walia, Nandita Verma and Akanksha. The second prize is shared by Bhavya Agrawal and Ayushi Rawat. Bhavya Agrawal and Ayushi Rawat.
I would request Dr. Rahul Singh from the organizing team to kindly come up on the stage. Dr. Rahul Singh. The next award category is for poster presentation in the UG category. For slot 1, the first prize goes to Sadaf. Second prize goes to Parthvi. In slot 2, first prize goes to Garima. Second prize goes to Khushbu. In slot 3, the first prize goes to Sakshi Gupta. Second prize goes to Sakshi. And third prize goes to Ifra. In slot 4, the first prize goes to Ketan and Atharya. The second prize goes to Akansha and Palak. In slot 5, the first prize goes to Malika and Riya. Second prize goes to Akshita and Fatima. The winner for third prize is Ishita. In slot 6, the first prize winners are Astha and Ekta. Second prize, Mayank. Third prize, Vaibhav, Harsh and Riya. And in the runner-up, we have Ritvik and Sachin. In slot 7, the first prize goes to Shivangi and Sabha. Second prize goes to Meghna and Aditi. And the third prize goes to Vani Gupta and Swati Singh. Slot 8, first prize goes to Ishika Singh. Second prize goes to Ashutosh and Ashma. In slot 9, the first prize goes to Manpreet and Simran. Second prize goes to Manvi and Akshay. And the third prize goes to Riya. In slot 10, the first prize goes to Anuja. Second prize goes to Satyam Kashyap. And the third prize goes to Rashmika and Divya. Slot 11, the first prize goes to Parul. Second prize, Anudeep and Akshita. And third prize, Tesunevo. Last, we have the winners for table clinic presentation. The first award is banked by Dental Case on Wheels from the interns of Subharti Dental College, Meerut. And the second prize goes to Sleep Sound or Sound Sleep, again from the interns of Subharti Dental College, Meerut. With this, we come to an end of our award ceremony, and we thank all the dignitaries on the dais for felicitating all the award winners. Thank you all. The winners for the cultural event in the poem recitation goes to Kumar Abhishek. In the solo dance, the award is banked by Manisha, Pahari, Harshita, Shipra, Tanishk and Parthvi. In group dance, the winners are Shivangi, Neha Singh, Mansi Singh. We are taking 5 minutes break, then we'll continue with the award function.
I request everybody to kindly stand up for the national anthem. I request all the participants, organizers, volunteers to kindly stand up for the national anthem. जन गण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मागे गाए तव जय गाता जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे भारत माता की. Thank you so much everybody.